So, right, morning everyone. Welcome to our board meeting that's being held in public. It's lovely to see so many people here today. And I'd just like to start off with a lot of introductions, and I'm having two bites of this particular cherry because I'm going to say a little bit more about folk when I get to my chair's report. But I'm really delighted to welcome new non-executive directors to their first board meeting, which is Paul Harrison. Hi Paul, Helen Taylor, and particularly excited to welcome our associate non-executive director, Tricia Bernard-Hector. You're very welcome, Tricia, to our table. I'd also like to welcome some of our new executive colleagues, and in particular our Chief People Officer, Jeremy Over. Hi. And I should say a sort of a metaphorical welcome, I think, to Gary O'Hare, because it is his first meeting as our interim Chief Operating Officer as well. And now where is she? There she is. I see Talia. I'm so pleased that Talia Langston, who is a former governor with NSFT, is now joining us in a new capacity as the co-chair of our Trust-wide Service User and Carer Council. You're really, really welcome, Talia. And I'd also like to say hello to Eddie Morris, who is the Medical Director for NHS England. Very welcome as well, Eddie, and great that you're here to see what we get up to and keep an eye on us. But yes, you're very welcome. Okay, and in terms of live streaming, we are live streaming today, and if everyone can try to remember to switch their little red button on when they talk, that would be fantastic. And obviously one of the things that we're doing now is meeting in person for our board, but it's really important that those of us that are not able to get here are also able to at least view what's happening during the proceedings. So that's a slightly, I don't suppose it is an innovation for us, but it feels like an innovation for us that we're doing this, which is really great. And I'm really conscious, it's lovely to see a number of our governors here. Thank you very much indeed for being here. And many more, I think, would be here, but unfortunately we've got a clash because a lot of our governors are very active on lots of fronts, and they're at the NHS Provider Governor Conference, which is also taking place today, and they send their apologies. So welcome. Let's do declarations of interest, and we've got those printed in the agenda pack. Has anyone got any amendments or updates to the declarations? No? Could we note those, please, then? Thank you. Thanks very much indeed. Let's move on to the minutes of the previous meeting, which was held on the 3rd of April. First and foremost, I'd like board members to confirm that they're an accurate record of the meeting. No amendments, so we'll approve the minutes as read. Then please, and let's then turn to any matters arising that aren't elsewhere on the agenda, and also the action log. Let's take the action log first, shall we, Ade?
Thank you, Chair. I'll just go through the actions that are listed as either in progress or not complete. So we have the first one that is in progress is item 25.10G, which is around the Learning from Deaths report, and the update we've had so far is that the annual report will be provided at the July meeting, and that will be dealt with jointly by Gary and Anthony. Is there anything you wanted to add, Anthony?
No, thank you, Adi, you've covered that.
Thank you. The next item that is listed as in progress is on the second page of the log, 25.39I, which is around the Integrated Quality and Performance report and the work around crisis and 111 improvement, and an update to be brought to the July board meeting for that, Stuart.
Yeah, that's on track. Yeah, that's on track, Eddie, thanks. We also did bring a report into the Quality and Finance Committee this month as well, just to update the board on that. In progress and on track.
Thank you. And the next one down is, again for you, Stuart, is around a proposal to bring to the Mental Health Legislation Committee a report on mental health legislation metrics, which is scheduled for September. Scheduled for September. And that's in progress.
Thanks, Eddie. That is in progress. Been working with Faisal, developing a list of proposed metrics that we could use, and the team in performance are working through those to see what they can pull together so they can be reported through the IQPR moving forward as well.
Thanks. And finally, again for you, Stuart, on the gender pay gap item, again in progress for us to have data around demographic breakdown in the IQPR.
Again, in progress and will be delivered by December.
Thank you. I wondered if anybody had any questions about those that are listed as complete or any of the other items.
So not just things. Oh look, I failed already. Not just things that are on the action log, but any other matters arising from the minutes of the last meeting. If anyone has anything to raise, that'd be lovely. No, good. Thanks very much indeed for that, Adi, and thanks as well, Stuart. Next, we're moving to the part of the agenda that's a bit why we're all here. And I'm really, really delighted to welcome Debbie and Andrea to our board meeting. We've met before, Debbie, and it's just fantastic that you're here to share your experiences with us, so thank you in advance for that. And obviously we've got Jodie joining us as well. Jodie's sat at the back too, so Jodie, great to see you too. And I'm going to hand over to Kath, who is going to introduce this really important part of our board agenda. Kath.
Thank you so much. We as a board are about to watch Debbie's thought-provoking video testimony, which offers valuable insight into the dual perspective of being both a service user and a carer. She shares part of her journey through mental health care, emphasising the key role that family involvement played in her recovery, and particularly during her most unwell moments. And Debbie reflects on how this positive experience has inspired her to contribute to the development of the Carers Charter, and ensuring that the voices of carers are recognised and supported, both within the care of their families and those that they support, as well as the improvement and transformation within our services. Now, Debbie speaks openly and candidly about the emotional impact of not being listened to, which has resulted in feelings of anger and frustration. These emotions illustrate a wider issue for both service users and carers, and the fundamental need to be heard and listened to. Debbie shared that the occasion described in the video was one of the only appointments that she attended without her husband, but fortunately was able to seek a second opinion through her support network. Debbie's experience supports the update being given today on the progress of the large-scale change programme focused on the service users, carers and families. The example of the Carers Charter also reinforces the programme's commitment to embedding listening, empathy and co-production into service design and delivery. Debbie's story is a reminder that meaningful change starts with listening to those with lived experience, both the service users themselves and their support networks. Thank you.
When I first went in, I didn't want my family involved at all. I was obviously quite poorly and I just didn't want to engage with them or services at that time. My husband would always bring me to the appointments. He would wait outside while I would go in, see the sort of MDT, the whole team. And then there was one day they said, "Oh, would you like your husband to come in, or he can come in partway through," which he then did. And in some ways I felt more comfortable because I knew he was there. I must have been doing some of the things and that I'd needed to do. My medication was obviously starting to work, tips and tricks that I'd had to help me to get on my journey and feel better, obviously working. And then my daughter was on a school holiday. She was also asked did she want to come in because she was a young carer at the time. And I don't think it happened to everybody then. Things have moved on with carers charters, which I'm helping to formulate a new carers charter. My husband and my daughter had carers assessments and they took those up. My daughter as a young carer was referred to young carers, and I think that helped her understand things more for her journey. When I used to go in and see the team, although my family were in there, I felt that I could have asked at any time if I didn't want them in the room. I felt comfortable enough to say, this is private, I don't want them to hear it, and I could have asked for them to leave. So I felt very well supported by the staff. So with the Carers Charter, obviously I've got my own journey as a service user, but also as a parent carer for my child, my daughter. I was asked by Andrea Bland, there was a Carers Charter coming up and did I want to get involved in putting it together, which I took that opportunity. So with the Carers Charter, there's a group of carers looking after all different people, different ages, etc. I think I'm probably the only one that's actually a service user as well, but I felt comfortable when we've had our meetings. We do them online, we've had some in person, but I've been able to say as the charter was getting nearer and nearer, ready to be looked at by the board, there was a couple of things that I said as a service user that I didn't want to see on there. And everybody listened, not just the staff, but the other people involved, the other carers, and those couple of bits were taken out because I was listened to. I did have an experience. I would have been in about 4 years into my treatment and I wasn't listened to, and I disagreed with the consultant. I took what the consultant said, but when I went home and thought about it, it made me very angry and quite cross about things. And I went via my GP, I have a good GP who listens, and said that I disagreed, and they sort of worked behind the scenes, and I had a second opinion, and that person agreed with me, which I felt was a really good outcome. That something that I felt at the time, I was quite brave to speak up and say I didn't feel that I agreed with something. So that was quite a big thing, but I'm glad I was listened to and I was valued. Service users in the services are listened to, but I think often it's family and friends that aren't always listened to. So hopefully with the Carers Week coming up, and we've been working on the Carers Charter, that will see an improvement and things will change, because sometimes family or friends, if you've got friends that are perhaps looking after you, aren't listened to and they're not valued, whereas I think with the Carers Charter they will feel valued.
Gosh, Debbie, well done. What a powerful message, and how thoughtful you've been in the way that you've articulated your experience. I know I'm not alone in wanting to ask millions of questions, but as the chair, I'm not allowed to go first. That's my rule. So I'm going to invite all of my board colleagues to participate. Tricia.
Thank you so much for sharing. That was a very brave thing to do, so well done on that. I suppose I was thinking about, you said it was a really big thing for you to speak up, and so that clearly was how do we encourage other people to do that? Because you've done it and it worked, but how do we encourage other people to do that? And that's what we need to know as a trust.
Probably giving people space and time. I don't know how you can incorporate it to every appointment and things, but even just someone saying, how do you feel about that if you're given a diagnosis? How does that feel? And then that might give someone an opportunity to say, well, actually, I don't feel you listened, or I disagree, or if they agree, that's fine, they can say they agree. So perhaps that for other people.
Can I add something? If that's
100%,
okay.
Andrea, go ahead.
So I think the way that we could do that as a trust is when we first meet with a clinician, we go into treatment, the clinician to actually say to the service user, please feel free to speak up, tell us how you're feeling. We really want to hear what you've got to say. So from the very beginning, they have that relationship where they feel that they can trust that person and they can speak up. So right from the beginning.
Yeah, that's a good idea.
It's not just permission to do it, is it? It's sort of that active encouragement, I think, is what I'm hearing here.
And feeling comfortable. You know, especially when you're really poorly, you're just not able to think about those things. So yeah, feel comfortable.
Yeah, really well put. I've got Linz, Helen, Caroline and Anthony, and amazingly I've got a pen today so I can write down the order. Linz.
Thank you. So thank you, Debbie, for sharing your story. So I wondered, over the period, how else has the care changed? Have you seen any difference in the quality of care you've received between 2012 and today?
I have seen a big difference in that you do actively allow people that use your services. You ask us how we feel. You've got like friends and family tests and things. But I feel the whole, if you like, the culture, it has changed, and there is much, much more listening going on. When I go to appointments, I feel I'm being listened to, and if I have got something to say, if they don't agree with what I've got to say, we'll talk it through, you know, and have like a plan. So it's much more informative, and that you're almost steering your treatment because you're being listened to. And I think the trust has come a long way in that time. I think I was very fortunate at the crisis team, and I just wish everybody could have that same experience. But I think more and more people do have that, and the trust does listen, but you can always listen more.
Yeah, too right, absolutely. Thanks, Linz. Helen.
Thank you. Debbie, thank you very much. I was really interested, as you say, you've got an unusual perspective because you're both a service user and a carer. With Carers Week coming up, I was thinking kind of particularly about that aspect, and one of the challenges is often about carers recognising that they are carers. Have you got any thoughts about what more we could do to help that?
I can't remember whether I said it in the video or not. I think I did, about the carers assessment. Making contact with those people, it might not be family, it could be friends, but whoever's that person's looking after or their carer, they may not see it. In a way, explain, you know, you're becoming their carer, you might be their loved one or their friend, and things like giving out the forms and leaflets at the time, like the carers assessments. It's really important. I think for young carers as well, they don't realise that they're carers. And I think some, you know, if your partner, husband, your wife, you're in it, it's your partnership, but you may not realise you're now becoming their carer. And I think that has to be addressed. So perhaps in meetings and things, make it at the very front of things, at the very first thing, and then you perhaps can help people. Ward visits and things, I think that's, if you're in hospital, that's really important, that the carers are there and accepted first thing, which I hope with the charter it will be.
Yeah, it's really important. We might ask you to say a little bit more about the charter in a bit, Debbie, just to give you a bit of warning on that one. Caroline.
Thank you very much, and Debbie, thank you so much for your story, and agree with you, really, really brave asking for a second opinion, because it's really difficult often to stand up to professional power, really, isn't it? And I wonder if we've done any learning around the listening that you didn't feel from your first experience. I'm particularly interested in the Carers Charter, and it's great to hear there's good experience where your daughter and your husband were involved, but we hear lots of stories where people aren't involved. And one of our programmes that we've also got is Listening into Action Think Family. And I guess it's a question maybe to Andrea, maybe to Jodie, Kath. Are we making sure we're connecting the Think Family work and the Carers Charter? Because I think family is, we're in the second wave now, aren't we, the Listening into Action work, but we're really trying to get, as a minimum, the carers recorded on our electronic patient record so that we make sure we've got a systematic approach to supporting carers. I think we've got a long way to go, but I just want to make sure we're connecting those programmes up. I can see Jodie nodding away.
Kath, would you like to come in, Jodie, or Kath? Either would be fine. Jodie, come on in.
Absolutely. Oh, thank you. I forgot about that. Absolutely, we are. It's really crucial that those that we recognise where programmes like that or projects interface, and that there is connectivity. And we've got some individuals with lived experience that span each of those projects, as well as senior medic and clinician involvement across those, recognising where the relationships are, ensuring that we're looking at national and local guidance, and making sure that we're drawing that into the developments too. So that's that nature of co-production, that's with our clinicians and people with lived experience, people who for whom the on the ground reality of introducing something like that, as well as the people that will receive that when it gets introduced, all come together. Yeah, I would say so.
Okay, that's really reassuring to hear. And just checking, Debbie, did you want to come in on that at all?
I'm really pleased to hear that you're going to have carers on the electronic record so they know who's your contact. I think that's brilliant.
Yes, it is really important. It is that kind of basic starting point, isn't it? Kath?
Yeah, thank you. I was going to pick up on Listening into Action and the Your Data, Your Choices, which is the part of the electronic patient record where carers' details should be documented. There has been some effort, but it's not significant enough. There is still work to be done, and my concern is that if there isn't a consistent documentation of the details of the carers within the clinical record, if a family or carer needs to be contacted, that's a challenge, but B, it reflects that actually we've still got a lot of progress to make in terms of our clinical teams consistently valuing the role of carers. So for me, that's part of the work of the Think Family and Carer LIA, and they escalated that to us, and we discussed that at the trust management team this week. But a long way to go, and it needs wholehearted commitment from across our clinical teams to improve that.
I'm going to be a bit challenging here, I suppose, which, someone looking at this conversation and looking in, and I look to you, Debbie, to support me, I suppose. I mean, it is so basic, surely, isn't it, in any clinical setting, but most importantly in mental health, that we have that information available. It should be the first thing that's going on the record beyond the service user's name. And I honestly, I'm gobsmacked that it's still a problem for organisations like us, and I wonder, are we challenging ourselves enough to sort this at pace? Caroline is going to say yes, isn't she? Well, we're not rehearsing this, no, Debbie, either. But are you gobsmacked, Debbie? I mean, let Debbie come in first. And
I am. I'm absolutely horrified, because when you're really ill and poorly, you're relying on those people to contact. And things like, if you're admitted, I personally feel your discharge planning should start literally on the day you're admitted. Let's work to where you're going to be, at a certain point. If they haven't got those details, how are they going to do that? Things like arranging, she'd like some leave. Well, if they haven't got those details, and I might not have, when I was a bit non-compliant, I might have not given the details over, whereas if they'd have been there when they bring me in, the details would be there. Yeah, I'm a bit horrified.
Spot on. Thank you, Debbie. Thanks for explaining it like that. I'll go Caroline and then I'll come you, Andrea, okay?
Yes, and my understanding, because I've been, I chair the Listening into Action sponsor group, so I've been, Sarah Maxwell is leading this for us, and I've been challenging quite a lot in terms of why can't we have 100% of carers populated. So we have apparently 2 tabs, Jason, don't know where Jason is, on Lorenzo. One is for relative and one is for carer, and there's a different definition for each. So our ambition is to have 90% by the end of our 20-week Listening into Action of the fields populated for relative, but then there's more work to do for carer. So I think we complicate things as well. So I do think there's more work to do, and whether Jason can help in terms of the Lorenzo fields to do that. But yeah, you'd think we definitely have got an ambition, and we've got the Listening into Action halfway event next week, so we'll be hearing where they're up to after the first 10 weeks.
And Debbie, I don't know whether you know about Listening into Action, but I'll just ask Caroline just to explain what that is, because this is this thing that means that we make change happen quick. Are you familiar with it?
Wasn't, no.
Right, Caroline will explain it better than I
quickly.
can.
So it's an approach that we use across the organisation to essentially, either we can make quick wins, so the things we can just get on and do, don't ask for permission, make patient improvements, workforce improvements, or we need to, something's more tricky, so we need 20 weeks. And one of the 20-week programmes is around putting families and carers right at the heart of care. And we're in the second wave, because we did a lot of work in the first wave, first 20 weeks, we're in the second wave. And lots of carers are involved in that.
Thanks for that, Caroline. I've got you, Tricia, but I've got Anthony and Faisal before that. Anthony.
Thank you, Chair. Debbie, lovely to see you again. Thank you for your video. I was struck by the question earlier about speaking up, and I just wonder, in terms of your experience as a service user, do you recall ever being given any advice about access to an independent advocate or not?
I was only offered that, I was given advice on that once, but not at the very beginning, which would have been quite useful. And I didn't think, when I went for my second opinion, I didn't need an advocate at that point. I was quite well enough to be able to speak for myself. But I think that's really useful, and people should see about that, know about it at the beginning. Thank you.
Thanks for that, Anthony. Is there anything you want to come back on that? Is that something that you're leading on or progressing across the trust?
Well, it's something in terms of support to our service users around their experience, you know, especially when somebody's detained under the Act, then they should be routinely offered that advice and support for independent advocacy. So it's something that we're looking at from, you know, the service user experience side of things. But I'll bring an update back to the board, Chair, if that's helpful.
Yeah, I think it would be, and actually, I think it would be really helpful. I'm not sure Jason's writing the script now for, that's not the technical word for what you have to do to change IT systems, is it? But I mean, a quick fix on Lorenzo might be something sensible for us to come back and have a think about. But I can invite you in a bit, Jason, if you'd like to come back on that. Faisal and then Tricia.
Can you hear me okay? Thank you. First of all, thank you so much. There's so many areas that I want to talk about, but I'll pick out 2 or 3. The first one is the bit about making sure that the people who care for us and love us, their details are on the system. And there is a regulatory point around that as well, because when people are detained under the Mental Health Act, there's a whole nearest relative component, and who do we contact? And that's something that we need to get really, really tight on. And I agree with Caroline, we need to do a lot better, and we are now looking at injecting some real pace behind that. It actually links to the point that Anthony and you were just talking about, which is what sort of other support do you get when you're most vulnerable or in a crisis, and the independent mental health advocates or the capacity advocates. And I think we should be coming back to the board and talking about how good or bad that is and what are we doing to improve that. And we can pick that up in the development of our mental health legislation group and mental health legislation committee. We're really working hard to improve that. The point that I wanted to air with you is you said something that really sort of touched a nerve for me, and that's getting a second opinion and how challenging that can be. And it's challenging not just in mental health services, it's actually equally challenging in physical health services. And in the last year or so, you may or may not be aware there's something around Martha's Rule and getting second opinions medically. Often when you're most vulnerable, and the sort of scenario around Martha's Rule was around a case where there was a patient who was suffering sepsis. And I just wanted everyone and yourself to be aware that we're looking at how to implement the principles of Martha's Rule in our mental health organisation and what that means. And just sort of reading between the lines of what you were saying, how difficult it is to get a second opinion when you really need it. So we've got colleagues in the organisation looking at exactly that, and we're going to need your input in sort of how we implement that and how that makes sense for service users and carers. So I just wanted you to be aware that that work's going on as we speak.
Thank you, that will be really useful. Thank you.
Debbie, I should have warned you when we were having a chat that you come here and you are so frank and open and honest, and then we send you away asking you to do even more for us. But don't forget the other big tip I gave you outside, okay? So I'm going to give you the last word on that in terms of, well, you know what it is, don't you? Now, I'm really conscious that I was going to bring you in, Andrea, and I forgot. Sorry. Andrea.
That's okay. So just going back to ways to get those carers and supporters details. So I'd like to think that could just be done in a simple conversation. So I know that when I'm working with somebody new, I try to establish a rapport and build a relationship with them and a connection. And so even if somebody's not forthcoming with those details straight away, if someone's telling you maybe they're going out for a coffee, oh, who did you do that with? And there's creative ways to pull that information, even if you don't get it right in the beginning. And so that's just a thought.
Yeah, it's a really, really good thought as well. Thank you. Glad I remembered to bring you back in, Andrea. Thanks for not being cross with me because I forgot you. Tricia.
I suppose my challenge is to this board. We've known for a good number of years about the Lorenzo and not having carers on it. I've raised it at board as long ago as 5 years. I don't know, some of us will know Jill Curtis, who was a carers lead, was one of her, she still is. It's been one of her bugbears for a number of years, and we've always put it into the too hard to do category. So, I mean, sorry, Jason, so I'd like to see it put in the let's get on and do it category and get some metrics back to this board. I do feel confident with the listening into action approach to it that it may work, but I think as a board we need to challenge ourselves and get those metrics and progress back to this board as soon as we can. So let's do that, but let's hear what Jason and then Stuart are going to explain as well. Jason.
Yeah, thank you. I think there's something about prompting on the system, but there's also something about clinical behaviours, and as Andrea explained, it should be the natural. It should be within our DNA of what we do on a day-to-day basis. And I think the systemic change is an easy fix, and we'll look to see how to do that. And I don't know, I can't give chapter and verse on why that hasn't happened today, but we'll absolutely look at that. And I think also the prompts on advocacy as well is really important, and so we can get that. If we can automate that, but that's only as good as the people that are using the system. So that's one element of it. So if we need a dual approach on this in terms of system and actual behaviour.
Yeah, you're right. There is a meld of both, isn't there? And I think that's what Andrea was saying. But there is, in this day and age of technology, a means of making people do stuff, and that makes me sound like that terrible person out of James Bond, doesn't it? But there is. I mean, you could have a situation where the system doesn't allow you to get to where you really want to get to unless you've actually done that. I mean, it doesn't seem beyond the wit of womankind to do that.
No,
I'm not directing that at you, Jason.
No, I'm not denying that. Absolutely, yeah. And we'll review and make sure that absolutely clinicians are involved in that development.
Okay, thanks. Stuart.
Yeah, thanks, Chair. Just picking up on Jason's point, I think it is literally half the job to put the prompt onto a Lorenzo. I think it's what we do once we recognise there is a carer and the carer has been identified, and ensuring that the clinical staff are taking the time to offer the carer a carer's assessment if required, and also taking an opportunity where they can to speak to the carer away from the cared for. So they might not want to speak about how they're struggling in front of the carer, in front of the cared for themselves. So it's being able to take the time, ensuring they've got the ability to speak to the carer and make sure the carer is feeling supported, and we're able to do that. So I think we just need to make sure that we do that, as well as the prompt on Lorenzo.
Okay, that's really helpful, Stuart. Thank you. MC, and then Linz.
Thank you. Thank you, Debbie, for sharing your story. One of the conversations we had at Mental Health Legislation Committee this month, or May, was around us not really getting enough of the patient experience coming through. So we're seeing lots of data, and we're talking a lot about the legislation, and you would expect that at a legislation committee. But what we were struggling to do is just to translate some of those outcomes into what it was like for our patients as an experience. And I wonder if that might be a useful committee that we could help drive kind of some of the oversight on this side of things, and push, taking Trisha's point that we've been working on it for some time. I'm not sure if that's the natural place for it to sit, but it did tie in nicely with some of the conversations we were having. It might be something we want to consider offline, but it would be good to have oversight of it in one of our committees so that we can make sure we are really pushing it on this time.
Caroline and I just had a muttered conversation, so we don't need to take it offline at all. It goes to Mental Health Legislation Committee and Quality Committee. We can't do this too many times, so let's take that as a resolution and an agreement. That sounds very grand from this conversation. Caroline.
Next steps. So I think we need to oversee this from a board perspective, and I'd suggest, whilst we've heard, haven't we, at the beginning of the agenda about new metrics are being developed for the Mental Health Law Committee, and so I think a lens of patient experience in those new metrics, Stuart, will be really helpful, particularly thinking about people that may be detained, advocacy that relates to that. I think there's a broader issue for all our service users who are or are not detained, and linked in through CAF to the Quality Committee. I think obviously we are, to Trisha's point, taking this seriously, and hence why we've really focused through listening into action. I think we've got a big cultural change still to achieve, and I still think there's more data issues, system issues from Lorenzo, that we could maximise. So I'd suggest that we agree that we're going to bring a report through initially to the Quality Committee while we wait for the new metrics for the Mental Health Law Committee, and update and really track that we are making progress in the way that we have really focused on your data, your choice, and do that through CAF, if that's okay, into the Quality Committee. And for you to decide, CAF, I guess, maybe at the end of the listening into action, so maybe not next Quality Committee, but the one after that, to give assurance of the progress that's been made. And then Stuart makes sure that we've got oversight of that going in the board suite of metrics.
That'd be really helpful. Linz, did you want to come in?
It was just to link that in with the Your Data, Your Choices that you've already done, Caroline. And we've talked about that here at board, because that's been looked at by Audit and Risk Committee and we're still being tracked. So although there has been take-up on Your Data, Your Choices, it has been slow. And last time, I think we said at Audit and Risk Committee, we were pleased it's gone into a listening into action, and hoping that it will get more traction soon.
And Stuart, I think it would be really helpful from our perspective if we could think about some of the issues that come out of the conversations that we have with service users and carers in board, how we can track that through routinely back into board, because, you know, if this is going to go into the next Quality Committee but one and then coming back into board, there's a danger that we lose hold the thread of what the commitments are that we're making in this public forum, and it's really important that we don't do that. So a kind of a follow-up mechanism for us here would be really helpful. You may have some thoughts on that.
Yeah, happy to have a think about how that might work, and obviously it's that sort of ensuring that we've actually followed through with what we said we were going to do, and so we evidence it as well. So I'll pull something together.
Thanks very much. And Debbie, just checking around to see if there's any other colleagues who'd like. You'll come in at the end. So Kath's going to sort of say the thank yous and everything, but obviously a heartfelt thank you from all of us on this board. This is your moment to ask for anything that occurs to you might be helpful moving forward. So over to you.
I know the board have supported, but I'd like continued support with the Carers Charter as that goes out to consultation and things. It's a great charter, and I think for people, carers, service users, it will be able to be used. It's a live living document that will be fantastic. And if Julie Williams and, is it Margaret Piers?
Margaret Tanner.
If they need any more sort of funding, because there's lots that they'll need, like leaflets. As a service user, I hate when someone photocopies things and you can't read it. So if they could have the funding for the leaflets for Carers Charter that they need, I'd be really grateful for that and your support.
Can I add something as well? If that's okay.
Please do, Andrea, and thank you for that, Debbie.
So I know that the work's being done on the Carers Charter, which is fantastic, but I work primarily with children and families and young people, and if we've got a lot of young carers as well, and I know the way that they view things and do things is quite different. It'd be great if we could get something in place for young people, young carers as well, you know, so we've got a little bit of an alternative for them and take into account that their role is quite different in some ways.
Yeah, you're quite right. I think those are very, very sensible and actually very modest requests. On the leaflets issue, Caroline's already said to me that she's going to agree that and that Rebecca will make that happen. So that's really important. And your point, Andrea, will make sure that there is that noted differentiation within the way that we approach involving our carers in all that we do, conscious of young people. Debbie, you'd like to come back in? Come on in.
In the meetings that we have had, my daughter's been on as a carer and as a young carer, and I know that's something that they have taken on board. It's something that I feel assured is going to be looked into and discussed.
And can I just add that I think it's really important with all the materials about the Carers Charter that they're accessible in different ways for everybody. So, you know, is there going to be something available for someone who can't read, someone who's blind, audio versions, easy read versions, so everybody's included?
Yeah, there's lots of nods on that one, Andrea. I think I can say with lots of confidence that I know that Rebecca and team are really, really on that one. So if that isn't the case, then we'll make sure that we correct that as well. So thank you very much indeed for that. I'll make a plea as well on the back of this. I went to the most amazing event about a year ago called Reach for the Skies, which is a special event that we support, putting quite a bit of money into it for a 3-day activities for our young carers, and they have a campfire and climb trees in the most terrifying way, and I was wondering, has anyone done a risk assessment on that? But it was the most amazing event, wasn't it? And Andrea, I know you were there, and we were talking about it outside of here. So I will also, as chair, make a plea that we really demonstrate the value we place in our young carers, and these are carers from across Norfolk and Suffolk, by continuing to support events like that. And that is me taking outrageous license as a chair, but I know Caroline won't mind me doing that. I'm going to hand over to Kath now.
Thank you. Debbie, thank you so much for sharing your story, both in video but also coming in person and contributing to, I think, a very helpful and useful discussion within the board. There are absolutely areas that need to improve. Having a charter is really important, but it needs to be implemented. So we will need to not just get to the completed charter, but it's about how we normalise it within the organisation. It's going to be the critical factor. Otherwise, it will be a nicely printed, not photocopied version of the charter that's available in multiple formats. But if it's not used, that's not acceptable. So we will be looking as a board to take collective responsibility for ensuring the widespread implementation of that charter. So thank you so much for your time and sharing your experiences with us today. Just as a quick reminder, the Carers Charter has been co-designed, co-produced, and next week, which is Carers Week, the charter will be put out for a much wider engagement. So we want as many people as possible to contribute their thoughts and ideas to the charter, so that the group that have led the development of it so far will then come back together, consider all of the feedback, and the aim will be to launch the final charter in July. That's the plan, unless we get 100,000 responses, and we might have to spend a bit more time going through them. But that's the timeframes that we're looking at. But the next steps really will be the implementation, communication and implementation of that charter. And so, again, that's how we take collective board responsibility for ensuring that that happens. So thank you so much, and thank you, Andrea, and thank you, Jodie, for all of the work that you're doing. And it was really good to see you today. Thank you.
Yeah, well done, Kath, and thank you very much indeed to you, and look forward to seeing you on Monday at the forum. And anyone who wants to come along to the forum, we've got a big event there. There'll be lots of organisations that support carers and provide carers with information, and we'll be doing a broader launch of the work we're doing to co-produce the Carers Charter as well. So thank you very much, and you're very welcome to stay for as long as you'd like to, Debbie, Jodie and Andrea. Shall we move on, noting the really important contribution that Deb has made, and noting the actions that we've taken away from that conversation, to the next agenda item, which is the Chair's report, which is me. You've got my report. I hope that you take it as read, but there are some really quite important things for me to talk about today. So I'm going to take maybe a little bit more time than I usually do in terms of my report. We are, and it doesn't need me to remind everyone, working in a period of profound change for the NHS nationally and for our system regionally and within NSFT. But amidst all of that uncertainty, and it's been an opportunity for me to step back in the light of the CQC well-led inspection, I am seeing really clear progress, momentum and an ever-growing sense, particularly amongst our staff, that there are sustained improvements in some places, but not all, for our service users. And I think it's really important to put that on record and to say thank you to all concerned. I'm going to start with some hellos and farewells, and I've slightly jumbled them up. And although she's not here, I do want to place on record appropriately my thanks to Tandy Matabonanzo, who was our Chief Operating Officer, and to reflect on the scale and significance of the contribution that Tandy made to this trust. She started a little bit after I started, and she came into that role, eyes completely wide open, knowing the scale of the challenge that she was taking on. And I think it's really fair to say that through her determination, her leadership, her values and her personal integrity, she's laid the groundwork in shifting this organisation from crisis, which is where we absolutely certainly were at that point in time, into recovery. She's stabilised operations, strengthened clinical leadership, and has really laid the foundation stones with many colleagues in the room to moving towards the new locality model, which I think is going to enable NSFT as an organisation to work for our staff rather than on occasions against them. So I just want to record that Tandy has left with our deepest gratitude and warmest good wishes. And of course, as I've mentioned, Gary O'Hare, who has a long schedule, he emailed me to say, I'm really sorry, Zoe, I've had my holiday in the diary for over a year, and that's completely fine. But that's the only reason why Gary O'Hare, who's our interim Chief Operating Officer, isn't here today. And for many of you, you'll be familiar with Gary because he's taken forward and led our Learning from Deaths work for over, I think, 18 months now. So we're really delighted to welcome Gary, who's a highly experienced leader and a really trusted voice, I think, not just within NSFT, but also across the broader organisation. We're very pleased that he's joined. And of course, it's great to see Jeremy here today. So Jeremy Over is our very brand new first week Chief People Officer, and you're bringing an enormous amount of experience from other NHS roles to us for the past 25 years, although you don't look old enough. Now I'm also... it's your turn, Tricia. Look, she knows it's her coming up. So Tricia Byrne-Hector is our new Associate Non-Executive Director, and this is your first board meeting. And Tricia joined us, I think, almost less than a month ago, and has absolutely hit the ground running. You've been to a number of our committees already, and that's not even put you off, has it? You bring really great insight from a range of different perspectives. We know that you've come from a pharmaceutical background. You worked in the pharmaceutical industry, and you're also sitting on a number of boards in a non-executive capacity across both Norfolk and Suffolk. So it's great to have you here. You're going to decide which of the board committees you're going to join, and I know you'll be making a really big impact in our committees, so thank you very much indeed for joining us. You are most welcome. It's not that people are rushing to NSFT to beat the door down, Eddie, but they literally are. So I'm also really delighted to meet Helen, to introduce Helen. And Helen, it feels like you've been with us for a lifetime, although this is formally your very first board, isn't it? But Helen joined in mid-April. She's taking on all sorts of roles already within our kind of board governance structures. So as well as being Deputy Chair in the Quality Committee, you're also taking on the Chair of the Mental Health Legislation Committee. I'm kind of thinking, if I got that right, because I've not written it down, but yes, you are. And Helen brings great insight from across a range of public sectors. She's a former Director of Adult Social Care, and many of you will know her, and I know Helen because she was chair of ESNEF, which is the East Suffolk and North Essex NHS Foundation Trust, which is effectively the Ipswich and Colchester acute hospitals. So we are incredibly lucky to have you here, Helen, and delighted that you're here. And then last but not least on the welcomes, no, it isn't last but not least, penultimate but not least in the welcomes. And he knows that I'm about to come to him because I can see him looking down, but I'm really delighted that Paul Harrison, again, week one, isn't it, for you, Paul, as our new non-exec director. But you are a very familiar and really trusted person within NSFT. You took the conscious decision when you left your NHS executive role to contribute through becoming a member of our Council of Governors, which was really important. And then most recently you've been our interim lead governor and have done an awful lot within that capacity to ensure that we're transforming our governing body and our governance through that. But you bring great experience in terms of the NHS experience. And again, we've got you lined up for taking over a committee in the future when the unthinkable happens and Tricia Fuller comes to the end of her tenure. Look at her smiling. And last but not least, in terms of welcomes, Melinda Bird. I'm delighted that Melinda, who isn't able to be with us today, has been appointed as our new lead governor. And Melinda is a staff governor. She's a clinician by background, a nurse, a midwife, a perinatal mental health specialist. And she's also now the operational lead for mental health within Great Yarmouth and Waveney. So really, really pleased that Melinda has just joined, and Melinda is having the baton passed on to her from Paul. And then someone who is the most important person probably to making sure that this board runs as efficiently and effectively as it does is Nikki Southgate. Nick is our corporate governance manager, and Nikki has really, in a way that's hard to describe, ensured that we do the right thing in the right way and demonstrating the best possible values. So Nikki, this is your last board meeting before you go on and do really exciting things in your life, and I just want to express a heartfelt thank you to you for all that you've done and contributed. I'm going to say a little bit about one particular thing that's happened in the last 2 months. I'm going to leave all of the CQC to you, Caroline. I was going to talk about it, but if you don't mind picking it up. But I do feel that I need to talk about the impact that the Race Equity Conference, and I know we've got this issue on the agenda today, but I wanted to talk a little bit about the impact that conference had on me personally, and I know on many of us in the room. This was the event that was held in Kesgrave in May, and it was really one of the most profound conferences that I've been to. It was full of honesty, emotion, and truth, and over 2,000 of our frontline staff attended from across the whole of the Trust, and all grades, and many colleagues in the room stood up and spoke with extraordinary bravery about the personal experiences that they've endured for far too long in our Trust of racism, exclusion and harm. And it was almost the long silences that followed that were as profound as the testimony that we heard. There were moments when the room was completely still, and those of you that were there, and I'm hoping we're getting this out to everyone to be able to see that the poem that Glenda Jelly wrote, I'm Afraid, from me to you and from you to me, which was read with real conviction by Paulette Curtin on the day. I thought it was really important on the day to open the conference, followed by Caroline to give a heartfelt apology for the racism that our staff have endured for far too long. And I'll say it again today, that apology was just the beginning. We have to create a culture where no one has to be brave, and that we have to enable all to speak and to be heard, and following the themes we've really heard from Debbie, to be listened to, because we know, don't we, when our staff are treated with fairness and respect, where it's not a fight to do that, where equity is available immediately for all, then that impacts on the quality and the kindness of the care that we're able to give to our service users. So I really just wanted to spend a bit of time sharing back to you that this, I think, is a turning point. We'll say a bit more on the agenda. We can't just sit here and sit on our laurels and say, yeah, we had a great conference. We have to act. There was a call to action at that conference. We've got an action plan that's going to enable us to translate the good intentions and that extraordinary feeling that we shared jointly together in that room into action. And it's my pledge as chair that will be absolutely a key priority for this board, and we'll keep it under spotlight every single board meeting until our colleagues are telling us they're not experiencing racism within NSFT, either from service users, patients, or from their colleagues and line managers. So I just wanted to place that on record. I felt it was really important That's it in terms of my chair's update. Everything else is in there that you've read. Please feel free to ask any questions of me. Jason.
Yeah, thanks, Zoe. And just off the back of the Race Equity Conference, I just wanted to say that as as exec sponsor of the REACH network, which is the Race Equality and Cultural Heritage Network, we've had a subsequent meeting since the conference, and there's been a real feeling of it something's different this time. But absolutely, the point you raised at the very end of what you just said there is we need to take the action, and we need to make sure that we ride on the coattails of the conference and the good feeling that we engendered there. So we haven't by any way finished this journey.
Yeah, thanks, Jason. And you did a lovely job. And I should, just for the record, thank all of the staff who were involved in that conference, both in terms of the organisation, but we had so many voices as well speaking up and giving their experiences of not being treated fairly and equitably within our organisation. It was really, really profound. Hi. Now, this is a board meeting that we hold in public, but questions we can ask them at the end. So I'm going to come to you at the end if that's all right. I'm so sorry, but thank you for being so interested. Any other questions? Faisal.
Thank you. It was not really a question, it was just a reflection following on from the conference, and I know we're going to say more about that, but a number of us are also involved in reverse mentoring at the moment, and some of those themes that we talked about with such openness in the race conference are coming up in those sessions, and the key here is to make sure that we really understand how it feels like on the ground for people. And I think the action plan that we're going to talk to and implement, that's where it needs to take hold. It's made a profound difference in the last few weeks, and it's palpable, and I think that's really positive. Thank you.
Yeah, thanks, Faisal. And it was so important that our executive colleagues were at that conference and played a really active role in that, and in many of the conversations, including the allyship conversation as well as the reverse mentoring conversation. So yeah, I felt very, very proud to be chair of NSFT, however difficult that conference was and how hard it was to hear the reflections back. It nonetheless made me feel proud that we've got this opportunity to really make this change happen. Great. Jeremy.
Thank you, Chair. I just wanted to give the board some assurance around the grip of the detail. Here, as you say, the conference is the start of something, and there were 303 ideas that participants came forward with, which is the basis for the formulation of our Race Equality Action Plan, which will be forthcoming. Yeah, there is a real grip of that detail, and we're working through that presently.
That's great to hear. Thanks, Jeremy, in your first week. Great, lovely. Thank you very much indeed for those reflections. I'm going to pass on to Caroline now for the Chief Executive's report.
Thank you very much. And just concur with the conversation we've been having around race. Very aware that we've also got the race report on the agenda later on, so maybe I won't say any more about that, but just concur it was a moving, emotional and impactful day, and really, really important for us as a board that we ensure we take action and see progress. So it's great to hear your contribution there, Jeremy. Thank you. So again, I'll take my report as read and just highlight some areas that I think are important. Significant change that I think colleagues are probably very aware of that's happening nationally, regionally and locally. I think we were the first ICBs in the country to go ahead with a joint leadership model, so we now have a joint chair and a joint chief exec. Really, really look forward to working with Will and Ed. Got a meeting coming up in the next few days, and we're starting to explore with the ICB blueprint and the changes in functions, what we need to consider as a provider trust and as the only mental health provider trust across the cluster of the 2 ICBs, what role we can play in supporting the new world. And they're very early thoughts and discussions, but ones that we need to come back to, and I suggest build into our board development programme and think some more about how we can support and what opportunities there are, particularly around integrating and transforming clinical pathways, particularly around mental health, learning disability, autism pathways. Also, significant change with our acute sector in Norfolk. We've now moved into a group model with Leslie Dwyer being appointed as the Chief Executive. And again, we look forward to working in partnership across with all our providers across Norfolk and Suffolk. And obviously the footprint will change for us. Well, the setting will change for us because we've been working across 2 ICBs, and now it'll help that we'll have one cluster of ICBs, and one that we very much have been supporting for our 2 ICBs to work together more collaboratively, particularly around mental health pathways. So it's really positive news for us, and we want to do everything we can to support the new world. There's a new performance framework emerging, which is very much draft at the moment. There's been some draft metrics that have been published around the new national oversight framework. It's going to be consulted on during Q1 and will be finalised, our understanding is, by the end of Q1. The new framework introduces 5 categories. I can't think of the right word for that. At the moment there's 4. There's national oversight for 1 to 4, and we anticipate with the draft that we will be put in 3 out of 5, which is positive, and obviously our ambition is to continue to improve and to move out of 3 and into 2 as quickly as we can, but we've got a lot of work to do across our organisation. I will not repeat all the welcomes to everybody because Zoe has done that in detail. I think I would like to just concur with Zoe in terms of thanking Tandy sincerely for the role that she's played in the improvements across the organisation in the last 3 years. And obviously welcome to non-exec colleagues, to Gary and to Jeremy. And also welcome to Dr. Chris Ainsworth, who's joined us as our new professional lead for psychology, allied health professions, and social care, and a really important role that Anthony has created to really strengthen the leadership across those professions. Obviously, a big part of our transformation plans is around strengthening professional and clinical leadership. So Chris has joined us in the last month, and we warmly welcome him. We are, again, as part of our ongoing transformation plans, we have a lot of work to do in building relationships, particularly with primary care, but across all our partners. And I'm really grateful to Faisal for the work that he's leading. I've been supporting, but Faisal very much leading in building those stronger relationships. And we're starting to get some positive feedback around the step change in approach that our GP and primary care colleagues can see. So it's really, really positive. And obviously Stuart is also working closely with primary care, making sure they're a key partner in our future clinical transformation pathways. So it's just good to see that intention is starting to be recognised. It was brilliant to welcome Lady Dannant to visit the Lord Lieutenant, to visit the Rivers Centre. Again, real commitment to support for mental health and mental health wellbeing. It was also yesterday, I know some board colleagues went to the Mental Health Wellbeing Conference that Michael Gurney organised and led in Norfolk. Again, we really, really want to support mental wellbeing and working alongside our partners. So thank you to everybody that has supported that to date. clearly, since we've last met, we, the CQC, they've been in the trust since March. So we are just coming to the conclusion of both our clinical core service visits and our well-led visits. And we are anticipating our report for our clinical service visits will be any time, and another couple of months before we get our well-led inspection. A massive, massive thank you to everybody across the organisation for all the work that has gone in. And most importantly, we don't do work because the CQC are coming. We have been doing the work and lots of work as part of our transformation plan that the CQC obviously recognised. And I think that my headline would be loads of progress has been recognised by the CQC, a lot more to do. But really important that we keep focused on our transformation plan. We'll be talking a little bit more later, a little bit more in the detail later on in the agenda. Really important to just mention the issue around professional registration and the high priority that certainly the executive team and the board are giving to this. We'll hear from Anthony later on through his Safer Staffing report. The continued assurance that we are seeking, and a little bit more discussion around the clinical harm review that's happened on the back of making sure that we've got the right people with the right skills in the right roles. Positive to see our adult community mental health survey that we broadly are in line with other NHS trusts across England. Of course, we have a lot more work to do, and we'd also like to see more people participate in the survey. So that'll be something that Kath will be taking forward as part of her priorities for the next year. Of course, delighted to welcome Talia as part of our Service User and Carer Council, and really looking forward to your role that you will have across the organisation and with the board, and supporting our locality service user and carer councils. Delighted that we've appointed Rethink as a co-production partner to work alongside us, and looking forward through Kath and Talia's leadership to seeing those locality councils being developed. So really, really warm welcome to you. Great to see that our veteran services have been reaccredited. Again, really important. So, and just to make sure that we're going to be talking about it later during the day, our corporate services redesign programme. So obviously phase 1 of our organisational redesign was our clinical services redesign. We've now moved into our 5 localities, and we always said phase 2 was going to be our corporate services redesign. It just happens that that's now become a national priority, but we're well ahead of that. We've had webinars, we're launching the programme as we speak, and a lot of detail that's going on across the executives in redesigning with teams the new world for corporate services, making sure that corporate services are supporting our clinical services, that they're high quality and that they are efficient. So really important for us. Also pleased that we will be hearing later in the agenda from the Freedom to Speak Up Guardian. Really great that the Dear Caroline initiative is continued to be supported well. And people increasingly are speaking up, identifying themselves, which I think is really important. And we're keeping a really, really close focus on making sure that we respond in a timely way. And I guess the 2 final things I would say is we have just launched our new Talk Values Awards, and we are delighted with the response that we've had. I think in the first month's awards, how many did we have for the first month, Rebecca?
Just over 100.
Over 100 people. And we've managed to select 1 overall winner and 5 locality winners, and we'll be doing that on a monthly basis. And lots of people that have put teams forward for the next. And I guess finally, just to say that all of our transformation is focusing on improving care for the service users, carers. Really challenging for us to continue to do that within the financial climate. One that we take seriously, We're really focused on our efficiency, value and improvement programme, and obviously we're just finishing month 1 and we've got a lot more work to do. We're delivering that hand in glove with our transformation programme. Happy to take any comments from anybody. Thank you.
Thanks, Caroline. It's always great to get that summary of everything that's going on, and it is so extensive, isn't it? Julian, did you want to come in?
Yes, thank you so much for such a comprehensive report, Caroline. I was pleased that you highlighted the Supreme Court ruling and the issues around that. And it's great that we responded so quickly and the involvement of the LGBTQ plus staff network in that. I know we're waiting for guidance from NHS England, but are there any issues in the meantime around this part of that? Is there anything that we can do on a transitional basis? Because I know that particularly trans people are really concerned about some of the issues that have arisen from that.
Yeah.
I apologise for not putting my mic on.
Really important area for us, Julian, and a really important question, one that we discussed only yesterday again in our executive team meeting. So we have been working with our LGBTQ staff network, and we have obviously put joint comms out around the response to the Supreme Court ruling. 2 areas that and we're also working obviously with the national picture and waiting for guidance, which we're all waiting for, but we want to assure that with the ruling happening that there are immediate issues that we were covering off. So we wanted to make sure, for example, that our toilet provision across all of our sites had the option of a separate toilet facility, which is something we've already done and been assured around that. We also, Anthony has been working with his colleagues across the nursing network to see what implications there could be for inpatient settings. Ade is leading this overall, and you might want to come in, Ade, to say some more. And Rebecca has been working, and we've been sharing our approach to communications more widely across other trusts as well. So I think we're doing what we possibly can. We're wanting to give the message of support to our transgender, both employees but also people that might use our services. We're still in a bit of a waiting situation for more guidance, I think.
Thank you.
I'm imagining that when we've received that guidance, we've put in place the arrangements we need to put in place. It's gone through our governance. There'll be a report back at some point to this board as well. Adi, did you want to come in?
Only very briefly. Caroline summarised very well what we're doing at the moment. The only other thing I would add is that we know that the Equalities and Human Rights Commission are working on updating their code of practice. We're expecting that to come out in July, and we suspect that at that point NHS England or the HSE will, the Department of Health and Social Care, will update their guidance to correspond with that. So the likelihood is that it's at that point that we'll be able to make some positive changes to our services in line with that. But as Caroline said, we're doing all we can at the moment to make sure that we're both compliant with the law but also sensitive to the needs of all our patients and staff.
Thank you very much. That's really helpful. Tricia and then Linz.
Thanks, Caroline. That's a fantastic report, and actually it's quite a good reflection on where we are. And just noting all the improvements we've made on people metrics, and I was quite happy to see that yours were exactly the same as mine in my report, so that was quite reassuring. I suppose the comment I wanted to make was around the corporate services redesign. If we look at the BAF, the attendance at risk management course is really low. It's as though it's not connected. In my report, I raised the issue yet again, and it's like a broken record, about appraisal and supervision levels in corporate services. Everywhere else they're great, but not in corporate services, kind of linking those corporate services to the front end and understanding what corporate services are there for. So I'm hoping that our corporate redesign will make that happen.
Yeah, I mean, as I said, the 3 priorities are around making sure we've got high quality corporate services, they're reflective and supportive of localities and that we're being efficient. I can't comment on the absolute detail, Tricia, but obviously things like appraisals and supervision are really high priority, and I think we've done overall fairly well, but still more to do. Thank you.
Thanks, Tricia and Caroline. Linz?
Thank you, and thank you for the report, really comprehensive. So my question is around the changes to the ICBs. How is this impacting on our moving to one contract? So has it accelerated or delayed our one contract work, which is so key to a lot of our transformation to ensure we're on a level playing field across both Norfolk and Suffolk?
I mean, accelerated. Can only be that. Linz, really, it's really helpful because obviously we'll be having one integrated ICB management team, and obviously the leadership of the ICB completely committed, both to one contract, but also much stronger provider-led collaboration. I don't know if Stuart wants to. He's been leading on the detail.
Yeah, absolutely accelerated, to be honest with you, Linz. We've got a meeting, I've just been speaking to Ed's team, looking to put a meeting in for the three organisations, the forming of that one organisation as an ICB in August this year, where we can start getting into the conversations about how we really take that forward and get that sorted once and for all. So August is the first day that we'll all be together, and they'll be in their new roles at that point as an exec as well. So a real opportunity for us to talk how we get that all sorted.
And just for the benefit of newer colleagues in the room, one contract isn't some dry sort of legal thing, although I'm a lawyer by background and I like all that stuff. It's really fundamental to us ensuring that we are able to provide the same high level of consistent care to our residents and service users, whether they're in Suffolk and Norfolk. We've had differing commissioning arrangements and starting points, which for a trust that straddles two commissioning bodies has been fraught with difficulties. So it is a tremendous opportunity for us. So thanks for that question, Linz. Kath?
You stole my thunder. I was just going to say that we are still living with the legacy of a significant variation in the type of services, the level of services that we provide, and the investment in order to do so. We talked about this in the last week or so as an executive team, and are looking to scope where that unwarranted variation takes place to inform the work that's happening in the communications with the ICB colleagues. But I see this as a great step change opportunity for us to ensure no matter where you live within Norfolk and Suffolk, we will be working to having equitable services that take into account health inequalities within our population and ensure that we are then able to meet their needs. Thank you.
Yeah, really welcomed. Faisal, and then I'm going to move on. Faisal?
And just to follow on from that, you can feel it where we're looking to change our services. So the sorts of conversations that we're having, particularly in the last 4 to 6 weeks, feel much pacier, much more accelerated, where before people were saying, well, we can't do X, Y, and Z because this is different and that is different. It's a very different type of conversation that we're having when we're looking at our sort of crisis services or our transformation. So you really do feel it on the ground.
Yeah, and just thank you to all executive colleagues around the table who in different fora are standing up and speaking up for mental health, because, you know, if we're not expressing the need to prioritise mental health, it will continue not to have the same level of standing as acute health. And I don't make that as a political point; it's a mere fact, and its consequences are felt by our service users. No excuses at all, and NSFT still needs to get an awful lot better, but if we have that equity of arms, if you like, in terms of mental health, that would be tremendously helpful. Great. Caroline, it was a superb report. Thank you very much indeed for everything that went into it. Thank you for explaining it so clearly. Could we formally note both the Chair's report and the CEO's report Lovely, thanks very much. Let's move on now to item 2565, which is the Board Assurance Framework and Risk Update. This is a standing item on the agenda, and we had a longer discussion than I planned to have today on this particular issue, but over to you, Ade.
Thank you, Chair. I'm going to take the paper as read and really like to just focus on three issues within the report and then open it for discussion. The first one is just to share some relatively good news, and I say relatively deliberately, around the appointment of our locality governance leads. Those are representatives of, well, senior members of staff who will be working within each of our localities to really support them around issues around risk and governance, but importantly from my point of view, really helping to bring about some consistency of approach across the localities, but also creating a really good link between what we're doing corporately around those issues and how they're working on the ground. We have had difficulties in the past in appointing to those roles, but the relatively good news is we now have some coverage across all of our localities. They're not all fully staffed at full-time level, but we have some coverage. Some localities are sharing appropriately resources across their geographies. So we now have the ability to start to do that work around consistency of approach and really growing our risk culture across the organisation, which is really a really good good development. The second area I wanted to focus on is actually taking the lead from what Tricia raised around training for corporate colleagues on risk. And I absolutely take the point that, as set out in my paper, the numbers of corporate colleagues who have taken up that training is relatively low compared to the number of people in teams. That training is new. It's been provided by Sarah Preston, our head of risk, and our risk manager, and it's something that we're rolling out sort of on a gradual basis, because obviously it's a small team, and we are responding to demand as it emerges. What we have recognised is that demand is growing. There is more of an interest now, both at locality and corporate level, for that greater knowledge and understanding of risk. And what Sarah will be doing going forward is actually providing that training on a much more of a rolling basis, as well as creating resources that can be shared with the localities and corporate teams to use at times that best suit them. So we're trying to create different approaches to give people the knowledge they need, but I definitely recognise the fact that we need to do more and quicker, and we're doing that as much as we can. The other good news on that front is that there is a desire across the organisation for even more specialised understanding around risk. So people have asked us for training around the BAF and a risk appetite, sort of slightly more esoteric risk areas, which is really good news again, because it shows the interest that people have in being able to manage their risks in the best way possible. So that's really good news as well. And the final point I just wanted to raise was around the BAF itself and the work we're doing the Board Assurance Framework, to move away from abbreviations that not everybody understands. We've created, in response to demand from some of our non-executive colleagues and committees, a new risk around EPRR, which stands for Emergency Preparedness, Resilience and Response. Thank you, Stuart. And that also incorporates a recognition of the greater cyber risk that we and all other NHS organisations face. So we've incorporated cyber security into that risk as well, just recognising the need for us as an organisation to be ever vigilant in that area. The other area that we're working on in the BAF as well is thinking about how best to reflect the risk around our understanding and use of mental health legislation in the organisation. It's a very key aspect to the work we do in various settings, and it's an area that historically maybe we have areas for development on. So we're just recognising now whether that needs to be a standalone risk in its own right, or it remains something within risk 2.1 around the way we provide good services across the board. So again, it illustrates the fact that that is a very live document. Our BAF is a very live document that we continue to update based on the issues that we face within the organisation, but in the wider sphere in which we work. So I'll stop there and open for discussions. Thank you very much.
Great, that's helpful, very helpful indeed, Ali, and really important that this becomes ingrained in business as usual across the whole of the organisation. I'm going to take issues relating to substantive matters relating to the board assurance framework under the IQPR discussion because it fits more readily there. But are there any issues or questions around the process that we're adopting to approve our approach that any colleagues have? Julian.
Not really relating to that, but the point that Adi mentioned at the end there around cybersecurity, which is on everybody's lips. As Adi said, it's part of a wider risk that's documented way down in the papers. But it's important for us as a board to recognise the changes that are taking place in how the NHS is going about this. So there is a new cyber assessment framework now that was issued at the end of 23, I think it was, which is replacing the old DSPT, Data Security and Protection Toolkit. And so it'll be important for us to assess ourselves against that and to keep really up to date in that area. So it's such a key risk, and it's primary on almost everybody's risk maps. But for us, it's quite well down, and it's buried within a bigger risk of business continuity generally. So we had quite an interesting discussion in committee around that.
So have we got a mechanism then for uplifting that risk, given what you've described, Julian? Have we got a plan for doing that?
I think it's okay where it is, and Jason slightly disagrees with me about the level of priority it's given to it. It's there, it's documented, there's a lot of work going on with it. So it's okay where it is, but it's
interestingly, Jason's desperate to get in, so I wonder if he's now going to demonstrate that disagreement with you, which is absolutely fine. This is a safe space. Go on, Jason.
Well, no, as Julie said, we had a really good discussion. We had this discussion at Exec and Audit and Risk Committee about the cyber risk being an element of business continuity risk. And to list cyber separately as a risk, we see that to be excessive, but it doesn't mean that it has any less priority in terms of the controls we put in place around it. So the EPRR risk is the priority risk we see, and cyber being an element of that EPRR risk. So it's not discounting the threat from cyber and the controls we have in place around it.
I think I understand what you're saying. It's the outcome and the consequence that we're concerned about, and the mitigation all sits together. Okay, Paul, and then Faisal, but I'd like to move on because we've got some delicious tea and coffee over there, and your temptation is that we're going to stop for 5 minutes and have that. So hurry up, Paul.
Thanks,
in your first comment to board, and that wasn't directed at you.
Yeah, thank you. Ade, it's great to hear that you're talking about building a risk culture within the organisation. I think that's really critical because that obviously connects very much into enabling staff and others to speak up, and also, if you like, driving improvement. So training obviously is one aspect of that, and also getting these governance leads within localities is another. Are there other things that we're doing to try and embed that in, and accelerate that we know that we're doing at the moment? Thank you.
Yes, I think one of the key things is again, going back to our new structures, is the Risk and Policy Group. So the Risk and Policy Group meets monthly. I chair it, and it's where we have a succession of locality and corporate teams coming to present on their risks and coming to present on both how they're managing their risks, but any difficulties they're experiencing and how we as a central team can support them. And actually, one of the things we're encouraging triumvirates to do in that is actually to allow some of the more junior members of their management teams to come to those meetings, so that not only so that they can present to us and get that support, but also they can hear what's happening in other localities, another opportunity to kind of cross-fertilize ideas across localities about what other localities are doing. So for example, the last meeting we had a really great presentation from Central Norfolk in terms of what they're doing, which was really helpful for colleagues from West Norfolk who were at a slightly earlier stage in their development. So it's a really good opportunity for people to share ideas in a safe space.
And going back to Julian's point, presumably we're ensuring that we're testing, checking and challenging whether we're doing sufficient on all of this through primarily audit and risk and other committees. Can I just check on that? Would you feel that you're being given licence, Julian, to do so?
Yes, there's open discussions going on, not just in committee, but outside committee as well.
Okay, lovely. Thanks very much for that. Faisal, the being quick was being directed at you.
Indeed,
Coffee,
indeed.
I'll
be succinct.
I'm
I just
recovering
wanted
myself.
to say that the risk related to mental health legislation is currently contained within the improving care component, and I won't go into the detail here, but the conversation and the work that we're doing is to look at the options of disentangling that and having a standalone risk, and that's the work that's being done through group, committee and executive.
So that's helpful. So it's a watch this space that may change, but you're doing the work to assess that at the moment. That's really helpful. Thank you for being very quick, Faisal, as well. Any other thoughts, comments from colleagues on the processes that we have in place? It seems to me that we have recognised that we need to up our game on this, and we have a plan in place for doing so. As a board, we have to challenge ourselves. Are we satisfied that the what, the so what and the what next has been covered in that conversation? Everyone happy with that? So could we, on that basis, thank Addy very much indeed for bringing that to us and note that report. Let's have a 5-minute break. We'll come back at 11:40. Maybe a bit of a scrum for the coffee, but first come, first serve. Thank you.
that are in the paper. So out-of-area placements continues to be an issue for the organisation. Today we have 31 patients in out-of-area beds. We have got a huge amount of work going on in that particular area to try and reduce that situation that we're in. One of the things that we've done is we've just conducted a bed census. I think I've talked about it at the board in previous boards that we'll be doing it. It's now completed that. And that is showing that 48% of our patients in our adult acute beds, our PICU beds and in our rehab beds are considered to be inappropriately placed by the clinical teams. Now, when I say inappropriately placed, it just means that they could be managed a lot of the time in a lesser restrictive environment. That could be at home, the support from the crisis team. That could be in a staffed accommodation in the community. But we've got them in the wrong place at the moment, and therefore they are taking up a huge amount of our capacity within the organisation. We have shared that findings and recommendations with the locality groups and had conversations with BDG, and we're pulling together now an action plan based on that paper. So that's one of the things that are happening. We've also got daily huddles happening, chaired by Andy Mack, the Deputy Coup, and they're taking place to try and improve the position, to try and add some rigour and some challenge into conversations about the use of beds across the trust and moving people forward into discharge and getting people who are almost currently not being supported to move out of the beds into the community and getting the right people to have those conversations. So making sure we've got social care involved there as well. We are looking to change the times of those because there were times whereby medics couldn't attend, so we're looking to change the times to ensure that we get medical representation at all of those meetings. And then we're also in the process of developing a dashboard. We are missing in the organisation at the moment a single source of truth on beds, and we haven't got the tools that are needed to allow bed management to be able to say exactly which beds are available across the organisation in terms of leave beds or how many beds are available generally that people can admit to. And then there's a number of other things that we need to do to give people the right level of information, either managers and leaders within locality groups and senior leaders within the organisation to understand where we are in bed position across the organisation. Those are some of the things that were happening to try and reduce our out-of-area placement situation at the moment. I'll move on to very urgent crisis referrals, which is another issue that we have across the organisation. In Norfolk and in Suffolk, there have been some real staffing issues in both teams. Suffolk less so, and that's been sorted now, so they've got a less of a poor position, but Norfolk continues to be an issue, and we're working with the teams to understand how we can sort of support that. Transformation is leading some work to bring consistency to process around crisis services across the organisation, and we are developing a refined clinical model and clarity of expectation for teams that will come with that. There is a new crisis standard operational procedure that's been implemented across the organisation, been agreed and been put in place, but we need to ensure that is absolutely embedded in the trust at the moment. It is just a sort of an SOP that people are looking at. Hopefully we can start to see them working to that now, and there's a clear expectation on crisis teams of what's expected to happen prior to a bed person being admitted to a bed. So things like face-to-face assessments happening prior to an admission being agreed by the crisis team, and also a robust purpose of admission to be completed by the crisis team prior to that admission being agreed. And bed management are now challenging acceptance of admissions coming in if those things haven't been completed. We are expecting to see improvements through the transformation work by November 25, but that requires the development of a new crisis model across the organisation, and that's underway at the moment. And the last thing we're looking at is improving gatekeeping across the organisation. We have an issue at the moment with psychiatric liaison services are able to directly admit into beds as well, and we just need to look at that because a lot of the time those admissions happen and the crisis team look at the patient during the course of the week and actually say we could have managed that patient in home-based treatment. So we're just looking to see whether we can make sure that crisis teams are the only people who can gatekeep into beds. So that's urgent crisis referrals. Pick up another alert that we've picked up through Improving Health, which is NDD, which I know has been there for quite a while.
Abbreviations.
Sorry, neurodevelopment disorder, WAITS. and we do have some work being provided by an external provider, supporting some of the teams with assessments or giving us additional capacity. And we are working with the ICB to develop plans for recovery. We are also waiting for new guidance that's coming out in June and July from NHS England. And we're looking outside of NSFT and outside of our system altogether to see who's managed to crack this or who's doing a lot better than we are on this. And one of the areas we're looking at is Portsmouth. Portsmouth seem to have a solution that's got them into a much improved position around their sort of neurodevelopment width. So that's another area that I just wanted to pick out and bring to people's attention. Around advice for improving health, we have physical health checks, and that's currently running at an 87% actual against a 95% target. This is no longer nationally monitored, but we think it's a really important target, and therefore we are going to monitor through all localities. It's been that actual target's been reviewed through all QP, Quality Performance Group meetings, and we're ensuring that any areas that are concerned, that the locality groups are coming back to us with trajectories for improvement as well. Another one on advice on improving health is the 72-hour follow-up, another one that's clinically important indicator. And while we are performing overall with most teams achieving the standard, we are picking up a few outliers in locality teams through the QPG meetings. I don't know if there's anything else Andy wants to come in with.
Yeah, thanks, Stuart. Just a little bit more narrative, I guess, around some of the out-of-area crisis resolution aspects of the work that you mentioned. So still quite worried about not being able to sustain the improved position around the out of areas at the moment. A lot of the work, obviously, that you've mentioned, Stuart, and that I'll touch on in a minute, is aligned, obviously, with the NHSE 10 high impact actions for mental health discharge, which, if delivered, are expected to hopefully reduce the average length of stay in the acute mental health pathway, improve local bed availability, and reduce the need for the out of area placements. So within that, really, Stuart's touched on the work we've done around the crisis resolution, home treatment team, standard operating policy at the moment, the SOP. We've definitely got more work to do in terms of making sure that our teams are working collaboratively to do everything that they can to make sure that we use the least restrictive environment possible to treat people outside of hospital wherever we can. And clearly some of the scrutiny we're putting around the gatekeeping is showing us that we're not doing enough in that. The new SOP should support that in terms of making sure that every single person coming into hospital has been seen in person by the crisis team. But not just that they're seen as part of that gatekeeping, that we're actually looking very specifically for evidence of increased community mental health team input in terms of what interventions have the community teams delivered and how much of an increased offer in terms of interventions is in place. And also, to Debbie's point earlier today, it's really important that when somebody's coming into hospital, they understand why they're coming into hospital, what's the purpose for that admission, and I think we've got some work to do in that area. And alongside that, having a potential date for discharge identified at the point of coming in, and a lot of the work around the crisis SOP is designed to help support with that. Touched on it there, we've obviously got the current community and crisis pathway transformation work going on, and it's really important to mention the community transformation in this space as well as crisis, because we must look at the whole pathway. We often focus in on the crisis and the out of areas. Actually, I'm pulling some information together that we can provide an update for in the future around actually looking at the level of interventions prior to coming into hospital. So how much increased interventions are people receiving from our community teams, and how well are we working collaboratively across the system with family, with carers, with third sector and other agencies around that. So I'll try and always bring that community piece into this narrative as well. Stuart mentioned the recent bed census. Please say we've got a refreshed multi-agency discharge event. I can remind myself not to use the abbreviations, a MAID event, within the trust. Now, we've talked about these before in the organisation. Really important that what we're trying to do is refresh the way that we work within the MAID events to ensure that there is genuine multi-agency approach to this. So this is being led by ourselves in collaboration with ICB. We are going to include all of our inpatients across Norfolk and Suffolk It will be a 3-day event, starts on the 17th of June, and we're going to have senior system partners in attendance of that. We've got executive support for that, and one of our execs will be opening the event. We would expect to go through all of our inpatients looking at unblocking barriers to discharge and trying to make sure that we can not just unlock some of the potential capacity we have, but also learn moving forwards around what can we do to make sure that we can mitigate against us having those blocks in the future. So I think it will be really interesting for potentially myself, Michelle or Gary, Michelle O'Donnell, who's leading on some of the work around the MAID event for us, to come back and give some detail on the outputs from that. I think just the only other things I would update around that is we have, we've talked about it before, we've now appointed to an operational lead for the flow role, and they start, at the moment it's 30th of June, although I'm trying to get them to just begin a couple of weeks sooner, and we'll be appointing to the clinical director for flow as well. We've initiated a review of the bed management function and discharge facilitation, and those individuals will be really key and central to how that works, and we've got a steering group for that, starts next week. And finally, I'd say just, of course, it's important to note that we are scheduled to open the 5th ward imminently too. But keen to stress, actually, we understand there's a lot to do around flow that isn't going to be solved just by opening those beds. Probably all I would add, Stuart. Yeah.
Okay, great. Let's just pause. There's a lot in there, isn't there? Let's start unpacking that. I've got David and Faisal and Julian.
Thank you. I'm partly assured by what's been said, but I just want to sort of stand back a bit, because I'm pleased Andy's talked about the sort of care pathway. Have we a model care pathway where we look at different interventions across that pathway? Because clearly this report picks up some of the standards and some of the problems in, for example, with the crisis referral seen within 4 hours. But have we got standard operating procedures on a full care pathway? I suppose that's my first question, or is that still, as you're saying, in the process of being developed? But I want to really focus, I think, on the inappropriate out-of-area placements. I mean, just to remind ourselves, we're not talking about necessarily out of counties, out of Suffolk or Norfolk, we're talking about out of trust. And presumably, most of those out of trust goes into the private sector. Okay? So if we then look at, this has been a constant issue for a long time in this trust. I'm dismayed that in fact it seems to be getting worse, 20 rather than, and Stuart's reported 31. In the report, and part of our financial planning, of course, we're looking to get down to 0 by the end of, by October. It's a massive mountain to climb, and I'm pleased that you've got the MAID event. There have been MAID events in the past. It may not be with this intensity. And
David, I'm going to ask you to get to your point, please.
Yeah, okay. My point simply is, I'm not assured at all by the plans in place, which are great, but it can't be in isolation, because this is a whole system. So my point really is about the ICBs and their input, the third sector and the 2 county councils, in terms of collectively owning this issue, because at the end of the day, if we don't collectively solve it through a partnership approach, then in fact we're going to be lumbered with the financial consequences and with the effect that people are in the wrong place, and that number of 48% is really quite staggering.
Yeah, no, I hear what you're saying. I mean, I think we've got to look at it from all angles. Let's not pretend for a minute there's a magic wand, and let's not pretend that our colleagues in social care and other parts of the sector aren't as equally pressed and challenged as us. It seems to me that the way through this is to work together to solve those problems. So I hear what you say about not being assured, David, and clearly it's not working at the moment. The question for us as a board is, what more needs to be done in order to kind of break through this cycle, which has certainly been a cycle since I've been chair, and we've not managed to break through it. What more needs to be done? And the events that you're talking about and the initiatives you're talking about, is that going to be sufficient actually to see our way out of this once and for all?
I can start, and then I don't know if Karen
Go
wants
on,
to come in.
go on, Andy. Since it was your birthday yesterday, we'll let you go first.
Yeah, thank you for the present. So, I was very good. So look, in terms of the MAID event, I think a couple of points. I think David's made a good point in terms of we've done MAID events before. I think, though, we're trying to change the narrative and the context around how we approach this problem. Historically, I think I would argue that the MAID events we've run have been more aligned to what other organisation and the Q sector would call like a long stay discussion, where we're talking about the issues for people who are stuck, and maybe half the problems are internal ones. I think what we're trying to move to is exactly that, where we're looking at the system sort of responsibility around where we have people stuck in our hospitals for a period of time, and the membership of the MAID events needs to be more senior decision makers from all system partners. So this will be representative of social care and third sector, district housing and others, and we can share the details of who comes up. Also on the social care, the local authority, I know Faisal's had recent conversations at an exec level to try and refresh that relationship with local authorities to try and make sure that we can get that absolute buy-in about how we can become allies in some of this space. But I would say that the MAID event is one thing to look at how we can try and unlock some capacity now, but we have to make sure we address the culture around doing everything we can to make sure that we're working collaboratively to affect what happens before hospital. So I think you're absolutely right, and in terms of your query around the standard operating policies through the part, I think we haven't got everything where it needs to be, and that's where we're trying to pick up a lot of the work in the community transformation work to make sure that we do have a better understanding of how we deliver that, and obviously in some of the productivity work we're doing in terms of making sure we increase the amount of time clinicians have to spend clinically facing. But I'll ask other execs to chip in if there's additional bits.
Because it also relates, if I may, to risk, our appetite for risk in the community as well, and there's a report later on that.
I'm sure Caroline's going to say this, but it's all connected. There's a cultural issue in this organisation where I suspect that there's a tendency for teams to want patients to be admitted because there is a risk around them, and the risk no longer sits with them, quite frankly. I think there's process issues and systems issues that are designed to cause teams to compete against one another rather than work together, and it sounds like you're dealing with that. But the point that I've asked numerous times is, are we absolutely convinced that we're clear on the capacity issue? Have we got the right number of staff with the right skills in our communities, in our crisis teams and in our inpatients? Have we got the balance right? How does that compare to other trusts across England and Wales? And if we haven't got the balance right, what are we going to do to change that? Because some of this is within our gift as a mental health trust, some of it isn't. So there's quite a lot there for you to unpack. But Caroline, and then I'm going to go to Faisal, Julian, and then Helen.
Okay, I'll be quick. I mean, there's a lot to say about this issue, isn't there? I think the first and most important from a service user and carer perspective is we need to be careful of the language, because it's not out of area, it's out of trust, your first point. Where people aren't being cared for within our services, they're being cared for in the private sector within Norfolk and Suffolk. So families aren't having to travel miles and miles, which in some areas of the country is the case. Second thing to say is it's a national issue, and it's something that we should keep very firmly on the agenda. You know, it's a big issue around parity of esteem, physical health and mental health. The third issue I'd say is that progress has been made, significant progress has been made, and you know, just after Christmas we were over 40 placements out of area, out of trust. We got them down to just over 20, and now they've gone up 10 to just over 30. But if we accept that 10 of those beds are going to be replaced with our new ward, if in effect we're talking about 17 out of area placements, and it would have been 7 2 months ago. I think there's a big issue still culturally to achieve, and just basics like annual leave during bank holidays, and making sure that we're tracking that really carefully, and we've got the right senior clinical staff in our services. 7 days is really, really important. Big part of this, and it would be really good to bring the report that we've had on the bed census into the board and to have a more thorough, detailed discussion. Because, you know, 48% of people, I mean, every trust will find that there's often 30% maybe that shouldn't be in the beds. And a lot of that is trusts aren't doing enough themselves. And a lot of it is partners aren't managing to provide the support that they need to support. But as Zoe says, the solution is to do this together. Big issues for us around pathway redesign. We've done some great work around our crisis teams, and we've now got a standing operating procedure, which was difficult to get, but we've now agreed that and it's being operationalised. But our clinical transformation programme is absolutely key to resolving sustainably this for the future. And my final point would be on benchmarking. What the benchmarking data tells us is we're not out with the resources, staffing resources that we've got. We should be able to manage the pathways well. So there's opportunity for us and capacity issues that we just need to use better and make sure that our teams are working together in a much more effective way.
I think, Stuart, you just want to come in on that, and then next I'm going to go to Faisal, Julian and Helen, and then we're going to move on to the next area.
Apologies, just on the bed census, because it's something that I've completed in a number of organisations across the country over a number of years. I've never come across an organisation that's less than 40% in terms of patients who are sort of in the wrong place. It's always in the 40s. So we're not an outlier there. And just to be absolutely clear, that's not to say those patients were appropriately placed at that point. It's just it's a point in time review. So it's just to make that clear. I think it's just the context is needed.
Okay, thanks. It sounds like we're attacking this from many, many angles, which is necessary. It'd be good to get from yourself, Andy and Stuart, really a degree of confidence that you have and when we're going to start to see this change taking place, because it seems to me if everything falls into place there should be some rapid turnaround in the figures that we've been seeing to board and obviously through board committee, but we'll come back to that. Faisal?
Thank you, Chair. There's so much in there, and Caroline has really covered half of what I was going to say, so I'm going to say 2 or 3 very brief things. So first of all, David, thank you for saying all of that, because the key here is that if people are in the wrong type of service or the wrong type of bed, it doesn't matter whether they're out of trust or in trust, they can equally be in the wrong place. So not getting fixated on whether they're in or out of the trust, they could equally be in the wrong type of service. And I think that's the key. Your question, your very sensible challenge around, are we following the right quality standards for our services? Have we got the right clinical models? Actually, all those quality standards exist, and they will feature very much as part of our transformation of those services, and the strategic sort of clinical collaboratives that we're going to develop will feed all of that into our transformation work. What's key here is what's in our control. And there's many things that are in our control. We're putting in clinical and operational leadership into the flow work. That's key. The things that we don't feel are in our control, we're influencing them within the system regionally and some nationally as well. So we've got to keep doing that work and make sure that this is high profile. Moving away from that, the point I actually wanted to make at the beginning was absolutely we need to focus on the areas that we need to alert and advise. But can I also just very quickly in 30 seconds mention the areas that are assured? There's some really, really positive metrics, particularly around first episode psychosis and our treatment times and talking therapies and our waiting times. These are consistently way above national performance indicators. I just wanted people to draw their attention to some of the things that we're also doing consistently well in, as well as the things that we're looking to improve.
No, it's quite right, and you know, part of all of our jobs, but probably mine more so, is to make sure that there's balance, because there are positives within this as well. So thank you for that, Faisal. I'm going to hold up any response to questions to the end of this segment, and then I'm going to go to Julian and Helen, and then come back to you, Stuart.
Can I just flag the great thing about the additional analysis by care groups is that it flags a bit of an issue with Central Norfolk, not just on crisis referrals, but on some of the other areas as well. And we did, again, talk about this in committee as well. Central Norfolk is clearly struggling a little bit at the moment. There are clearly operational issues, but we've got to be careful around the structure of the care groups, because it's great that we're imposing or asking for greater accountability from the care groups, but we also need to look at resources in those situations. And I think that's probably an ongoing discussion before we get into too much detail. But we need to recognise that there's an issue there. Thank you.
Yeah, I mean, it jumps off the page, doesn't it, in terms of that, so I'm pleased that that's been raised. Thank you very much for that, Julian. Helen?
Yeah, just wanted to follow on briefly on the conversation on flow. Absolutely concur with it has to be a system approach to this. There will be things within the trust that we can do. My question is really on a system basis, whether we sufficiently engage with housing providers, because there was certainly national reporting just a couple of months ago about for mental health, that being a really significant cause of delay, both supported housing and other housing options.
Great, so Stuart, over to you to field all of those.
Around the housing, that there's something that we're looking at now, Helen. We've just reached out, actually, we've also reached out to MC just to see if she has any links. We can also link it with to have some conversations about what's available out there. And local authorities we're speaking to on a regular basis. Just yesterday I had a conversation with Nick Roper at Suffolk about how we can be more involved in I'm going to their meeting next week to talk about the transformation work, but also to talk about how they can be involved in this work here that we're doing to try and reduce the amount of out-of-area placements we've got and improve our flow across the organisation. And similar conversations happened with Norfolk County Council as well. Sorry, what was the other one? Apologies. Oh, was that it?
Kath wants to come in, but Caroline next.
I just wanted to go back on that, really. I think it's a really important issue, Helen, and I think we're starting to, but we haven't had the history, I don't think, of sustainable partnership working across the pluriad of housing providers. I think we've got to think more strategically about that as well as operationally. So I think it's one for us to think more about and come back to, really.
Thank you. Again, it's on the housing issue, and I had the opportunity as well to speak to MC last week or so about what we can do in partnership with housing providers in relation to providing more intensive support for people who discharge from an inpatient unit into a social housing, where the social housing provider can feel more supported, that there is access to mental health services should there be a problem. So for me, I think there's a historical, from my understanding, historical decommissioning of an intensive support for housing providers for people with challenging mental health disorders. But I do think that's something that we need to do as a board, is to endorse that actually many of the individuals that require housing are subject to significant health inequalities. They're usually homeless, or their housing is no longer suitable, and as a result of that we need to actually do more at system level, but the relationship strategically and at place level or a locality level with the local providers is absolutely fundamental. We need to lead and support that, but be delivered also through our locality director teams. Thank you.
I mean, what's really helpful from the perspective of the board is that there is clearly a lot of activity. There's also a sense of anticipation that at some point all of these different activities that we're undertaking is suddenly going to click into place, and we're going to see that change happen. I suppose my question back to you, Stuart, and executive colleagues, is are we sure we're doing enough in all of those areas of culture, capacity and process to guarantee that that change is going to happen? And are we clear enough at the moment as to when we can expect there to be real tangible difference in the areas of kind of alert that we're talking about now, particularly relating to waits for access to services or services being provided by the wrong people at the wrong time. So are you able to provide a bit of a steer on that, Stuart? I know it's a nasty question and I didn't give it to Andy because it was his birthday yesterday, but I mean, that has to be our challenge back, is like, when are we actually going to see this change happening?
I think it needs to happen, and I think it will happen in the coming weeks and months, to be honest with you. I think, as you said, there's a number of things that are lining up now, and I think over the coming months they'll come into train and we'll start to see that movement and those patients starting to be repatriated back into the organisation, and a reduction and an increase in flow, and we'll see a reduction in out-of-area placements. I just think we need to embed some of those things. I think the SOP for crisis, that's just been rolled out. We're just starting to see that starting to be embedded. We're starting to offer some challenge there. We're offering additional rigour into bed management. Andy's having conversations on a daily basis with the operational leads. And we need a sense of ownership coming back from the locality groups that this is their problem, and they are having to push forward with the recommendations that are coming out of a number of areas. So the bed census comes out with a number of recommendations. We need to get those implemented. I think once all those start to embed in the conversations with the local authorities and pulling in them as well, I think we'll see some real traction and some movement with the numbers out of area.
Okay. So does that mean by the 31st of July, which is our next board meeting, we'll be coming along and saying no? So give us an idea of a realistic time frame, would you? And I think it's our job as a board to consider whether that pace and ambition is sufficient, because we've had this problem for a very long time. But I guess that you're going to say how long's a piece of string. But I think we do need to challenge ourselves to set some trajectories and then measure ourselves against them.
Do you want to come in?
Sorry, Caroline, I got my back to you.
No, it's fine. What I suggest is for the next board meeting, we bring a more detailed plan with what exactly we're doing, because we've talked about it, but in a plan with some credible trajectories, which should, I mean, we're working really towards October with the opening of the new ward. That's our plan, to get down to 15 out of trust placements. I think it's achievable, but I think let's bring a paper that gives more assurance in July, and then let's make sure we're tracking. We are tracking it anyway, aren't we, really closely?
Well, so we're already, I think, to bring a paper on 111 and crisis into July's board. I wonder if we just add to that. So you've got more sort of information in there about what we're doing around out-of-area placements. Just all that lines up.
It's all connected.
It is all connected, isn't it? And then, site liaison as well. I mean, that's all absolutely connected, isn't it? It's how does it all fit together? And if one piece of the jigsaw is solved, does that immediately mean we push the problem somewhere else, or does it mean that we've got the opportunity to solve other parts of that jigsaw? I think just having that clarity in terms of a plan will be really helpful for us, because we pick this up through the IQPR. So can we have a freestanding report on this with a proposal for what further needs to be done, the pace and the scale of our ambition, and a kind of sense for the board as to what our ambition is through the trajectories. And then we'll think about how we bring that repeatedly back to board to check and challenge that that's actually happening. Okay, great. So we're doing ever so well on timing on this this board meeting, but don't worry, we'll come up with a plan over lunch as to what we're going to do. I do think that there's lunch available now. Is that correct? Oh, I know you are. I know, but lunch is out there. So what I'm going to suggest, if everyone's happy, is that we go to 12:30, stop, grab a quick bite to eat, and come back more rapidly than we thought, because I know you've got loads more to tell us about, but I don't want us to miss our lunch either. So let's do that. Let's go through to 12:30 and then stop.
Okay. Thanks, Chair. Can I bring in Lindsay just to provide any comments in a report from the Performance and Finance Committee at this point, please?
Yeah, thank you. So in Performance and Finance Committee this time, we did have a deep dive in the crisis services. We had a case study on this to see what the changes are and when they would come through. And I think it's a good idea that that does come to board.
and the next phase of that has then had more chance to deliver. And we also had information this time on crisis and, no, I've already said that one, the other one, out of areas as well. So again, to look at what's happening around there. So, and we did challenge quite significantly on this and thinking around the other areas of the IQPR, the themes that have come through around things like Central Norfolk. So what we've asked for next time is to actually have a look at that bed census. So that was going to come back in July. And the other area is to look at the productivity work stream, which links our efficiency, value and improvement, or EVI work streams, as well as our performance improvement as well. And we've also asked for a triangulation piece, because when we're looking at all of the different alert areas, some of this is picked up, or much of this is picked up in our transformation work, and also a lot is picked up in our incident management groups as well. So that triangulation to ensure that where we do have alerts, we do have a grip on what's going on. The one thing I would say is there is a fragility around where we are at the moment. So although much has been done, so on our transformation work and in getting those crisis teams with the new SOPs up and running, there is a fragility. Last week we had 42 people waiting for a bed at the end of the week. So we can't account for what will happen out in the community. You never know when a larger crisis will hit. So I think it is important to note that although much has been done, there is still fragility to this, and there's much work to continue.
Thanks very much, Linz. It's that sort of inherent risk, isn't it, with the work that we're seeking to achieve, and the ability to keep our service users as safe and well as possible within our communities, which is still an ambition and certainly not an achievement. Anything else that anyone wants to comment on Linz's kind of added dimension there? Go Linz.
Just to also come back on that, so where people were waiting for a bed, we also had a discussion on how they were being kept safe in the meantime. Sorry, I didn't want to just leave that hanging there.
Yeah.
Yes,
No, that's
thank
great.
you.
Okay, Caroline.
Just on that very issue, Stuart, I think you said earlier that the work that's been done with the broader dashboard now is going to give more visibility to people that are waiting for a bed. Yeah. And I think just making sure that the board have oversight of that going forward will be great.
Yeah, so that will allow us to see who's waiting for a bed. It's also really important for bed management to understand who needs the next bed, who's the next person who should get a bed when it's available. And at this moment, they're having to dig around in information and trying to get an understanding that's difficult for them. The manager we can make it so much simpler for them. So the dashboard should do that. The other thing that I would also say is when you scratch under the surface of the 40 people waiting for beds, when you speak to the clinical teams on the ground, they say, well, some people can wait. They could wait for another fortnight. Actually, it's all right. So you've got to have the conversation with the clinical teams to say who should be on that list for people who are actually waiting for a bed and need a bed today. And that's what we're trying to get down to. That's what we're trying to get the bed management team to work with the clinical teams, so that list that sits in bed management of people waiting for a bed are people who really need a bed and they need it now.
And that's our single version of the truth, is
Absolutely.
it, that we talked about at the beginning, because that seems pretty essential, doesn't it? If we're going to work together rather than be, fighting one another for the, the scarce beds that are available. Okay, Linz, in terms of your report, and I think we're talking about your report that is, I'm just checking the page reference, this is on page 352 of the pack. Is there anything else that you want to cover off in the context of the IQPR discussion here? And if so, let's do that now. If not, can we also note your report as part of this conversation?
We can, and the key alert from my report is that the pace of that transformation programme is so key, and we've already discussed that here today, so I'm happy that that has been covered. Thanks.
Okay, can we, as a committee, can we note the report that Linz has presented on the Performance and Finance Committee's Chair's report, which is agenda number item 2575? Thank you. Stuart, do you want to come back on any further points?
Do you want me to move on to approval, Kat?
No, it's 12:29. I think we're going to stop lunch for lunch. Let's do that. We're due to have 30 minutes break for lunch, but I'm only going to give us 20, I'm afraid. So can we come back at 10 to 1, please? Thank you. because what we're doing is we're feeding in the committee chairs' reports as we go through. So back over to Stuart.
Thanks, Chair. I'll now move on to improving care. I just want to pick sorry, I should have mentioned in the last section, obviously, there was no alerts for either care or culture, so just to make that clear. I'll move on to improving care now, and a couple of advisors I wanted to pick out of improving care, please. One is around care plan compliance. We are showing improvement across all localities with a continual improvement since November 23, and these are where we are still below in certain areas. We are picking up individual conversations through the quality performance group meetings, and also we have a discussion regularly at business development group on a Friday with the locality groups being present there as well. So that's been picked up through there in terms of trajectory for improvement. Another one I wanted to pick out was the percentage of positive responses from friends and family tests. March 25 showed a dip below Commissioner target of 80% to 78%. That's the first time since July 24 we've seen that dip. The dip can be partially attributed to delays in logging the friends and family test, where teams manually collect. So we've had conversations with the teams on the ground to see how they can improve that. And then two localities, Great Yarmouth and Waverley and West Norfolk, did exceed Commissioner target of 80% for positive feedback. And West Norfolk came close to a national provider average of 89%. However, Central Norfolk, East Suffolk and West Suffolk are all receiving positive feedback proportions well below 80% targets. These issues have been picked up through QPGs in trajectories improvement requested. Can I bring in Anthony and Kath for any additional comments on improving care, please?
Thank you, Stuart. I mean, you've covered the items that were under advisory. They are three important tenets, obviously, of improving care. But I think the important thing to say about the IQPR and this section of it is that it's in development. So it's a very limited number of KPIs at present. But my quality team are working with Stuart in performance to develop a wider set of KPIs that will give us a better indication of how we're performing under improving care. So we'll bring those through. Hopefully by the next board meeting we'll have an additional set of KPIs in the IQPR.
That's great, and that's something that we've been looking forward to, isn't it? And it may well be just in terms of managing this agenda, if we've got some new KPIs in there, I guess we won't have trend data analysis, but just a kind of clarity as to what they are, why we've chosen them, and you know how they highlight our priority areas would be really useful. Great.
Thanks, Chair. I would also say, I will bring you in, Catherine, in a second. I will say, it's a month-on-month improving picture with the IQPR. We've had quite a depleted performance team. Those are starting to get people in post now and improve the sort of capability and capacity of that team. I've also got an incoming Director of Performance starting in 2 weeks' time. So excited to get Alan in post, which will also take an improved picture in the IQPR. We'll start to see some improvements on that coming through. Can I bring Kath in for any comments on the improving care section?
Thank you. Specifically regarding the friends and family test update, colleagues on the board will note actually further on in the patient experience report that's on the agenda, there is a more detailed set of information and actions in relation to how we're looking to address this. What I just wanted to say is, I think you've already made reference to it, is a bit of a cumbersome process for the collection. Now we've doubled our friends and family test completions over from 23-24 to 24-25. So we've actually really got to look at the process to make sure it's fit for purpose and gives us timely information that can be used effectively. I've mentioned before, we've had Nikan Talawadi, our Director of Patient Experience, join us from Barts in London. He started at the beginning of April, and he's got a track record of transforming friends and family tests through using good digital techniques in order to get that impact. So my aim is that we will continue to grow the number of responses but improve the response rates in relation to good or very good experiences within our organisation. Thank you.
Thanks, Kath. And now can I ask Helen to come in as Deputy Chair of the Quality Committee to provide any update on the committee?
Okay, thank you. Just if you want me to cover the Quality Committee Chair's report, there weren't any alerts, as Stuart has flagged. I think we had quite an extensive conversation on safer staffing, and that's on the agenda later, but probably particularly to note that it was agreed that there would be an executive-led subgroup which would involve service users to review the harm work that's being undertaken in relation to that. So that was a good discussion and will enable us to take stock of the duty of candour issue, whether there is or isn't a duty of candour issue there. So it was an extensive conversation on that. We had an update on learning from deaths in the committee. Good to see the external review by Niche confirming a high level of confidence in the new mortality system. And our conversation in the committee was about where we go next with that, which we will have a further report at the July meeting, but really talking about how we then use the data in particularly to address early mortality and get into the health inequalities issue, which we know is so real for patients with mental health conditions. And I think that's probably, and we also took a report on prevention of future deaths. There'd been a retrospective review of the notices over a 9-year period, 2013 to 2022. All the actions had been addressed from there, but it's also good to note that in the last period there hadn't been any new prevention of further death notices, and qualitatively some very positive feedback from the coroner on work with the trust. So I think those are the things to highlight particularly. So if you're happy, that then would cover off the report at 14.15. Thanks.
Thank you very much indeed as well, Helen, for stepping in and covering the feedback on the Quality Committee in Roger's absence as well. I'll just pause to see if any colleagues have got any questions of the work of the Quality Committee in those areas that Helen specifically has raised, many of which are being fed through into this agenda, as it is absolutely right. A little bit later on, and under some of Anthony's reports, we'll pick up a number of these points. No, I just want to ask about the Friends and Family test, Kath, if I may. And I understand what you're saying, that to some extent there's a cumbersome process. You might want to take it later on in the agenda, but are we going to kind of rapidly be able to pull this back in, because there was such astonishingly stunning great work done on this, and now we seem to be sort of slipping off where we might want ourselves to be. So is there any assurance you can provide for us on what next?
Yeah, absolutely. So thank you. Yes, there will be. So the diving down at locality level, understanding the variation, and then putting improvement trajectories in place, and also looking at the narrative that people are providing in their response, so we can use that as a basis to understand why that's affecting the experiences of people that are participating in the survey. So what my plan is in amongst all of this is identify those hot spots and then put improvement trajectories in place for that.
And that will continue to get reported in through Quality Committee, and then if that's not having traction, that will get escalated back up to the board. Is that right? Okay. Can we note, colleagues, the Quality Committee report that Helen's presented? Thanks very much. Stuart, over to you.
Thanks, Chair. Moving on to improving culture now, and just pick out a couple of advice in the improving culture section. One being annualised sickness absence, sitting at 5.53 against a 5% target. We continue to aim to decrease this figure over the next 12 months through the AVI programme of work, including proactive management of annual leave usage to support staff wellbeing, and moving from a culture of annual leave expectation to more focused consideration on staff and services, and the need to align with roster and guidance also. We also have ongoing support for leaders to manage long-term cases of absence. The other one I wanted to bring to people's attention was the voluntary leavers not completing 2 years of service. And the percentage of those, 41% against a target of 30, so still remains high. We have a continued focus on this metric in the organisation. Staff leaving are coming from admin and clerical roles and non-registered staff in clinical services. There is work underway to improve retention by introducing a 12-month induction programme in the organisation and career pathways for staff groups also. I don't know if, Jeremy, you want to come in, day 4, and add any comments to that?
Yeah, absolutely. There is actually a bit of a glitch in our scorecard here because we are saying that we're failing the target for annualised sickness absence, but we're passing the target for the 2 components of it, which are long and short term. So we need lower targets for both long and short term, which are the 2 constituent parts of the overall figure. So long term sickness absence makes up about 60% of our total amount of sickness absence, and I think that's where we need to focus, and as the data shows, that's where we're seeing an upwards trend. So I think the evidence shows that's where we need to focus in on. That's where I will direct my efforts in terms of my scrutiny of what's going into our EVI programme. On the 2-year retention stat, I'm okay with the actions that we're taking so far. I'm going to go to next month's session that we have with new starters. So after 3 months, we get new starters together and get some feedback from them. I'm going to do the exec slot next month to get involved in that, which will help with visibility too, and we'll see how that goes.
Excellent, thanks Jeremy. If it's okay, I'll hand over to the Chair, Patricia, of the People and Culture Committee.
Just on that point on 2-year service, I mean, that's been a very long-standing problem. We had, proud to be admin, we ran a programme in career development which got much traction. But, and don't ask me to explain this, but I think the numbers are falling if the percentages aren't falling. Don't tell me, I don't know how that works, but anyway, the numbers are falling marginally as opposed to the percentages not falling. But from the Chair's report, there's only really one alert, which is the one I referred to around corporate services earlier on. And I wouldn't want to lose sight of all of the positive indicators that are coming out from People and Culture, because they're in Caroline's report, they're in my report as well, and they are significant, and they're not kind of flash in the pans, they're embedded improvements. And we also received the initial report on the race matter, which again we've talked about before and is further on the agenda. But the interesting thing was we had our staff story on the agenda from the black community who'd been with us for, well, he'd been with us for over 25 years. Very, very positive about the trust and about, you know, the need for compassion and teamwork. However, in his presentation, he kind of just had very light service the fact that it took him almost 20 years to get promoted, and that seemed to be, that was okay. So I think that really highlighted the issues that were coming out of the race report. Other than that, I don't think there's anything really I need to draw your attention to.
Thanks very much, Tricia. And what's interesting is that we've, as you say, the alert area we've had a conversation about, and then other points that you've just raised there are going to be picked up elsewhere. I think it is really important that you've highlighted the Assure areas where we're doing incredibly well, and there really has been a turnaround, hasn't there? And as you say, the pace and momentum of the changes in terms of reducing vacancy rates, increasing the number of nurses, consultants coming into the trusts is truly impressive. So to be commended, and I think we should note that as part of the board record. So thank you to everyone involved in that. Members of the board happy to note the Chair of People and Culture's report on that basis? Yeah, thanks very much. Stuart, back to you.
Yeah, thanks, Chair. I will make a comment just on the IQPR, just in recognition of the lack of sort of information that's in there around the things we're assured by. So I will make an effort next month to make sure that there's more information in there about all the things that are really happening well in the trust. I don't think we'll focus on them enough. And then I'll pass this section on to Jason, please, to give us an update on improving value.
Thank you. Yeah, so the improving value section, it isn't under the 3A, the Alert Advisor Sure structure at the moment, but we're working with Stuart's team to bring that in line for the next board meeting. So focusing on the month one position, so that's year to date to 30th of April, the revenue position is 600k deficit, which is in line with plan. But this has been achieved by utilising non-recurrent mitigations. We're working with the locality teams and the operational teams to focus on the specific mitigations for the areas of overspend. However, the position has been impacted by the registered general nursing issue, and we're working to evaluate this, and we'll specifically report on this in future months' reports. The efficiency programme specifically was 400k ahead of plan, delivering 1.8 million of savings in month. However, the recurrent delivery is 800k behind plan, and it's expected that this will be recovered later in the year, but it is consistent with the trend that we've seen throughout 24-25, and I'll cover that later in the meeting when we look at the full year 24-25 position. Capital is in line with plan, but I think it should be noted that there's a very small element in the plan for month one, but also that we have been successful in the first stage of bids for some national estates safety capital, capital for reducing out of area placements, and urgent elective care. However, we're still working through the approvals process, and we'll notify board if and when we receive that capital funding. Currently in the pipeline is about £5 million of additional capital, so that's good news if that comes through. In terms of cash forecast, this remains sufficient to cover the Trust's working capital requirements for the next 18 months. We forecast that forwards. However, this does require the delivery of the recurrent efficiency programme to underpin that cash position, and we'll be monitoring that closely together with the impact of the efficiency programme to make sure that we have sufficient cash going forward into the future. They're the key headlines. I'll open it up to questions.
Helen? Thanks, Jason.
Jason, just to pick up your comments on the additional capital that's available, becoming available nationally, is any of that for EPR delivery? Because I note that we have got a funding gap there.
No, it's not. We're still working with the regional and national teams to look at the funding gap in the EPR. So we're pre-full business case submission. So by the time we submit the full business case, we need to have that funding gap closed.
Jason, where are you in terms of confidence? Because obviously we've now got the registered general nurse issue, which could have a longer tail on it than we anticipate. And obviously you're saying we're over-delivering in terms of the EVI programme, at least in month one. How are these factors going to balance and weigh one another out, perhaps?
Yeah, I'd say I was marginal at the moment in terms of we need to deliver our recurrent efficiencies, and we haven't seen the step change to date, but we are working closely to make sure that we it links back to the conversation earlier in terms of the out of area placements as well. It's when we see the change. So there's a lot of work that's happening, but it's when we see that change and when we see the delivery come through.
And is the point that you're talking about is when all the bits come together, there's not just going to be incremental change, there's almost going to be a kind of big bang, is there? Is that what, well, I mean, don't put that in the minutes, but yeah. You know what I mean? There's suddenly going to be, this kind of exponential step change that we're looking for. Is that right? And we'll quote you on that, yes.
There's many things happening. So if we look at the efficiency programme, it's broken down into 8 specific work streams. And we've talked about the majority of them in other discussions here today. Yeah. So productivity, flow, sickness absence, temporary staffing, that type of thing. So when all of those pieces align, we'll start to see the run rate of expenditure reduce.
So when do we as a board need to start becoming alarmed if we're not seeing that in terms of the financial year that we're obviously early into now? When are you going to be saying, right, board, it looked like it was going to be okay, but it really, we're really getting concerned now?
I'm hoping that we don't have to have that conversation.
Good.
But absolutely. We monitor this on a monthly basis. We don't wait till boards. So
No,
we do our financial reporting on a monthly basis. So we're close to this.
So by the 31st of July, are we going to see something as a board that's looking a bit more positive in terms of recurrent savings that we're identifying?
I must admit I haven't got the month 2 position, and it's being worked upon as we speak. So I can't confirm that, but I hope that we're in a favourable position.
Okay, lovely. Yeah. I'm going to go to Linz and then David.
Thank you. I just wanted to bring in one of the discussions that we had at Finance and Performance Committee, which was I felt a good challenge over the financial positions and some of the key drivers that go into this. One of which is people cost. We are a people organisation, and we talked about some of the key controls that we have around that, looking for seeking assurance and evidence of those. And one of those is the quality performance groups, and we now receive a regular paper on how they are not only performing as a group, but also what needs to happen to enhance them as well. So things like get the same information across all of them and the correct data. So something that's happening quite well but does need to be enhanced. And we also dug into, maybe not use dug in, sorry, in the minutes as well, interrogated the EVI as well, or the Efficiency Value Improvement Programme. And that's part of the reason why we've got coming back, hopefully next time, that deep dive on out of area or out of trust, and also productivity. Because one of the things that we spoke about was having that golden thread that will knit together when do we deliver on EVI, when do we deliver on transformation, and when do we see improvement from things like the IMGs, or the incident management groups. Sorry, I keep doing the things as well. How do we knit all of those together so that we know that what delivers and when is on track for giving us those recurrent or non-recurrent savings? So that was part of doing that for next time as well. And if we can bring that back to board as well, that would probably be quite helpful, because that will set us up for the rest of the year as well, with hopefully success, or at least knowledge now of where we're going to have serious crunch points.
I'm sure Jason's going to say yes, but I'm just observing there's quite a theme coming out from the conversations we're having of the need to have some trajectories and forecasts that we can measure ourselves back against routinely. But I think we've all noted that point, and we'll make sure that happens. But Jason?
Yeah, absolutely. We can bring that back. And I suppose within the financial forecast, we're constantly forecasting to the year-end position. So we update our forecast on a monthly basis. So we will continue to do that and notify the board of that. What I did want to say was this position isn't without risk, and we must highlight that there is risk, and we've talked about the nursing issue that is a risk that we didn't have when we put the plan together. We've talked about the out of trust placements. Again, that's a risk that we need to mitigate, and this is a constant balance of managing those risks to try and land the financial position in line with the quality that we need to continue to provide.
Thank you, Jason. I've got you, Helen. I think David's next, and then you, Helen.
I think your challenge, Joe, is right in terms of when we'll see an improvement. One way we could think about that is that if you remember last year, the EVI programme and the structure behind that took a bit of time to gain traction. We're now hopefully gaining traction. So I just wonder if we should have a sort of end of Q1 comparison between recurrent and non-recurrent savings over those two time periods, because obviously we've always been underpinned by non-recurrent savings to get a sort of financial balance. It'd be sort of a quick snapshot at a high level to look at that balance over the two time periods.
Sounds like a really sensible baseline. Jason, would that be doable?
Yeah, absolutely. And we actually talked about this at the EVI board earlier in the week about how we show the split between recurrent and non-recurrent, but also by specific locality. So the reporting is more enhanced, really.
Great, thanks very much, Helen.
I was just going to say that sounds really helpful, because by the next board meeting we'll be looking at the quarter one position, and if it hasn't kind of shifted by then, unless we start to do something at an early stage, we won't be able to turn it around in the year. My question is whether there's any risk to the trust from the system financial position.
I think the short answer is yes, there is, but we need to work closely to try and mitigate that. And sorry to keep saying this, but it goes back to the earlier conversations about our system partners and how, for discharge, for example, if we need system partner involvement, if they're in financial challenge as well, there may be behaviours that we experience that we don't want to be experiencing. But yeah, we need to work closely with our system partners to mitigate that.
Yeah, I suppose I'm particularly conscious that a number of our partners within the system are in significant deficit.
Yeah,
so,
absolutely. And actually, I should have mentioned that as at month one, this system, as in Norfolk and Waveney system, as we form part of that from a financial point of view, it is 2.7 million behind plan just after 1 month. So that's a significant deficit to plan.
I think you're absolutely right to flag it, Helen, because we know that the deficit funding that we've received is predicated on the system coming in on balance, and if we were to not have that deficit funding, and I won't use the word I sometimes use, then that would be putting us at severe jeopardy of being able to provide the services that our service users so need.
Absolutely, and I think it's in relation to the in-year position. I think we guaranteed to get the deficit funding. It's just that we need to deliver our position to receive it. It's the repayable nature of that deficit funding which is really key, and absolutely don't underplay that at all, because it will have an impact going forwards.
Right, well, I think we do need to be doing something proactive as a board on this, because it's unimaginable, isn't it, that we would have to repay that 6.9 million as a consequence of the system not coming in on budget, and it's really going to be penalising mental health, which has been traditionally underfunded anyway. So can we just log that as a significant concern of the board, and then take away maybe an action for Jason as to how we reinforce that message. I know we're doing it repeatedly in the partnership meetings that we're all going into, and I know you're doing it through your finance routes as well, but it is a real risk to us. Caroline.
Yeah, no, really, really important point. And I wonder, because we wrote formally to the ICB under the different leadership, so I wonder if we now, with the new leadership, resend the correspondence that we did around the concern around the system deficit having an impact on our need to repay that.
I think that's colleagues happy with that. I think it was a well argued letter, and we should resend it and remind our new colleagues of the position. Okay, great. Sorry, Jason, back to you.
That was it in terms of if there's no further questions, but I will pass to Linz. I know you probably covered some of it in terms of the chair's report from the Performance and Finance Committee on the finance elements of the committee.
Yeah, thank you. I didn't have anything else to say. I did cover everything before.
Thanks very much, Linz, and I believe, because I'm being advised, that we have noted and approved your chair's report as well, so thank you very much indeed for that. Great. Any further questions of Jason in respect of the improving value part of the IQPR? So, good. Okay. Stuart, anything else in the round on IQPR?
No, I think that's all done.
All right. Well, we can pick it up in the reflections on the meeting, but I feel it's increasingly sensible to try to bring these conversations together and to kind of have that read across and possibly allow even more time than we did today on that. But thank you very much indeed, and formally note the the tabling of the IQPR and all of the comments that have flowed from it. I'm not even going to begin to attempt to summarise that. Let's move on to the improving health part of the agenda now, and the trust strategy large-scale change programme. Caroline.
Thank you. Thank you very much, Chair. Okay, so this is a summary of our overall strategy and progress against our 12 major change programmes, our large-scale change programmes. Just to remind the board, the 25-26 large-scale change programmes have been updated. So we have a new programme around health inequalities. Kath is bringing a strategy to a future board around health inequalities. Really strengthening approach to outcomes in terms of their clinical transformation programme, with a real focus on clinical standards. Broadening the locality restructure programme, making sure that we are focusing on the benefits of the locality restructure, but also, as we've talked already, about the redesign of corporate services. And then finally, broadening out the EPR, electronic patient record programme, into a wider digital programme. You can see the detail of the assessment of progress against each of the 12 change programmes, and I'm not planning to go through them. There's obviously an assurance around delivery and also risk, and an explanation of those, and really happy to take any questions from anybody.
Yeah, once again a theme, isn't it? There's so much going on in the Trust at the moment, but colleagues, any questions of Caroline in terms of the progress of these change programmes that are fundamental to improving our outcomes for our service users? Linz.
Thank you. Just thinking of the EPR, the electronic patient record programme under digital. We mentioned before that the funding has been potentially delayed, or we don't have all of funding as yet. How will that impact on the delivery of our programme and getting the business case prepared, please?
I can see Jason's got his hand up, so I'll...
Thank you.
Thanks, Jason.
So we have received some funding, and that funding is sufficient to run the programme to the period we've got. What we've got is a gap for the recurrent, for the capital funding for the rest of the programme, and that's what we're looking to discuss with NHS England and system partners about closing that funding gap before we submit the full business case.
Do we have timescales for when we might hear back from that?
It's one of those things that's dependent on national funding initiatives. So we've been assured that we will get the funding. However, we verbally, but we need it in writing to enable us to submit. So I think we're intending to submit our full business case in August, September time. So we need that imminently.
Okay. Thank you.
Jason, is the funding predicated and dependent on the business case, or have we been told we are going to get the funding and it's just the quantum that will be defined through the business case?
We're going through a process. So that part of the process is that we need to identify a preferred supplier. We're going through that process at the moment. Once we have identified the preferred supplier, we then have a certainty on the actual cost envelope. Then once we've got the certainty, we can then have the full discussions with the national teams about that funding gap and that funding flow. Because at the moment we're talking about a number that could move.
They're not going to pull the plug at the last minute, though, and we do all of this work, and then they suddenly say, "Well, no, we've changed our mind."
They're aware of the risk to the organisation, so it absolutely we need an electronic patient record. It's fundamental to the running of the organisation. They fully understand that. We're one of two organisations in the east of England who are using Lorenzo, and Lorenzo is being discontinued. So there is absolute awareness. We just haven't got that formal certainty in terms of the funding gap.
Okay, well, do say if there's anything more that we, Caroline and I, ought to be doing in terms of applying a bit of pressure in that regard, because we don't want this work to be nugatory. David and then Julian.
Just a quick one on that last point. I mean, they may approve it, but we may not get the amount of money that we wanted, which is always, I guess, a possibility. Just a comment, really. I really like this approach, sort of program management approach, with this sort of oversight that the chief exec and the execs have got, and it comes together in one place, and it gives us I think a lot of assurance as a board in terms of that kind of management grip and understand the connections between the programmes.
Thanks, David. Yeah, absolutely. I'd echo that. And Julian?
I second David's comments on that, really, but I wanted to just add on EPR. EPR systems are notoriously expensive, and it's also quite difficult to justify the investment on the basis of value as well, and that's where FBC's for business cases get into difficulty around approvals. So there's work to do on this, and I think Jason's right. That this may take a while to get us through this stage of the EPR. The great thing is that there is considerable political pressure to get EPRs installed appropriately, and Lorenzo is a dated system, and we do need to replace it. But I think we've got to accept that there's going to be some difficult months ahead, really, in terms of getting this through, and the full business case will be critical to getting the funding.
Okay. Well, if there's anything more that we need to do to make the point that they can't renege on the verbal assurances that have been provided to us, we absolutely will. Thanks for that. I've got one question on this, Caroline. It links really to the paper further down the agenda, which is us needing to make cost reductions in terms of corporate services. I wonder to the extent to which we've got the corporate capacity to be able to drive such a significant large-scale change programme through, while at the same time seeking to reduce resources within potentially corporate services where we might expect to see some of the support.
Yeah, so I think that's a challenge. It's going to be a challenge for every trust in the country. What's been helpful for us is that, as I said earlier, we'd already planned to have this as our programme. So we've got Lisa Quinn who's supporting this. The new Chief Delivery Officer will have it in their portfolio as well. And we've brought in some additional HR capacity. And we'll talk about it more in the private part of the agenda.
Okay, thanks very much indeed, Caroline. On that basis, can we say thank you to Caroline for bringing this paper to us, and can we note that that paper? Thanks, colleagues. And now we're turning to learning from deaths. I'm going to ask Anthony to present this report.
Thank you, Chair. You'll see that there's two reports under this item, Chair. First being the Q4 report on learning from deaths, and then the second paper is around a review of the prevention of future death reports that we had to attend to. So I'll just take the Q4 report first of all, board are familiar with the sort of nature of this report. It gives us the information from January to March, during which time there were 586 deaths, and that contributed to 2,030 for the 12 months. I think each of those we know is a life that has been lost, and there are family and carers affected by all of that. I think there's a few other points that I'd like to just raise before I then open it up to discussion. In the report, you'll see some of the actions that we've taken to support families and carers, particularly over the past 12 months, the introduction of our family liaison officers to support families, and they've been involved with over 59 cases during that time, and they've got 32 that they're still active with. The flows have become a very valued. We've had very good feedback in terms of those roles, and the flows in this organisation have become recognised within the system as well for the work that they're doing. I think importantly, what's the purpose of all of this work? Well, it's to learn from the deaths that have occurred. And you'll see that we have identified some key themes from learning from deaths. There's 6 that are listed in the report. Each of those we can now track across to either the work that we're doing through listening into action, or through our transformation work in the organisation, or in our Safer Care quality improvement programme. Also in the report, it highlights the importance of working in partnership across the system, and one of the pieces of work that we've done is linking up with the Suffolk safeguarding partnership with Anthony Douglas, and we're doing a joint review of 6 deaths with Anthony and his team, and that links across to one of the risks on our BAF 2.5. The learning also includes where we've carried out structured judgment reviews, and also learning from our leader reviews as well. Some of the areas identified under structured judgment reviews relate to end-of-life care, our actual care planning for end-of-life, our documentation, our systems and our processes to support end-of-life, and that's a piece of work that we're picking up through our physical healthcare lead in the organisation. So they're just some of the points to highlight from the report, but going back to the numbers and the lives, attention's often drawn to the unexpected, unnatural deaths. But Helen quite rightly pointed out in her update earlier about the premature mortality. And if you look at the years of life lost, the years of life lost is probably greater in those areas where we've got unnatural deaths that they're expected, but sorry, I'm getting my confused there. It's the premature deaths where the years of life, if you look at the years of life lost there, it's probably greater than the unnatural expected deaths, unexpected deaths. So that turns to the work that Kath is doing around suicide prevention and the health inequalities work. We need to do some more analysis around those the age groups of those premature, where we've got premature mortality, really understanding the health economics around all of that and the social deprivation factors that are involved. So there's I think there's more that we can do to mine the information that we now get from our Learning from Deaths report to help us in terms of our planning of services and quality improvements. That's the Q4 report. It's the end of the 2024-25 report. So I'll pause there before I just move on to the update on the PFDs.
Thanks very much, Anthony. I'm going to go to Tricia, then Kath.
Thanks very much, Anthony. It's interesting reading this now compared to when we first started. That was all about collecting data and managing numbers and what have you. So the maturity of this reporting has moved on. I just wanted to reflect on the positive practice of where we're now willing to breach confidentiality if it's going to protect others, either from themselves or from other people. And we're all too aware of, a very sad death as a result of us not being able to breach that confidentiality in the past. So I think that, for me, that's a really solid move on to be able to do that and to acknowledge that. Thank you.
Yeah, well said, Tricia. Thank you. Kath?
Yeah, thank you. In relation to the level of information that we have within the Learning from Deaths report regarding years of life lost, it's an absolute fundamental basis that we should be using this information, learning from it, and as a platform for the work that I've already started doing, meeting with our public health colleagues within the 2 counties, meeting the population health teams within the 2 current ICBs, Mark Ewan, who is working with Stuart, is joining, because on the basis of we need to understand our population health needs, be working towards a health equity model, and then using that information to design and transform our services so that they meet the needs of the very different needs of our population across our localities, and also individuals with potential, for example, serious mental illness, or people who have a learning disability or autistic. Sorry, I can't speak. And this information that Anthony's mentioned, there's not many organisations out there that will have that richness of data. And for me, this is one of the real fundamentals of how we can use this to transform better outcomes. Won't have a turnaround with in a 6-month, 12-month. It could take a number of years, but it's how we harness that support and collaboration across our system partners in housing, in social care, in primary care, all sectors of health and care, and the voluntary sector, to actually use this data and make a difference for our population. It's absolutely invaluable.
Thanks very much, Kath. Linz, and then Helen.
Thank you. And my question actually leads on quite nicely from what you just said. So looking at the coroner inquests, the outcomes are predominantly conclusion of suicide and then also drug and alcohol related. So I wondered, what are we doing both as a trust and also with our wider partners to help reduce those health inequalities? So although we may have suicide prevention programs, what else do we have, particularly around drug and alcohol related issues?
Thank you. So there are separately commissioned services for people living with drug and alcohol challenges and addictions, and I don't believe that we have sufficiently engaged with those services and made sure that our service users aren't bounced between the services. Often people are using substances as a way to mask the symptoms of their severe mental health challenges, so coming together is absolutely integral. Part of that will be through the suicide prevention strategy and groups that take place within our systems, but it isn't just all about suicide prevention, it's actually about helping people to live well with their mental illness, be supported with any treatments that they need so that they can avoid the use of substances in order to help mask those treatments. So I think we're at the early point of that collaboration and commitment to working much more together with the other partner organisations.
I've got lots of people that want to come in on this, so I've got Helen next, then Paul, then Jason, and then Stuart.
Just to say I really welcome the work with the Safeguarding Adults Board. As a former chair of the Safeguarding Adults Board, not locally, I think that could be really rich and important for us. Just following on from that conversation about the health inequalities experience, I just wanted to draw a connection with, we were talking earlier about physical health checks and that we need to improve the performance there. But then what we do, as well as just ticking a box that somebody's had their physical health check, whether there are opportunities around the sort of making every contact count models or things like that, that could really start to drive some change.
Thanks, Helen. I'm going to take all the questions and then I'm going to come back to you, Kath, if you could kind of round up your answers all in one. So I'm going to go to Paul next.
Yeah, thank you. It's great to see the learning flow through into our large-scale change programmes. I'm just wondering how we close that learning loop back, though, to ensure that the learning's actually being embedded and delivered. As sometimes once you go into a large-scale change programme, it gets larger, and of course some of the learning can get lost within that comes back to this. So it's just how we're closing that loop, I guess, is my question.
Do you want to pick that up in a mo, Anthony? Yeah, okay, so some will come to you, Kath, some to Anthony. Jason?
Thank you. As we said before, this reporting is light years from where we've been in the past, and the difference is far improved. However, I want to challenge ourselves about the accuracy, or not accuracy, the data input that we've got in some areas, and the area particularly about ethnicity reporting. Our second biggest category is not stated and unknown, and we really need to focus on that to make that a small element of our data. It goes back to the earlier conversations about your data, your choices as well, and how we report what we're seeing and what we're recording within in the EPR system, because that's where you get the richness of the data. That's where we look at can feed into the health inequalities work and really make change.
You're quite right. I can feel another trajectory coming on, but I mean, really, we should not be allowing, you know, these records to go without such a vital part of the information about an individual human being.
And in anticipating the question you're potentially going to ask is we have looked at how we can ensure that there's a prompt on the records to ensure that we do record this information.
Thank you very much. It's like talking to ChatGTP, isn't it? Apparently, I use it all the time. I was told by somebody the other day that you do it for companionship rather than information. I think that says more about me than anyone else. Anyway, it's obviously getting on in the day. Jason, we've just had. Stuart.
Thanks, Chair. I just wanted to sort of assure people, just picking up on Kath's point around understanding our business a lot more and understanding our population health needs for the localities. If you think about when we're developing new community models for services at place, then we really need to understand that population demographics and health needs for that area and build our systems and our processes, but also our teams around that, and they'll look different. And that's why I keep talking about, you know, the need for ensuring we haven't got unwarranted variation, but we will have warranted variation in teams based on population health needs. But we really need to understand it in a lot more detail, and I don't think we're there yet. And then hence the conversation that we're starting to have now with the wider system to say, can we really try and get down at the right level of detail for each of our community areas to understand what their needs are, and that will help us understand what the teams need to look like, the structure of the teams, the skill sets within the teams need to be. You know, how many drug and alcohol workers would we need to manage certain localities, and it'll differ by locality based on that population health needs. So there's work underway to look at that in a lot more detail.
Good, thank you, Stuart. Kath, and then Anthony. So Kath to respond, and then Anthony on the large-scale change point.
Thank you. There's a couple of key points. Firstly, Helen's comment about physical health checks. One of my challenges is we may undertake the physical health check, but what does that result in terms of any actions where we might identify need or ill health? And I know that Dawn Collins, who works for Anthony, is really focusing on physical health needs, but it is really important that we understand not beyond that metric and what that means. Just going to take the opportunity to mention the SMI, serious mental illness health checks that are undertaken for people on an annual basis. This isn't reported, but when you mentioned about making every contact count, Helen, here is a good example of a variation in commissioning approaches. So this is for people every year who are on the serious mental illness register. In East and West Suffolk, this trust is commissioned, and again led by Dawn, to provide those annual health checks for individuals, and they're achieving 87% of annual health checks, which is far in excess of what's happening in Norfolk and Waveney, where we're commissioned to undertake the very first annual health check, and then primary care provides that service thereafter. Norfolk and Waveney are performing at 58%, and the England average is 58.5%. So there is significant variation amongst our population. Commissioning variation is a contributor to that, but actually I would say all of our population deserve to be at the high 80s and higher. So there is still so much more to do. Is noting the data and then acting upon it is the most important. The other
Kath, I'm going to move you on quickly.
Very quickly,
mind, please.
Ethnicity reporting.
Yeah.
I've commissioned a deep dive within my team to understand this. Jason is absolutely right, and if there's anything technically we can do about this, but tackling ethnicity reporting is very much part of our PCREF plan, our Patient and Carer Race Equality Framework Plan, which was approved at board in April. We are working on it already to enhance that, and ethnicity reporting forms a major priority in that area.
Just on your point around the divergence of commissioning around annual health checks for people with serious mental illness, is there something that we could do from Caroline and I's perspective to push that we have a sort of equitable commissioning across Norfolk and Waveney in the same way we do? There's such an opportunity with a single ICB for us to do that.
Absolutely. Well, earlier I mentioned about us pulling together where the variation exists in terms of commissioning of services. This very much sits on that list. I think then it's a case of what we strategically
Can
do
I
with that
make
list.
a suggestion? Can I suggest that Caroline and I invite the chair and the chief exec of the single ICB to a session where we present that data and information to them and the impact that that's having on the long-term health of our service users. Are you happy that we propose to do that? Because I mean, that seems a fairly simple, straightforward offer to Will and Ed, I would have thought. Caroline, are you okay with that?
I think it's help. I'm sure it'd be helpful. I think we need to take it also through the executive team. So the work that we're doing with the workshop that you talked about earlier. But I think it's helpful to then escalate it up as well.
All right. Yeah, I think they're really keen to get out and visit. So it may be something that we link onto a visit if it's a bit premature. Faisal, and then we're going to go to Anthony again.
Yeah, just to say from a health inequalities perspective, that joined up conversation in that meeting that Stuart referred to is key, because there's way more than what we can attend to. So tackling deprivation, focusing on social needs, there's clear evidence that when you do it at a system level, you reduce mortality by up to a third. So I think that's the bigger conversation in that meeting.
Thank you. Absolutely, Faisal. Anthony?
Thank you, Chair. Just to your point or question, Paul, through our patient safety incident response framework, we've kind of re-engineered our systems and processes in terms of how we respond to incidents and events in the organisation. So our new Director of Safer Care, Caroline Sweeney, has been working in collaboration with localities just around taking cases and doing the follow through, looking at the rigour of how actions are carried out, completed, and what's the evidence assurance. And we're also now working with them. It's not started yet. It was just at Trustwide Safety last week. There's going to be each locality will be bringing a report to Trustwide Safety on a rotational basis about how they've embedded the learning from any deaths that they've had in their locality. So, and we've also got the, which was referred to in the report, around our new learning from incidents and events group, which replaces the old learning from deaths action management plan group. So there's some infrastructure there in the system to help us with that now.
Great, thanks very much, Anthony. Do you want to move on to the next part of the...
Thank you. So the second paper there is obviously, it's the review of the 36 prevention of future death notifications that we had during 2013 and 22. Gary, who's been referred to today but is not here, Gary has led this, working with partners in the system, particularly carers and bereaved families, through the Learning from Deaths Action Plan Management Group. All of those prevention of future deaths have been reviewed, the actions reviewed, updates gained. We're now confident about the assurance that has been provided back to coroners. So all of those have been reviewed, taken through the Learning from Deaths Action Plan Management Group, and again there's themes that have been pulled out of it, and you'll see that those themes correlate with what we've got in our Learning from Deaths report as well, give or take one or two issues. But again, we've mapped those themes to our LIA Wave 2 work. Some of it has been picked up in Wave 1. and where they've not been picked up in LIA work, they're probably, well, one of them's in our EVI acronym. Jason, you need to efficient value and improvement is in there, and then anything else sits into our clinical transformation work. So we've done the mapping to make sure that these themes are being picked up through our wider work. So I think they're the key points that I'd just like to highlight from that report.
Thanks. I felt this was a really, really important report, and again, a sign of our maturity as an organisation that we're able to bring this in this form here. Caroline.
Thank you, and thank you again for the work that's been done, and obviously Gary's led this. I think the board need a bit more assurance around the so what. So we've said we've done the mapping, but we can't see that. So I think it would be helpful, Anthony, if we could just, from those themes, say what assurance have we currently got, what more have we got to do, and what work stream is dealing with that. And I guess ideally, how does that triangulate back with the performance report from Stuart's perspective?
And which committee is that that detailed review going to look at? Quality. Okay. Yeah. Okay. That'd be helpful.
Thank you. I haven't.
Anything else on that from colleagues? But thank you for that challenge, Caroline. Great. Well, shall we note in that case, colleagues, both the Learning from Deaths report and the Prevention of Future Deaths review work that's been done so far, and thank Anthony for presenting it to the board. And let's move on now to the Freedom to Speak Up report and annual report. Hello, lovely to see you, Holly. If we could take much of your report as read, if you could pick out 2 or 3 key things for us, please, that would be great, and then we'll have a discussion.
Thank you, Chair, and thank you very much for having me here today. Welcome to those who I haven't met before. So yeah, the report, I'll take it as read. This is a summary of the year and also an outline of the data for the month of March, which is the first full month of data that we've had under the new internal Freedom to Speak Up process. So just the key points I'd want to highlight for everyone really is just within the annual report, obviously we captured the board themes, and I want to kind of extend another thanks to the Garden Service Limited, Dean and Kim, for their support with that transition process, and we've been able to kind of capture the broader learning from their time, and that we've obviously had high levels of staff engagement consistently throughout that period. For March, I wanted to kind of highlight that we've got quite a high level of case numbers, higher than we've ever kind of had before, which does demonstrate staff obviously having confidence in the new internal process, although I don't want to be complacent. It's 1 month of data. A high level of those cases were also relating to the safer staffing issue. So the other key kind of thing to highlight from there is that those were mainly raised in the period between changes being implemented and the date of the first webinar. And since the announcement of the webinars, the number of cases relating to that concern has significantly reduced, and all the cases that were opened in that period have since been closed, with staff, whatever their opinion on the decision being made, feeling that the organisation is providing that response and that communication that they need ongoing. So the other thing to kind of highlight as well is that I've been asked to capture the data by percentage of headcount for each localities. So you see within there is a higher percentage for the central locality. So we're monitoring that ongoing, and that has reduced down in the subsequent months to, although it'd be slightly higher, it is the highest care group by headcount, not quite as high as the number is within the report there. There's a number of kind of hotspots that have been identified, and some fact finding has come forward from that. So yeah, any questions? Otherwise, this kind of gives you a snapshot of the data we'll be capturing moving forward.
Thank you very much, and thank you for enabling such a smooth transition as well. It's lovely to have you here. Holly, let's take questions, please. Julian.
Thanks, Holly. It's a super report. I was really thinking about the number of issues around organisational change and processes and so on. Is there something about our messaging of change and the need to be a nimble and resilient organisation in the face of all the demand changes that are taking place, that we need to take on board here in how, in managing expectations for our staff who are being tossed and turned by all the changes that are taking place, and trying to understand that we are behind them and supporting them as best as we can in the face of all this change. I know there's a lot of work being done on this, but do we need to do more in order to try and just reduce that pressure that we see coming back to us, not just through freedom to speak up, but also in terms of our staff survey as well?
So I think what I identified, most of those cases being raised in that really quite short time period, and then the learning from that is that the feedback from staff was they felt the subsequent webinars was what they were kind of seeking. So it was such a short time period, and this is such a huge kind of scale. I wonder whether this would have been much bigger had there not been such a timely intervention in terms of the communications. 20 staff, when we think of the scale of numbers affected directly and indirectly, it spread across the different areas as well. I feel, and the staff I spoke with felt that subsequently, retrospectively, it had been managed as best as possible, but there's always learning, isn't there? So thank you.
That's great. Thank you.
Thanks. It's good to hear your insight, Holly, because you're clearly in your role very, very close to this. So thanks for that. I'm going to go. I've got lots of people wanting to come in. I've got Tricia, Rebecca, Paul, Jeremy. Anyone else want to come in? Tricia.
Hi Holly, nice to see you again. I mean, clearly we have a bigger debate about this on People and Culture Committee, but one of the things we discussed, and just before I said that, there was some ambivalence about moving to an in-house service yet again, myself included, but so it's really heartening to see that the way you've managed that and how well that's running. But given the issues that have come out of the race report, we don't ever pick up issues on race through this freedom to speak up, and that feels odd, for the want of a better word.
I completely agree, and I think there's a lot more work we need to do to make sure that we're targeting, reaching out to different individuals. I think the fact that Ivrain, who's our second Freedom to Speak Up Guardian, comes from an organisation where she's implemented strategies to support women of colour. She's from BME background herself, and we're doing some work actively with the Reach Network and Inclusion team to try and collaborate on some initiatives, really getting into the LIA projects as well. It's the first stages of change, but this is, very embedded within the organisation, I think some would argue. So there's a lot of work we need to do to win trust, and this is one part of it. But yeah, keen to definitely keep an eye on it as such and make sure. So thank you.
It's great to hear that you're on it. Thank you very much, Holly. I'm going to randomly make up it. I found my list again. Rebecca.
Thank you, Chair. I wanted to ask Holly a question, but if I could just comment on your points that you made, Julian, in terms of supporting staff. I think we've had a bit of a revolution from a communications perspective in terms of being very proactive with our staff. So, for example, we've really listened to the fact that staff and all our colleagues missed the all-staff briefings that we used to have, and we've moved into a cascade leadership briefing, and people felt they really missed out. So we've reintroduced those all-staff briefings again, and executive every month review the content of that agenda, and people are able to ask questions of all the executives and the chief exec through those all-staff briefings, which has been really welcome. And our recent internal comms survey shows that people really appreciate that. But I think importantly, we've introduced webinars around really tricky issues for people. So a good example of that is our safer staffing work around the registered mental health nurse and registered general nurse issues. So we've had regular ongoing webinars about that to reassure people, and physical visits as well. Anthony's been back to places where he knows there are concerns amongst staff to talk to them and see if they feel that we're making the progress we need. But the other point I'd like to highlight is the positivity, and we're trying to very much introduce a celebratory theme, which has been, sadly lacking in this trust through quite a difficult time. So things like the Talk Awards that Caroline highlighted, but also really extensive applications for external awards we're progressing, so people can actually start to celebrate some of the really great work we're doing as a trust. seeing themselves on television, as we've had recently with our female veteran service that we're offering, and also just the ability to see yourself in some of the publications and news stories that we run. So I think that's a really important part of making staff feel supported. So I hope that helps add a bit of colour in response to your question. And very briefly, my question for Holly. Your new Freedom to Speak Up champions, can you explain to us at board about how you're going to be able to work with them all? Because there's going to be upwards of 50, it feels, for your paper. So how, when they're all in place from July, how will you work with them all together so they provide a consistency of response and that you know that what's being said across our all 5 localities is consistent? Thank you, Holly.
Holly, just before you jump in there, because I know you're raring to go, I'm going to take Paul and Jeremy, and then I'll ask you to take all of the responses together, please. Paul.
Yeah, thank you. My question, I think, is really about the fact you highlight in the report that colleagues have tried to raise issues locally and then not being able to get anywhere and then come to the Freedom to Speak Up service. I just wonder what we can do to change that, because it seems to me that if we can get localities hearing and responding to issues locally, then those things will get resolved much quickly and more effectively. So I just wonder about what else we're doing to enable that.
Thank you. And Jeremy?
Yes, thank you. 2 things. Hi, great to meet you. First time. In relation to diversity, curious as to whether we collect demographic information from people who raise a concern, where they do so non-anonymously, because I think that helps us to understand where there may be an over or under-representation of concerns. And secondly, one of the things I would love to do with you is to get under the surface of the staff survey at departmental or team level to understand where we may have some particular pockets of the organisation that need greater support, and we can do that together in partnership.
That sounds good. Thanks, Holly.
Oh, thank you. So just to come back, with regards to the champions, what we've developed is a really brief standardised form which guides the champions to give a tick box as to what the outcome of their conversations locally is, and we as the 2 guardians get alerted to each one of those. So that way we can capture some data, hopefully evidencing conversations are happening locally, and the outcome of those, which is either they're signposted to us as guardians, either they're signposted to support locally, or they're giving advice and left to make that decision themselves. So that's the remit of the champions, and the training, it's a full day. It aligns with the National Guardian Office guidance, is very much around it being an enhancement of the role people are currently doing. It's not designed to be an additional responsibility, case managing. It's very much around providing advice and information for people when they raise that concern, and highlighting bringing that cultural intelligence to the guardians as well. So that's what we'll be capturing there, which leads on to the point that you've raised, I think, with regards to what we can do. The next phase, once this is embedded and the champions are embedded, is looking at training and bringing the 3 levels of training for the guardians, which is speak up, listen up, follow up, into the leadership development programmes that are currently ongoing and wherever it's relevant to people at their different levels. And I think really upskilling leaders to understand their roles and responsibilities in managing concerns. I still do hear of people who have been advised by their leaders to bring concerns to the Guardian. So it's about actually looking at why people are lacking that confidence, those skills, and giving them that. So that's the kind of aim there. And then with regards to what Jeremy's raised, we are starting to collect that demographic data. I think there's more work we need to do to get more of it. And that's some of the work that I've been doing with Ivrain, who started, and bringing some of the ideas she's had about how she's collected that data in her previous organisation. So I'll be very keen to hear about how you perhaps have looked at doing that. So yeah, thank you.
Okay, thanks very much indeed. Just checking, Kath.
I just wanted to end by thanking Holly. It's been a remarkable 2 months since she started in the role as the Guardian, and welcome also formally from the board to Ivrain, who is our additional Guardian that you have mentioned, Holly. Holly works directly to me, and the only thing I wanted to add is we're looking into ways of doing fact-finding where there are some themes and issues that are happening, clusters of issues being raised. So we're working on that as an executive team and a trust management team in order to support Holly and, of course, the people who've raised those concerns.
I'm really, really pleased to hear that, Kath. I mean, I was going to reflect back. You know, you're so full of energy, Holly, and you know, you really bring that kind of whole approach that's going to encourage people to speak up. And I've met Ivrain very briefly at the race conference as well, and we're going to have a network of champions. I think we need to think moving forwards about how we're able to distinguish between the fact that actually we're creating the environment where people speak up, versus actually we've still got some real pockets within this organisation where we've got real problems. And while we'll always celebrate people speaking up, we just need to be mindful of it not becoming a mantra. Well, of course, everyone's speaking up because it's, you know, they feel so much better about the trust and they're able to speak up. I'd like us to challenge ourselves a little bit more as a board to be absolutely convinced that that's the case, and maybe think outside of here about how we bring that assurance back to the board, please. That would be really helpful. So use your fantastic mind to help us work through that one, if you wouldn't mind, Holly. But I'm going to draw that discussion to a close and say thank you so very, very much indeed, both for being here today and for all you do. And we'll note that report. Thanks very much indeed. Holly, and don't feel obliged to stay for any more than you need to. Let's move on now to the NSFT race report, and over to Caroline. That was seamless.
Yeah, I'm just going to introduce it, and then clearly Jeremy is going to be the lead executive for this going forward. But given it's day 3, it's not very fair to say to Jeremy, on you go. So this is the report that was we commissioned Yvonne Coghill to come and do. It's important that Yvonne wanted, her advice to us is that we created with our staff the consequences and the so what from this report, which we've still got to bring back to the board. But it was great to have the conversation earlier with people that attended the race conference that really felt it connected with the people that were there and massively had intention for taking action. The report tells us that we have much to do, and it's really, really important, I think, that we're open and transparent about that as part of our improvement. Something that I've done in other organisations that I've had the privilege of leading, and it's a big part of the journey of improvement, the honesty and openness. The report tells us that we have made some progress, which is important to recognise, and particularly if we look at, similar to many other organisations across the NHS, that we've improved the people that we employ from a minority ethnic background from 9.8% to 13.5% in the last 3 years, which is significantly higher than the local population. Now, whilst that's positive, it also gives us issues around people living in a population and being part of an organisation where they're very much a minority, and us understanding that experience in a much, much deeper level. We've got significant issues in terms of a glass ceiling. So only, whilst we have 13.5% of our overall workforce are from a minority ethnic background, less than 1% are in an 8A or above management role. So that's a significant area that we need to take action around. When we look at disciplinaries, and whilst with Jeremy's leadership, I know we're going to really focus on a much stronger just culture and really enable and support our leaders to prevent disciplinaries and grievances as much as we possibly can. We have a very strong dominance of our junior staff, band 3s, who find themselves in disciplinaries. They're 15% of our staff, but 42% of our band 3 staff are subject to disciplinary. Now that's of all backgrounds, but we have an overrepresentation of 27% of those people being black staff. When we look through the lens of abuse, harassment and bullying, we see that from a patient abuse, harassment and bullying, we have an overrepresentation of our white staff as well as Asian staff. And when we look through the lens of abuse, harassment and bullying by managers and staff, we have an overrepresentation from our white Irish staff and Asian staff as well. And actually the lowest representation from our black Caribbean staff. So it's a really, really interesting picture, and one that Yvonne has spent some time taking us through. We've also seen some good progress in terms of, if we see this as progress, as the leaver rate. So that has decreased from our minority ethnic staff over the last 3 years, from 20% down to 14%. So there's some seeds of hope for us to build on, but we have so very much to do. Obviously, we had the conference, we've got the Reach network that Jason chairs, we've got the Inclusion Council that I chair, and we are planning to bring back, through the People Committee, and then I think back to the board, a really comprehensive and detailed action plan with some clear metrics that we need to track through committee and board that demonstrate that we are going to take action and that we will see progress. Really happy to hand over to Jeremy. You might want to say a little bit more about your thoughts and intentions and then open it up.
Thanks, Caroline. Jeremy?
Yes, Thank you, Caroline. I don't have anything to add in terms of the detail of the report. It speaks for itself. It is, I am running to get up to speed with the brilliant work that has taken place prior to my arrival. As I mentioned much earlier in the day, a clear set of ideas and proposals from attendees from the conference, which is the starting point for our action plan. The thing that I found most compelling when thinking about next steps are the reflections in the report from colleagues who have remarked on their perceptions of other people and the lack of progress in the past. So we are coming to this now with some real energy and hugely positive intent, but there is also an element of perhaps jadedness or cynicism as a result of a lack of action or a lack of progress in the past. We will have to work so hard to understandably change mindsets on that. The thing for us today, I think, as board members, is to acknowledge what is in the report as an absolute starting point, is for each one of us to be absolutely conversant in the content of this report and what it's saying, and the joint and shared responsibility that each one of us have for the progress that we absolutely want to and must make as a result.
Yeah, absolutely. And, reaffirming that we've made this our absolute priority in terms of culture. And we had a long debate, didn't we, about whether or not it was right to highlight race as that priority, and it is. And we have to shift the dial on this, and we can do it by walking the walk and taking responsibilities as leaders around the board. And we can do it by providing support, encouragement, exhortation, and challenge. And that's what we're all going to do around this board table. In terms of pace and ambition, it would be helpful to understand what we expect to see by when, and what we'd like to see in terms of changes, particularly to our key indicators within our res data about how valued our black staff feel and whether they'd recommend here as somewhere to work for them. So I do think we want to set really challenging ambition on that and measure it forensically. Anthony, and then David.
Thank you, Chair. I think one of the things we... oh, sorry. Is it me first?
It was you first,
right, okay.
Then David, and I missed Paul. Sorry, Paul.
Yeah. I think one of the things we need to do is when you step into NSFT, you step into this space, what do you visibly see that sort of reminds you about how unacceptable this is as an issue? And there's nothing that catches your eye in this organisation as you walk round. We have sort of messages up about violence. We won't tolerate violence towards staff, but we don't have anything about that we won't tolerate racism. I think there's something about the need for good subliminal messaging as well to our staff within the organisation. There's the role modelling that we're all responsible for, but there's something about we know this exists in society, but you're stepping into this space, and there's something in this organisation that we've identified as a priority that we won't tolerate. So we need to make it more visible, I think.
Over the years, I've read many and been involved in many reports on race in organisations. I think for me, what's fundamentally different about this report, which gives me a lot of optimism, is it's evidence-based. It gives us a whole series of metrics that we can build into how we review the progress that we're making. And I think when everyone came to talk to the board of November, December time, I think that's what really struck me, how they dug into the data. So this is hard stuff. You can't argue against it, nor should you. But for me, that is to say that the point of the potential improvement that we're going to be making, because we can actually review the progress that we're making.
Yeah, quite right, David. Thank you. Paul?
Yeah, it's a great report, and I think, like David, I've been in many organisations where we've had this conversation, and I think it's great to have ambition and pace to change things, and there are a lot of things that we can change, quite technical things probably that we can do better, but the danger is that we get lost in doing the technical things. We really need to focus on changing the culture, and that is going to be the biggest challenge, I think. If you're in that room in Kesgrove, as we were on that day, you felt what the reality was. You felt what was needed to be changed. But I think there were 200 people in there, were they? That's 200 people out of 5,000 in this organisation. So there's something about how we really step into that space to have that conversation with the rest of the organisation about what this really feels like, so that people can own this in reality and make changes where they're at. And I think that conversation that was started there about what does zero tolerance mean, speaking back to what Anthony was saying about what we accept and don't accept, I think that's got to be a critical conversation that we have, because there are so many different views about that in relation to relationship between managers and staff and patients and carers and staff, etc. So I think we really need to be clear about that in our conversations as well.
Yeah, absolutely. And I don't know how we spread that feeling that we experienced in that room broader, but we have to spread it, because bulletins, posters, messages from me and Caroline and Harpreet and other fabulous, I don't count myself in that, but from other fabulous people in the trust ain't going to cut it. We need to get alongside and with our staff and have that conversation repeatedly across the trust. And if we mean business, that's what we should be investing our time in, I think. I think one conference is never enough, but actually being in a room together and having those sobering conversations and making that kind of together pledge is something that we have to do. So I know we've spoken about that, but as part of the action plan, coming forward with something that involves and embraces all of our staff in that movement, I think is really key. As I say, I have no idea how you do it, but maybe Jason's got all the answers.
I don't think I've got all the answers, but the fact is there were 200 people in that room from a wide selection across the organisation. And I think the key is allyship and really proactively promoting this movement, because the people we need to get to, we can guarantee weren't in the room. And they're the ones we really need to be targeting to try and influence. And and that's not easy, and because it's not an NSFT problem. People aren't racist because they work at NSFT. They're racist from a cultural, wider community point of view. So that's how we do it. We really need to be calling it out. We really need to be embedding the allyship roles across all the organisation and using those 200 people to do that across the organisation.
And I can be political because that's my job as chair. We have all of the evidence to demonstrate that this is an intrinsic and inherent part of us delivering the highest quality services we can to our service users, because if our staff feel undervalued, isolated, subject to racism and any other form of abuse, they're not going to be able to provide their best self to provide that care to our patients. And we have to be very aware of the political environment that we live in, which is in some quarters there is not an acceptance of that being a fact, even though it is. And we need to move rapidly and at pace to embed the change that we want to make in Norfolk and Suffolk in that regard. So, lots of pledges, lots of commitment, and I really felt that commitment from my board colleagues and others in that room. And Caroline is advising me that we may well be coming back fairly rapidly with the action plan, which will encompass a number of the contributions that colleagues have made today. I think we should have a standing item on the board agenda on progress against the race equity action plan, not as a token gesture but as a demonstration of our absolute determination to treat this as a priority. If colleagues agree. Okay, good. All right, lovely. Caroline, is the last word to you?
Well, I'm just very aware that Jeremy's literally just landed, and I haven't had the opportunity to talk to him about this. But I think we've got to work at pace on this. So I would hope that the team are now working on the action plan, that we can take it through to the next People Committee and back through to the next July, to the board in July.
Just with the caveat that I would want to make sure that we are engaging with people in a meaningful way. So, for example, the staff network are involved and are absolutely intrinsic to its development and are able to comment and critique it. But we should be able to do pace and meaning in tandem.
Great, that's good to hear. And Tricia?
Just as Chair of People and Culture, we have cleared the agenda down for the July meeting to create a bigger space for this. We've taken some items off at our planning meeting yesterday, and so whatever state that action plan is, it needs to come there to that July meeting.
Okay, that's really good. Well, thank you, colleagues, for that. Let's note that report and the additional proposals stemming from it, and let's move on rapidly to the equality delivery system. Jeremy.
Yes. Thank you very much. So this is one element of how NHS organisations are supported by NHS England to meet their EDR commitments. Of course, we don't do this work just to comply with legislation. Of course we don't, but it does help us to meet our obligations under the Equality Act and also the Public Sector Equality Duty. It's a peer-reviewed assessment of, in this year, 3 domains, one of which relates to patient experience, 2 of which relate to staff experience, and we are then rated on a 4-point scale in terms of our progress with this agenda, and the summative position is one of the sort of second of 4 of the ratings there, which is we are developing as an organisation, which feels about right. We have seen some progress since our previous assessment, which is highlighted in the report, and I am just going to bring Kath in if she wishes to around domain 1.
Yeah, very quickly, just to say, as Jeremy has said, domain 1 relates to service users and carers, and particularly focused on 2 commissioner identified services that were reviewed as part of this. The table at the bottom of section 2 shows the progress that has been made in all three domains since the previous financial year, particularly noting that improvement within domain 1. And there is still so much more work to do. We've talked a lot about race equity amongst our workforce. That also has an impact on service users. In terms of the impact of the care that is received by service users. So it's so important that, as Jeremy said, this is not a means of submitting an annual report. This forms part of our plan to tackling and improving and delivering race equity. Thank you.
Thanks very much, Kath. Okay. I suppose my question, maybe not for answering now, is how do we make sure all of this activity, which is presented in a form that NHS England require, actually is meaningful to the broader work that we're going to do on the race equity plan? Because I found this interesting. There's a lot here. I didn't understand the prioritisation. I think that's because of the nature of the kind of the document we have to send in. But maybe we can take that away, Jeremy, and come up with an answer.
For me, this is a tool. It's one piece of a jigsaw puzzle, and I would rather the board be presented with the whole jigsaw puzzle on at least an annual basis. So I will review that for the future.
Yeah, absolutely. I think we do have to have this before us in any event, but I just want it to be really meaningful. But Paul, you're going to give us assurance that we can work this through.
No, not necessarily, Chair. I was just going to raise the same issue because we've got the patient carer race equality framework, haven't we, as well? So there are a number of these things that are interrelated and speak to each other, and it does feel to me like those things need to be part of the same jigsaw puzzle, if you like, and that they need to be brought together in some way that makes sense to us. Otherwise, we're constantly reporting on different elements.
So let's just ask our executives to go away and have a look at that and come back with a proposition as to how we can bring it all together in one place. That'd be great. Lovely. Thank you. We need to note that report, I believe. Addy, thank you very much indeed. Colleagues, happy to note the report. Thanks very much. And we're going to go really rapidly, aren't we, Addy, to the fit and proper person test?
Thanks, Chair. I'm just going to spend a very short time on this. First of all, just to say, unfortunately, I just noticed there's a typo in the report in that it refers to the checks being done for 2023-24, which is wrong. Which is 2024-25. That's in the recommendation bit. But anyway, this relates to all the tests that we've done under the fit and proper person test requirements, which are set out in Appendix 1, and I'm pleased to announce that all of the board members who are in place during 24-25 have been adjudged to be fit and proper, and indeed I can also further say that Tricia Bennett-Hector and Helen Taylor, who obviously weren't board members during that year, would also have been fit and proper had they been, because all these checks were done in relation to their joining the board subsequently. So as a board, we are in compliance with the requirements.
Good, thank you. Noted. Thanks, Eddie. Yeah, colleagues, happy to note that? Great, really important part of good governance. Thank you very much for all the work that goes into that, because I know for a fact behind the scenes there's an awful lot that goes into making sure that we are properly fulfilling all of our obligations. So please pass our thanks on to the staff that do this as well.
Mainly to Nikki.
Many thanks, Nikki. Let's move now to, I think we still need to do audit and risk, don't we? Julian, over to you.
Thank you, Chair. So a very busy meeting, which was actually chaired by Linz, very kindly to me as part of bringing me into my new role. Quite a lot of focus on the internal audit programme, which is a really important area of assurance for us. And that programme has not gone wonderfully well this year, but mainly, I think, because of the delivery from the internal audit provider, TIA. And so we are well behind on that programme in terms of the committee review of reports, and we flagged an alert on that. We're going to be dealing with a lot of that programme at our final meeting of the year, which is in June, when we come to approve the accounts. It's not although it's a difficult situation, it's not impossible. Most of the field work has been done, most of the reports have been issued, and they're actively being reviewed by the executive and management teams. So it's recoverable, but there's a lot of work going on before the middle of June to get this clear. But having said that, it's possibly not entirely TIA's responsibility. It's ours as well in terms of turning those reports round, and the changes to the care groups has probably not helped that. So we're anxious to get that onto a much better footing this year. I think also under the advise heading, we did have a procurement internal audit which reported limited assurance. There's a number of management actions coming out of that which are being dealt with quite promptly. So I think we're feeling confident about those actions in due course. And finally, in terms of the original programme for this year, we delayed looking at employment disciplinaries. Jeremy, you'll be glad to hear about this in your first week. So we've put back that particular internal audit until November 25. It is an area of concern because we are behind with our disciplinaries, but there is a lot of change going on about that, and we were convinced by the recommendation to defer that particular audit until later in the year. So that's internal audit. On advise as well, we talked about cyber earlier, but we had a fairly comprehensive report around cyber, and it's an area that we as a committee are looking at very carefully. Some positive news around the value for money assessment from the external auditors, which is looking better for this year. And areas which are going better, where we are being assured, I think particularly around the counter-fraud report, improving trend there, but not perfect in terms of all the ratings that we get in the areas of counter-fraud. And the annual review of declarations of interests, gifts and hospitality, which is an important control in terms of some of the other areas we've been looking at today. So those are the main areas that we looked at in the committee. Finally, I should say, we did say a big thank you to Linz for her chairing of that committee over a long time. And as part of that, we handcuffed her to the committee for the coming years. Very happy to take any questions.
Thank you very much indeed for that, Jim. That's really very, very clear indeed. Questions? Sorry.
Just one thing on the internal audits. The internal auditors have confirmed that the outstanding audit reports will not impact their ability to make a head of internal audit opinion. So it won't impact our annual accounts and report submission.
Thank you. This is an ongoing issue in terms of the alert that we've highlighted here in respect of internal audit. Is this going to come to a resolution at some point in the not too distant future? I've puzzled you by that question.
Yes, I think we've had discussion and we'll work closely with the internal auditors to develop certainly the 25-26 plan and delivery of that plan.
Okay, possibly something for private board. Okay, thanks very much indeed. Can we note the report of the Audit and Risk Committee? Great, thanks very much. We've done the Performance and Finance Committee. Jason, we have done month one. under the IQPR, unless there's anything more that you want to add.
No, but I do need to formally mention month 12 for 24-25. So this hasn't been to board because of the timing of the board meetings. So these are pre-audit figures. And the trust achieved a break-even position in line with the plan, and it's a pretty similar story to what we talked about in month 1. It was achieved by utilising 16 million of non-recurrent savings, which the financial recovery plan mitigated in year, and it was in line with our financial recovery plan that we bought for earlier in the year. The efficiency programme delivered 5%, which is £17.5 million. 6.3 million of that was recurrent, which is actually the highest level of recurrent efficiency that the trust has ever achieved. So that's some good news, but not as high as we'd anticipated in the original plan. The only other thing I wanted to just mention briefly was the capital expenditure was 4.5 million above the original plan, but this related to the timing differences in relation to the expenditure with regards to the River Centre and the VAT refund. These timing differences had been agreed with both this ICB and the NHSE regional team, so they didn't cause us an issue at year end, and we expect to receive the VAT refund this year.
Thank you very much indeed, Jason. And of course, we have regular updates to this board in respect to the financial position, and the position for 24-25 was very much a baseline against which we had very significant and in-depth conversations around the setting of the budget for 25-26 financial year. So this is all very, very familiar territory to colleagues on the board, but thank you for articulating the position.
One final point, we have an extraordinary audit and risk committee to approve the annual report and accounts on the 19th of June and an extraordinary board meeting on the 26th of June to have the final sign-off.
Which we have to do in accordance with the statutory framework, is it, or just the obligations we have as a foundation trust?
Yeah, well, we have a deadline that we need to submit our accounts, so that
okay.
Gets us inside that deadline.
Okay, that's good to know. Any questions on that? No, thanks very much. Can we note the financial update and the position as of month 12? And formally, I don't think I did this last when we discussed it under the IQPR in month 1. And thank Jason and his team for all of the information that you routinely bring to us in such a clear and digestible format. Thank you. Let's move on to the CQC well-led inspection feedback letter. Caroline.
Thank you very much. So in the pack is our initial feedback letter that we've received as a result of our well-led inspection, which is prior to us receiving our full well-led report that we anticipate receiving a couple of months after the inspection, so probably in about six to 8 weeks' time. It's important, I guess, that we recognise, as I started off in my Chief Exec's report, the progress that has been made. And you can see from the letter a recognition which is so important from our staff and the passion and hard-working nature that they put themselves across on. They've recognised the recent appointments to the board, which is really positive, and our focus on local leadership, and particularly our new locality structure. Also, really importantly, the marked improvement in stakeholder relationships. They've indicated to us, as we would acknowledge, that there is more for us to do. So in terms of our new model, of course, there's more for us to do in terms of embedding the model. They commented on the fact they could see what they described as the up and down reporting lines within the new locality structure, but couldn't maybe see as much across the structure. which we provided more information because obviously we have a weekly business development group, a weekly patient safety group, which is executive chaired and brings all the localities together. We have a monthly trust management team meeting. We have the clinical networks that are in development. We've established the clinical transformation directorate, all of which is aimed to ensure we don't have silos and we have the cross organisational collaboration. Next issue they picked up, which we've discussed in this board meeting as well, is whilst we've improved our mechanisms and focus on data and performance, we have more to do to demonstrate learning and improvement. And again, we've talked about that today and our plans around that. Interestingly, they picked up that in the interviews, particularly with the executive team, that maybe we weren't strong enough in terms of the service user voice. So I think that's learning for us. Clearly, there's a real commitment to service user and carer voice. We've got that obviously in the Service User and Carer Council. We've got service users involved in a whole pluriad of programmes right across the organisation. And again, we've provided information around that. Further work for us to do around staff skill mix. Again, the board and the quality committee have been considering this, and we've got a paper in a moment on safer staffing and staff skill mix. We've established a support group through Anthony for staff that are affected, and there's a particular lens around international recruits that we're making sure that we are supporting. A theme around curiosity, check and challenge of the board, making sure that we focus continually on that. Obviously that's supported by our overall board development programme that we've been working on for the last year or so. Recognising the work we've done on freedom to speak up, but more to do in terms of giving staff confidence to speak up. And again, we've heard today from our Freedom to Speak Up Guardian. I've reported back that about 3/4 of the Dear Caroline speaking up now are not anonymous. So I think it's definitely moving in the right direction. More work for us to do around the PCREF framework, and just thinking about the piece, the jigsaw that we were just talking about before with the equality diversity report, the race report and the PCREF. I think there's something that we need to do to put all of that together and to give more focus. And I suggest we look at that again in the July board meeting to make sure we've got a strong enough plan, and Kath's looking at that already. And then the final area is around how do we continue to strengthen visibility, particularly of senior leaders across the organisation. Clearly, through establishing the localities, that's something that's really helped. We've just recently, as a board, aligned ourselves with localities, so that's in its very early stages of being developed. And we anticipate governors will be part of that as well. So it feels like we've got plans for all the areas of further development. We're giving more information to the CQC around this, and overall more than happy. And well, whatever people's thoughts and comments are, it's important, I guess, for us to discuss.
Great. Well, obviously we will have lots of discussions on this as we move forward and await the report. I think from my perspective, having now been through this a few times, I think we've been inspected 8 times the CQC have been in the last...
In 10 years.
10 years, so, you know, we're fairly familiar with this. We welcome them in. We are pleased that there are no surprises in this feedback, and that's very, very important that the inspectorate don't tell us things that we didn't already know. There's areas, of course, that we've recognised and told them that is very early doors and is not yet embedded, and we can't demonstrate that it's sustained. What was interesting for me when I attended the feedback from the lead inspectors is that sense of momentum and forward movement, which I hope they reflect in the final report as well, because sometimes they tell you nicer things to your face than they do in the report, and perhaps I'm even guilty of that in my past life as well. But what was very interesting is they recognise that we're on that journey. They recognise that we've come a long way. They recognise if they'd come perhaps in 6 months' time, things may be even better still. So I thought all of that was generally encouraging, but I think right from the beginning, the tone set rightly by Caroline and this board is one of humility, of absolute transparency, of being very clear that we've got further to go. And our expectation, obviously, is that they write a report that's fair and reflects that. I don't think we can ask any more of our regulator if that's what's achieved. And we're already working on those areas that they've identified, because we've told them that there are areas we need to work on, and we're just carrying on with it. So unless anyone's got any comments or observations, I suspect it's probably better to save those until we get the final report. But thank you very much indeed, Caroline. Let's note that update from the Chief Exec on the CQC well-led inspection feedback letter. And let's skip now to the Mental Health Legislation Committee Chair's report. Over to you, Helen.
Thank you. This was definitely in at the deep end. This was a meeting observed by the CQC. I suppose the introductory thing to say is that this is very much an evolutionary, in an evolutionary stage, really. The work has been taken out of the Quality Committee, and that will enable ultimately the board to have sufficient oversight and assurance on our work in this key area. So there were no alerts, but we had a report, a data report, but very helpfully had the conversation with Alex Todd from Business Intelligence about how that work, the work that he's doing with Faisal and colleagues to automate that. It's a very, I understand, very labour-intensive manual kind of process at the moment, and also that data will come through in a more timely way, because it was 3 months old, the data that we were looking at. So that was a key part of the meeting, looking at the data that we have. And recognising the need to develop more of a narrative to accompany the data that there is. Just to flag on the advisory notes that there were delays in the authorisation of deprivation of liberty safeguard issues once urgent approvals have lapsed. But this is a kind of very long-standing and national issue, not helped by the delay, or it just seems to have fallen off the agenda altogether, about the national agenda about the liberty protection safeguards, which would have addressed some of those issues. But we had a conversation about more information about that in the future, particularly about the effect on the patient experience, and that was a running theme through the conversations that relates to the points that we picked up earlier about mental health advocacy and mental capacity advocacy. So we asked to see more of that in future meetings. So overall, it was a good meeting, but evolving.
Well, all I can say to you, Helen, and I think we should record the board's thanks, is congratulations. Thank you very much for taking on chairing this, and for us to put the added pressure on you, not only the first meeting of effectively a new committee and CQC observing as well. I think you did a tremendous job, and thank you for feeding back so articulately. I think this is going to be this is really one to watch. That's why we've taken it out of the Quality Committee, so we can shine that light, and very much looking forward to your reports back to this committee moving forward. Your point about qualitative data is so important, isn't it, Stuart? So I'm sure you'll be picking that up.
Yes, it's work in progress.
Work in progress. Faisal.
About data which leads to intelligence, which leads to insight, is key here, and that's what we're working on. There's a very, very detailed piece of work that sits underneath all of this, and it's going to go through the group to the committee, and it's going to link into the IQPR for the board.
It's really great to hear. Thanks very much. Any other colleagues got comments or observations? No? Well, with thanks to Helen, the new chair, recorded, let's note the Mental Health Legislation Committee Chair's report, and let's move on to the Service User and Carer Council update in terms of reference. Kath.
Thank you so much. A quick update. We have obviously we have co-chair, and Talia is here today, and will be joining us going forward at board. We have a vacancy on the council, which we are recruiting to currently. Caroline mentioned Rethink as the co-production partner that we've appointed, which we're really excited about. And they are going to support us with regard to the rollout of the local councils that will take place later this year, and also help with the development of the council itself. Chairs of each of the locality councils will join as members of the Service User and Carer Council, the Trust-wide Council. The members of the current council have done extensive work on these terms of reference and ask for the board's approval of the terms of reference that you see before you. Happy to take any questions or comments.
Thanks very much. Thank you, Kath. This is really, really important, isn't it? And extending this across our localities in a joined-up way as well is good. And I can see that there's a real determination to do that at pace too. Questions from colleagues? Paul.
Yeah, thank you. Maybe you know the question I might be going to ask at this point, but great terms of reference. But having sat on the Council of Governors, obviously the governors do represent the voices of service users and carers as well as the Service User and Carer Council. So my question is there a relationship between these two councils that needs to be in some way reflected in the terms of reference of both? And I know you're in the process of still co-production with colleagues, but it feels like there's an opportunity to do a bit of co-production with the Council of Governors around that as well.
Can I just add to that as well, actually, Paul, because, you know, you're absolutely right, and we've discussed this, haven't we, in the Council of Governors, and I'm conscious that Talia's wearing two hats on this as well. Not anymore, but understands the perspective. But I have a similar question, if you're going to answer this. We do have an existing and extensive infrastructure of people participation, of volunteering, and I know that they feel that they would like clarity as to what the interface is between Service User Council and the existing structures as well. So let's have a brief update from you, Kath. But I suspect what we're going to need to do is a bit more comms around this so that everyone's clear.
Yeah, thank you. So I think the next steps with the support of Rethink would be to look to see how we can connect and what the interface may or may not be with regard to the Council of Governors. So I think it's a great opportunity, but for us to use a co-produced approach in order to take those terms of reference to the next step. We were very keen to get these agreed because we've spent a long time as a council going through these, and Talia has done an amazing job in helping to coordinate all of the responses. So I think this will be version 1, but I would suspect in a few months' time version 2 will come along as a result of the development of the council with the support of Rethink. And then in terms of the link to other groups of people, participation, colleagues, volunteers, I think the fact that this sits within my directorate means that I can actually coordinate and pull across all those different groups of people. We will be able to have a much more strengthened approach to involvement, engagement and co-production, and using the expertise on the Service User and Carer Council as a fundamental part of that process as we develop our corporate team and learn, as I say, from working with Rethink.
Really helpful, and I can see all the work that's gone into this, and I know what it's like drafting, you know, bringing together people who are new and getting to know one another and actually coming up with such a comprehensive set of terms of reference. I congratulate you on that, Talia. Thank you, and thank you, Kath, for the support. I think that broader issue of the interface between this and other mechanisms that we have isn't really a question for the terms of reference for the Service User Council, Care and Service User Council, but it is a question for us as a board, and it would be helpful to come back with clarity on that in due course, if you wouldn't mind. With that in mind, colleagues, any further comments on the proposed terms of reference? Could we note our thanks to Talia and congratulations to you for being appointed co-chair, and can we approve the terms of reference and note the report, please? Thanks very much indeed. Right, Kath, this is at the point I've got a bit confused. Service User Experience Report.
Yes. Yes, that's correct. So it's a separate report which gives an update to the board in relation to different aspects of how we capture service user experience. So you'll see within the report there is information relating to in section 2 complaints, for which you can see there has been some improvement in the response rate for 30-day turnaround complaints, but still nowhere near where we would need it to go. There's also, we've talked about friends and family earlier on, so I wasn't necessarily planning to talk about any of that. Previous board, there was a request for just an update in relation to the Parliamentary and Health Service Ombudsman position. You can see that at the bottom of section 2. Compliments. It's always important that we remember that service users who take time to give compliments to the organisation, often directed to individuals. You can see that that's reported in section 4. Next steps in relation to the service user and carer experience. We approved the strategy last year, and a comprehensive update was taken to the Quality Committee in May in terms of progress against the deliverables set out within the strategy. We've already heard in relation to the council, and we are progressing with regard to ways of being able to evidence and effectively influence improvements and transformation within our organisation, working very closely in particular with Stuart. Thank you.
Thanks very much indeed. Lots of activity going on in this space. Thank you very much indeed, Kath. Questions? David?
Kath, do you have any sort of understanding of why we're still consistently below target in responding to a complaint? Clearly we're acknowledging within sort of 3 days, but the 30 and 60 day, I mean, to be on the receiving end of a complaint, to wait for that long, is just really unacceptable. And I mean, we've never really hit that sort of standard. So any thoughts about what the problem is and what we're trying to do to rectify it?
Yeah, absolutely. So we get a relatively high volume of complaints, and they are allocated to the relevant locality team for response, and there is variable response, I will say. There's also variable quality in the response, and then the customer services team, as they currently are called, then have to do a lot of quality assurance work in relation to the complaints, and then potentially go back to the locality team, and eventually then they come through to me for that final quality check. And we do not have that process mapped out effectively in order to set those expectations of turnaround. There's also some of the complaints which are very complex, which I believe we are not accurately. Some of those complaints should be labelled, should be badged at 60-day responses, and then we need to give realistic and reasonable timeframes to the complainants, so they are not sitting there waiting for something that they're expecting to receive within 30 days, when in fact 60 days might have been more reasonable. So we have within the...
Kath, I'm going to hurry you up, please.
Okay, no problem. We are undertaking a mapping and then an improvement programme, and working along with training for people who are investigating and responding to complaints, and requiring an improvement in the quality of that. I'll stop there.
Oh, press the ding dong bell. Ding ding. Sorry about that. Thanks, Kath. It's a really complex issue, David. It obviously gets picked up through the appropriate committee. We do want to see, I think, the general tone is we do need to see improvement on this, and people in localities need to be given the time and the space as part of their day job to be able to respond to complaints. And part of the root cause is that they haven't been given that time and space to now, but we've got that opportunity, haven't we, the locality directors to change that. Any other questions of Kath? No, thanks very much, Kath. Let's note that report, and let's move on to the safer staffing report, Anthony, and then followed rapidly on with safer care. I'm planning to give this at least 20 minutes. Andy, I know you're going to give us an update on the assertive community mental health support, which will take a little bit of time, and I want to leave at least 10 minutes at the end for questions from members of the public.
Yeah, thank you, Chair. I'll take the report as read, the Safe Staffing report, and you'll have seen that there's three sections to it. The first is reports on what we routinely have to send through to the National Quality Board, which is our staffing levels against the establishment. So that's our fill rate, and we've got the data there for 3 months, January, February and March. The sweet spot around those safe staffing numbers is if you can keep between 90 and 120%. Anything beyond that, those parameters obviously gets flagged as red or amber. At an aggregate level, we remain within those parameters, but you'll see from the report there's wards where we've got very high numbers of fill rates and some low fill rates as well. And the narrative in the report points to issues such as sickness, vacancies, acuity levels and the registered nurse issue as factors that have affected that. In terms of the daily checks, we have daily safe staffing huddles to make sure that across our wards the staffing levels have been reviewed, and where necessary we do reallocate staff if we need to ensure that the wards have got safe numbers in place. So there is that daily check. There's also the weekly check and challenge meetings with the senior nurses to make sure that rosters are completed and that we've got shifts covered for the month ahead. So they're the main points. Happy to take questions on the National Quality Board requirements. The second section in the report is around the work that we're doing on the mental health optimal staffing tool. And that work continues. It's part of our clinical transformation work for our inpatient work stream, and we're using the MHOST data to inform what our enhanced multidisciplinary team establishment should look like for our inpatient wards moving forward. That work is still in progress. It's not been completed yet. We've had some initial options coming through the directors of nursing group, but we will need to sort of bring that information, the detail of that information through to executives and then update the future board hopefully in July. The next section of the report is obviously the one that's most current and a cause of concern, I know, at the moment. Chair, you mentioned at the beginning of the meeting that we had new people with us today. So just very briefly in terms of what's the issue here. As a provider, we're regulated to provide secondary specialist mental health services, assessment, treatment, diagnosis, and for people who are detained under the Mental Health Act. We therefore have got a duty to ensure that the staff are appropriately qualified and trained to provide that care and treatment. That doesn't negate the need for a good skill mix, but we need to ensure that we've got people with the right qualifications and competencies in charge and carrying out assessments. So in early March, board colleagues will know that we discovered that we weren't always providing a registered nurse mental health or a registered nurse learning disability to be in charge of our wards at all times. We discovered that we had a number of registered nurse adults or RGNs, registered general nurses, in charge. It was a small, when we did the deep dive into that, it was a small proportion of the overall shifts that were covered by registered adult nurses. Nevertheless, we had hotspots, and those hotspots were the Julian, our older people's hospital, our outlying wards at Kings Lynn, Samfire, Great Yarmouth Acute, and one of our low secure units in Norwich. We took immediate action to remedy that, but obviously that affected a number of our staff who are registered general nurses. We've been working through this at pace, as much pace as we can get behind this. One of the things that we importantly had to do was to review all of our incident data, and we discussed this with our regulator CQC at the outset, and also discussed it with our ICB colleagues. And at that point we decided that we would look at 6 months worth of data and incident data, including complaints, including Mental Health Act issues, including freedom to speak up issues as well. We've had that data through our incident management group, which was established to oversee and manage this issue, and that initial set of data has not revealed any significant concerns to us. So I think based on the discussions that we've had at the IMG, we need to do some more work on that. We're proposing that we will have a wider group, similar methodology to the work that we did from Learning from Deaths. We will have a wider group. It will become a subgroup, an extraordinary subgroup that will report through to the Quality Committee, and will include system partners, service users and carers in that, to get their views on what more do people think it would be valuable to look at here, by way of any kind of concerns around potential harm. I've also got a meeting planned with CQC to discuss that as well, so that's work in progress. At the moment, in terms of duty of candour, we haven't identified anything that would meet the threshold for duty of candour, but obviously the further work may sort of reveal that we do have things to consider. In addition to the review of data, we've completed all of the competency assessments for our registered nurse adults in inpatients and in our urgent care 24/7 services. We're now, through our Director of Nursing Group, we're now making sure that those competencies align to NHS England's competency framework and align to the bands that those staff are employed in, and that will then inform how we can ensure those staff can be part of the skill mix in either those teams or services moving forward. We've said from the outset this is not about staff's roles, jobs being at risk. This is about making sure there's safe care and that professionals are supported within their scope of competency to practice safely. We've continued the discussion with the NMC, in particular around international recruits who are very concerned about their livelihood and future. The NMC said that they informed us that registered nurse adults who've completed the requirements for the NMC in the UK, that they couldn't undertake the mental health test that would put them on the register unless they've completed mental health training in their home country. We're working with HR colleagues at the moment to get that information, to see if we can support them to do that. I've written personally to all of our international recruits to assure them about their sponsorship and their visas, that they're not at risk, that we're supporting them as an organisation with that. We've also set up a support group for our all of our registered nurse adults, or RGNs. There's been 2 support groups so far, chaired by Dawn Collins, one of my deputies, and they found that extremely valuable and helpful. Trying to think if there's anything else that's helpful to I think they're the main points that I probably want to highlight on this, and I'm happy to open it up to questions.
It's really helpful, very, very comprehensive. A huge amount of activity has been undertaken from the moment that this matter was discovered. It's gone through the appropriate governance arrangements. It's been subject to significant check and challenge in the Quality Committee. Most recently, we've set up the additional group to provide further oversight and challenge. We do have a track record of being able to manage situations like this, and we've adopted the approach we took in learning from deaths. And key for us was to establish the facts, understand the issue, and then determine what action we're going to take to put it right. And it was really important that that information gathering, that inquiry stage was undertaken properly and by our executive team as well. Just for the record, Lynn's.
Thank you. Thank you for the report and the overview there. I have two questions. I'll make them brief from the report. The first one is using the mental health optimisation staffing tool, or MHOST, as it's known as. How will variances within different teams be managed, even with an optimised tool for staffing? You've already demonstrated throughout the rest of your report that there are outliers, whether it's from acuity or events that happen on specific wards. So even using that tool, how would staff be able to flex up or down their staffing requirements under MHOST? I'm trying to get to what will feel different next time when that comes in. And my second question goes into the registered nurse issue, and completely agree the amount of rigour this has already been through and the various committees' discussions. But I'd like to challenge us again as a board. We've gone back for 6 months to see if there was any concerns within that area or any period of harm, which you've identified none. Thinking of our learning from deaths, we went back a lot further than that. So should we be going a lot further back on the registered nurse issue, back to when ultimately things changed and general nurses were becoming prevalent on the wards?
Thanks, Lynn's.
Thank you. Lynn's, thank you. Just in terms of the mental health optimal staffing tool, it will provide us with an indication of what your staffing levels should be on that ward, particular ward, based on the acuity levels. So we, as you don't really remember, we captured 3 data points, and we'll be repeating it as well, in order to get some kind of a reliable information that that controls for either seasonal change or other things that might be happening through the year. So that information, along with the professional judgment, should be able to tell you, what your staffing levels need to be on those wards. There'll always be a degree of there's headroom built into that then as well, in terms of flexing up or down. We should be able to flex up or down, but we shouldn't. The sort of extreme variation that we're seeing, we can't properly explain that at the moment. And what seems to be happening is a default to safety in numbers, that people are just bringing in additional numbers, and I can't connect the two. But if you have got maybe nurses that are not trained in mental health, you may feel, I need more support around. I need more additional staff here. So I'm not saying that that's the causative factor, but I think it is an issue here that people we need people who can apply the right professional judgment in those situations as well. So I think MHOST will help us determine what the set staffing level needs to be. It's not a dynamic tool that we can use on a daily basis that says to, you know, next week we'll need X or Y. It will give us a position that we can, with finance colleagues, workforce colleagues, agree this is what we need moving ahead now. And then on your second point, I based on what we've found, Linz, I think you're right. I think we're going to have to look at a longer period of data to provide us with the assurance that we've not missed anything. And I think.
Can I just be clear on that, Anthony? I thought you said that we hadn't found anything that gave rise to concerns regarding duty of candour.
No. We've not found anything from the 6 months worth of data,
Right.
but I think the challenge will come.
It's now safe to go. Now it's appropriate to go back.
You probably need to look at a wider set of data here, period of time rather.
Caroline.
Yeah, I think what we were planning to do is to use the same approach that we did with learning from deaths and discuss with our ICB colleagues, our CQC colleagues and regional colleagues. I think you're going to pull together those into a multi-agency meeting to say this is what we've done so far and then agree what the next steps are and the time period for that.
We are, yes.
Yeah, brilliant.
Will the plan for that then come back at the next board?
It should come through the quality committee first and then definitely through to the board. Yeah.
Thank you.
Thank you, Liz.
Thanks, Anthony. Any other colleagues' questions on any points in that report? No. Helen, sorry to land this on you, but obviously there was a significant discussion in Quality Committee regarding the registered general nurse issue, and you fed back in terms of your report. Is there anything additional that you think the board ought to be aware of in that regard, in terms of assurance that we're taking all of the right steps from your perspective?
No, I don't think so. I'd really welcome the transparency with which the issue is being covered, and I think based on the approach that was adopted in learning from deaths, adopting that similar approach with the subgroup will give us again that increased assurance and oversight of the issue. For me, I suppose there's always just kind of one fundamental question about having discovered this and everybody was surprised. Inevitably you ask yourself, are there other questions, other dark corners? But that's just always an issue for boards, isn't it, of NHS organisations, I think. Are there other things that we are surprised if that we don't know about? But it's a bit unanswerable. Caroline's got an answer.
Well, we were having this very conversation yesterday and particularly thinking about our internal audit programme for this year, and Anthony was just going to go away and think about our other professional groups and do we need to have an internal audit. I think the medical profession is really well regulated, but we were thinking about psychology, social work, AHPs, and you were just going to go away and have a think, and then we might build it into our internal audit programme this year.
I think somewhere having that conversation in a board committee as well about are there any other things that we should expect the unexpected in NSFT. We are the most inspected trust, I think, probably in the country. CQC have been here 8 times in the last decade. We think that we're bringing kind of forensic oversight to our organisation, but we can always charge ourselves to do more. So those conversations about what's the possibility of what could be happening that we're not aware of, and then coming back here actually for assurance, I think would be really helpful. And it's very difficult to answer the question of, is there something happening that we don't know about? It's that kind of unknown, isn't it? But I think we have to challenge ourselves in that regard and satisfy ourselves that we've gone through that process. So it's really helpful, Caroline, that you're doing that. And could we have that process at least reported through committee and to board, please? Great, thanks very much indeed. What I'm proposing to do, Anthony, if we're finished on that particular report, is ask the committee to note that report. Everyone happy with that? I'm really conscious that we've got members of the public who have been really patient who want to ask a question. So I'm going to do the public questions now, and then I'm going to extend the board by 15 minutes so we come back to the safer care item and the action plan on intensive and assertive community mental health support after questions from the public. And thank you so much for your patience. Over to you.
Thank you, Chair. As a Unison caseworker who works and represents a lot of members in your partner organisations, it's been really valuable for me to listen to all this today, to get your view of where you're coming from and how you're trying to deliver those services. Because from my perspective, when I'm meeting management in these organisations, it's sometimes that isn't clear. And I think they play on that as well. So by me being educated today, thank you very much, I know now who I need to go to, who I need to, let's say, step it up a bit and let you know what's actually happening on the ground. So thank you very much for that. My question is, Norfolk and Suffolk Foundation Trust contracts Norfolk and Waveney Mind to deliver NHS Step 3 talking therapies. However, Norfolk and Waveney Mind advises it does not employ high-intensity therapists as required in Step 3 talking therapies to deliver high-intensity interventions, as instructed by NHS England. Can you please confirm if NSFT has contracted Norfolk and Waveney Mind to deliver NHF Step 3 talking therapy services strictly in accordance with the NHS England Talking Therapies Manual instructions, including those regarding the workforce?
Simon, thank you very much indeed for that. And I'm also really glad that you found value in understanding who we are around the table, and really do hope, we work in partnership with our representative bodies, and we all want the same thing, which is for NSFT to improve. So I do hope from your patience in sitting through this board meeting that you'll find that we're more accessible to you. But I think Jeremy is going to answer that question.
Yeah, thank you. Hi, I'm Jeremy. I'm going to start to answer the question today, but I'm sure we'll need to continue the conversation outside of board, which I'm very happy to do. There are a number of issues, I think, wrapped up in your question around the nature of contracting, around job evaluation, and also around sort of employment responsibility. So we need to work through those. I am on day 4 and want to get under the skin of those things so that I can properly answer your question, which I will do, and we can talk outside.
Okay, thanks very much. It's just that we have actually invited the Trust and Mind to discuss this in a meeting openly, because unfortunately the members I'm representing haven't had a straight answer. It seems like the Trust has been saying this is Mind's problem, Mind have been saying this is the Trust's problem, and I think the ICB are very clear on what needs to be delivered. So yeah, if we can have some dialogue over this. It's just that the members have already had strike action, a day of strike. They're about to work to rule because they are not being paid as high-intensity therapists, and they have been told that they are not high-intensity therapists. They're not going to take on any new high-intensity clients. And at the moment, the last figures I saw, around 60% of the referrals are high-intensity. And that action will be starting in around 2 weeks. So if we could meet as soon as possible, because obviously my members don't want to take this action.
Yeah, I think it's really important that we do this. There's a couple of things I take from this. Caroline's going to give you a response, because obviously Jeremy being very new, it's difficult for him to go into all of the detail. But what I will say in terms of matters of principle, I think it's really important that we have these conversations with our representative bodies ongoing, so that you don't have to come to public board to have this conversation. And I'd like to apologise to you for you having to have done that. And obviously outside of here, I'd like to understand why it's got to this and you've needed to do that, Simon, because obviously there's established routes through which we have these ongoing conversations. So I'm no more cited on this than my non-executive colleagues, but it's a revealing conversation for us. I think Caroline's going to give you a further response, and then outside of here we'll work our way through this. But thank you again.
Thank you.
So, yeah, Simon, thank you ever so much. So Peter Passingham wrote to me, who's the regional Unison person, isn't he? And we've agreed, and we've got a date in the diary to meet with Peter to discuss this. We're just waiting for Gary to return from his leave, who's the Chief Operating Officer. So it's in a couple of weeks, I think, and Jeremy, myself and Gary will be meeting, and you're more than welcome to come to that meeting.
Okay, thank you very much.
Thank you ever so much.
Yeah, we really value the trade union voice in all that we do in the Trust, just to be really clear on that. Thank you. Has anyone else got any questions? Michael?
Yes, thank you, Chair. There's 2 points. I think yeah, true. 2 points. One is on carers, the other is on racism. And I just want to be complimentary, as I like to be. Now, your report is excellent on carers, but what I have been worried about, this conversation has been going on when I was in harness in the Trust since the mid-90s, and it's taken a long time to get where we are. And so hope that's it, plunge ahead, don't hesitate anymore. And the other thing is for young carers, I've been very passionate about young carers. I brought it up on social services here and when I was on HOSC. And it's so important that because of their lifestyle, school, work, caring for their invalid families, it's hard work. And I do hope you will look after the young carers in particular. I think I've said enough on that one. The other one is racism. Well, since 1976, I've worked with and trained with the Royal Edinburgh Hospital, the Inverness, Highland and Islands, and the greater part of the time down here. And you know something? I've worked greatly with people from all over the world. And you know something? I have very much appreciated that, and I have become very richer for this experience I've had, so I do thank you. So the thing is, I've never come across racism in all the places I've worked at. So that says a lot. So hopefully, you know, we've had some cracking people from all over the world, and I've really enjoyed working with them. So racism, I haven't come across that in the health board. I think that's all I'll say.
Okay, thank you very much indeed for that. I'm going to ask Caroline to come in on the carer point, and I'm going to say something about racism. And I think the issue for racism is about our ability to understand racism from others' perspectives. And I think it's always very difficult for us as people who are white to be able to make comparisons and perceive the world from where we sit, and I think we have to be careful about doing that. So you'll understand, Michael, that I feel I need to respond to what you've said in that way, but I'd ask Caroline to answer the question that you've raised in terms of carers.
Yeah, I mean, I think what hopefully you've heard, Michael, during the meeting is our real determination now to sort out and invest in supporting carers, but obviously making sure that that's linked to service users so that we've got carers right at the heart of everything that we do. The fact we've appointed Kath as a new executive role as leading on service users and carers, she's now building a team around her. We've got the listening into action, Family First, we've got the carers Charter wants to call it the Triangle of Care because that's what it used to be. So we are, and we're meeting next week. So certainly I will be keeping really close to that. So dead important, and thank you very much.
Thanks very much, James.
Yes, thank you very much indeed. And may I just say the papers, the 452 pages of them. I mean, how well presented they are. And what a document that one can take away with you and refer to in later weeks and months when you compare things. So thank you for that. If I could just first of all say, Chair, a thank you to Paul. I say on behalf of the governors, but on behalf of myself particularly, of the work that Paul did as lead governor and lead governors prior to. And also, once again, perhaps I'm speaking for myself, I've got two other governors here, delight to see Talia here at your table. I think that is going to be a huge step forward and absolutely shows the trust doing the right thing. Paul's already mentioned about how it links with what the governor's role is. I am sure we can make it work, and with Talia there, we can make it even better. So just coming to the 452 pages that you have.
I think there's a question in this somewhere, James.
Well, yes.
But thank you very
you
much.
wouldn't like it if it wasn't
No,
a question.
I wouldn't. Carry
you?
on.
No, you tell me afterwards. Yeah. So you have the 3 A's I really like. This alert, advice, and what's the other one? Assurance. Thank you. On the particular one under the Integrated Quality and Performance Report for Improving Care, there are actually 6 of those reports, those diagrams, that are outside framework, outside the framework. Nobody has actually commented on those within your reports, and I'll just take one of them particularly, is of complaints, because within the report there are 150 complaints shown, but actually when you come to the service user experience for the same month of February, there were 45. So what does it mean when you actually say outside framework? Thank you.
Well spotted, James. Thank you very much for that. And Stuart?
Yeah, thanks, Chair. And yeah, thanks for the question. So there is work ongoing. I think I mentioned it a number of times that it's an improvement process trying to pull the integrated quality performance report together. I think Anthony also mentioned there's a number of areas that we want to try and improve in improving care. When we talk about outside the framework, it means that that's some work that we need to do in the organisation to set the standard that we want to see for each of these metrics, so then we can report against them. And we're in the process of working through those metrics to achieve that setting of the standard in the organisation. Once that it's in there, then we can report against a target. At this moment in time, we haven't got a set target for those individual metrics that we've identified as outside the framework. That's the rationale for it. So in the coming months, you'll see those disappear and become less and less in the programme. So you'll start to see individual metrics.
I'm just interpreting from James's slightly, I was going to say glum look, but not really glum, just quizzical, I think is your look, is you're wondering why there's 2 different sets of data on the same point, and I wonder if Kath can help with that.
Yeah, absolutely. So I looked into this myself, and it appears that we're not reporting like for like. So the 150 aren't just complaints that come from service users. They include other sources of concerns, whether they're MP complaints, but also we have what's called EPIN, which I've got the translation for in a second. But this is where we have issues that get raised from other providers in the system, queries, concerns, etc. So the information that's dragged across from Datex includes all of that, but in our patient experience report, we are reporting on service user and carer complaints. So one of the work that we need to do together with Stuart's forming team is making sure that we are not continuing to make that mistake in relation to reporting on essentially apples and pears. Mm-hmm. So it's well spotted, absolutely. I actually queried that with my team, and that was essentially, they did the maths and worked it all through, and it all adds up to those different sources of complaints and concerns.
So, Chair, thank you very much for that, and I accept that response. I think the concerning thing is if out of 9 reports, 6 of them are out of frame, then, are there things that are actually slipping through that you must get them sorted out? Thank you.
I think let's have one more go at explaining what we mean out of framework, because I don't think it does mean that, but I can't attempt to explain it. Stuart?
Yeah. So outside the framework is that we haven't set the standard yet as the organisation. Doesn't mean we're not monitoring. So we understand, that if we get an improved position or a position that's going down, we're monitoring that through the QPGs within the groups themselves. So we have a conversation on a monthly basis, but we're comparing month to month. What we're trying to do now as an organisation is to set the standard. So we're in the process of doing that, but it takes a little time to agree that standard across the organisation. But in the coming months, you'll see those disappearing.
The only thing I'd add to that
is that sometimes we can't set a standard. So with complaints, would we really say, well, we want to set a standard of having 20 complaints a month? Or would we say that we want to set a standard of reducing complaints and demonstrating learning? That would be an example. Whereas if we're looking at a waiting time, for example, we want to make sure that 100% of children are seen within 1 week if they've got an eating disorder. So there's different metrics that can have different standards, and some that it's more difficult to do, or it's just not appropriate to.
I think what we'll need to do is just be really clear, and if we're awaiting a framework, we'll say so. And if we're, like other probable mental health trusts, struggling with actually identifying a framework, then again, we'll make sure that that's really clear within the papers, James. So it's a really good point.
Yeah.
Great, thank you very much indeed. Any other questions from members of the public?
There's one written question that we received in advance from Duncan.
After you, Eddie.
So in addition to those questions, we had received a question from Duncan Double in advance, and the question is, the out-of-area placement problem is long-standing over many years. It is therefore welcome that the plan is to reduce such placements to 0 by October. However, there have been many such previous commitments which have not been realised. The problem can probably only finally be solved in each locality if each locality develops services to keep within its own bed allocation. This has the advantage of beds being part of an integrated, functioning locality service. How will localities develop services to function within their bed allocation? And we've got an answer from Andy. Do you want to read it, please?
Andy, if you could just give a potted response, please, rather than that very long response that I've seen there, that would be great.
Thanks, Chair. So I guess in essence we've had lots of that conversation already today under the crisis and out of area conversation. I think the only bit that I would add is, as part of our new structure, clearly we've moved to a position where we've got localities with bed stock within those. So the aspiration is clearly to get to that space, but in the interim we have to wait till we've managed all of the bits we've spoken about today.
Thanks very much indeed. That's really helpful. Thank you for the reminder as well, Ade. Okay, so that's the end of questions from members of the public. So we're going to go on to the safer care part of the agenda, which is item 2583. Anthony.
Thank you, Chair. And again, I'll take the report as read and just highlight a few key points from it, and then open it up for any questions or comments. The report is here for the board to note and comment on. So you'll see that it mentions that there's been a reduction in the number of incidents, but that's slightly kind of counterfactual. It's to do with the new national reporting system, that once a DATEX report is submitted, it automatically goes through to the national system, whereas previously DATEX would come in and our safer care team would disaggregate the issues. So, falls might be related to a restraint, or related to somebody, an assault between two patients. So we would separate those out as different incidents. So don't be alarmed by the reduction in the number of incidents. We're still looking at those particular issues within safer care. The issues that have been highlighted in the report obviously refer to the number of self-harm cases that we've have. They're some of the highest incidents that we see. There's the work that Kath mentioned earlier around the suicide prevention work. We're doing some work on our storm training, which is storm training is about clinical risk assessments. We have also produced some self-help guides for our service users as well, and we're also obviously working on the co-production of care plans to create good safety plans for our patients as well. Physical assault is another area commented on in the report. This again is something that we're addressing through our Culture of Care programme. We've got a reduce and restrictive intervention programme, and we did a deep dive into that and reported to the Quality Committee in January in terms of how we're reducing physical assaults, and we've also got our violence prevention and reduction group established now as well to oversee that. I've mentioned about the work we're doing to improve the number of staff that are trained to carry out effective clinical risk assessments. The staffing issues are being dealt with through in the 111 service through our incident management group and the clinical transformation work. I think other points to highlight from the report, you will see under safeguarding that there's been a drop in the number of referrals, which we don't fully understand. So I've asked the safeguarding team to do to review that, to understand why we're seeing that variation in our safeguarding referrals. We've just recently appointed a new head of safeguarding, Kirsty Henry, which is a really helpful appointment and has now got oversight of safeguarding across the trust. I'm pleased to report there have been no never events during this reporting period. And it's also good to see that in terms of our prevention and management of aggression and violence team, which provides all of the training to our staff, they received accreditation earlier this year for the standards that they provide within that training, which is a positive. And then I would just draw the board's attention to, under the IPC part of the report, you'll see there was an audit of the in regard to water safety and the governance arrangements that we have around water safety, and that reported limited assurance for that. So there is now an action plan in place to address that limited assurance that is being managed through our health and safety group through to trust-wide safety and trust management team. So I think, Chair, they're the main points that I'd wish to highlight from it, and happy to take any questions.
Great, thank you very much indeed, Anthony. A very important report, this. Colleagues, questions, thoughts, observations? Linz.
Thank you. Thank you for the report. In the period since this report, there was a very unfortunate incident with a service user out on leave with 2 members of staff from the Woodland unit. It was reported in the press. Without going into any detail of the individual or their circumstances, can you just give us assurance, please, that that will go through the same rigour as other incidences? And where might we see the assurances of that come through and the learnings from it?
Thank you, Lynn. Yes, I mean, that's been categorised as a serious incident, so it will be subject to a serious incident investigation. It's been reported, obviously, through the national system. So our Safer Care Directorate will be overseeing the investigation of that particular incident. It will be reported through Trust-wide Safety Group, and then Trust-wide Safety Group we report through to the Trust Management Team and to Quality Committee as well then. So you should see the outputs from that investigation through the Quality Committee.
Anyone else? No, I mean, the data in here is really important, and you've given us an explanation as to why that's changed. I do think that we could do with some further assurance around that and what that means for us, because presumably there's still ongoing long-term trends that we'll need to be able to pick up, and I'm just curious as to how we're intending to do that, if the way in which the data now needs to be reported is different from what we've known previously, because it's really important that we look back and look forward. So, Anthony, without going into lots of depth, can you just give us an inkling as to how we're going to make sure that we can continue to track this appropriately? Because it does look alarming, some of this data on the face of it. and so that we can all understand we're not changing the goalposts, we're having to report in a different way, but actually we're keeping a grip on this as an individual organisation.
Thank you, Chair. Yes, as part of our Safer Care team developments, we've appointed a deputy for safety and security, and he will be overseeing all of our incident data. And one of the objectives for him will be to provide that kind of disaggregated report. So he will be producing a report that will be pulling out all of the individual themes and issues from our DATIX reports. So you'll see a much more comprehensive report moving forward that will be able to sort of show that trend data, okay, and importantly what we're doing about the incidents as well.
Okay, good. And when will that be by?
He starts on Monday.
All right. Okay, we'll give him by Wednesday then.
By Wednesday, yes. So, I'll bring an update through to the next board meeting on the progress around that.
Yeah, I think that would be really helpful, because obviously we have to demonstrate in public that we're giving the assurance, and if the data's moving around a bit because of things outside of, you know, our control in a sense, it just does make it a little bit more difficult, I guess. Okay, great. Any other questions from colleagues? No, thank you very much indeed, Anthony, for explaining that. Let's note that report, shall we? Let's go on to the Action Plan for Intensive and Assertive Community Mental Health Support. Andy.
Thanks, Chair. I'm conscious that I'll try and be succinct, but there's a lot of information in here, so I'll
let me ask you this.
through.
Let me just ask you this question: if it's too much to ask, because this is such an important area and it links into many of the other conversations we've had today, if we can't do it justice now, is it time limited? Or do we need to deal with it today?
We do need to do it today, and I think we'll be okay for time. Okay,
all right, good.
Okay, so the Intensive Assertive Community Programme, I'm sure many colleagues will remember, comes off the back of the tragic events, Valdo, Colacane, and sadly stabbing 3 members of the public in Nottingham. I guess in terms of background for this presentation, back in last year, the part of the 24-25 NHS priorities and operation planning guidance required that all integrated care boards needed to review community mental health services by September 2024, with a focus ensuring the robust policy and practices are in place for individuals with serious mental illness and who require an intensive community treatment and follow-up. As a reminder, we, in collaboration with the ICBs, undertook that review last year and developed a project plan to address the identified gaps and barriers, and this was reported to the ICB boards only back in late 2024. And since then, we've had 3 key developments that have shaped the direction of the programme moving forward. So the first of those was the independent homicide review into the treatment of Valdo, and that's published back in February of this year. We've had the updated NHSE guidance issued of April this year, which is, sets out clear expectations for how we should support this cohort. And we've also had the draft personalised care framework published in April of this year also, which outlines the minimum core care processes for people with serious mental illness. The reason I say we need to keep it on the agenda today is all mental health trusts and ICBs are required to update local action plans and report the progress at public boards by June of 2025. We've previously taken this to both SNE and Norfolk and Waveney public boards the week of the 19th of May, and it's been received well in both forums. In terms of the original programme objectives and priorities, there were 3 really core priorities to focus in on. That was around the cohort identification, so making sure we could determine who within the services met the criteria for the intensive and assertive support. There's a whole checklist of symptoms to look for, so we're looking for people who are presenting with psychosis, but not necessarily given a diagnosis of such. They might not respond to, might not want to, or may struggle to access and use routine support, vulnerable to relapse and deterioration, have multiple social needs, such as housing, self-neglect and finances, likely to present with co-occurring problems, so we talked about earlier today about substance misuse and codependencies, may have had negative traumatic experiences of mental health services or other services such as criminal justice, and they may have concerns raised by families or carers. So the first priority was to identify the cohort that met with that. Then we had to do some review of internal policies that affect the care and treatment of this cohort. And thirdly, make sure that we're developing a way of working collaboratively in this space. So we set up a steering group in November of last year, chaired by myself, included ICB, leadership, locality reps and clinical colleagues, and we meet fortnightly to monitor, develop and deliver the programme. In terms of progress today, which is important elements for us at the moment, is around cohort identification. It's been a huge task in terms of going out to all of our teams across all of Norfolk and Suffolk, so all of our community teams, with those those indicative ways of seeing who's in this cohort, and we managed to identify, we think, everyone within that space. What we've also done, though, is to pull together a clinical panel of experts, so clinicians who worked in assertive outreach teams previously within the Trust who are doing the validation of that cohort, and we're expected to conclude that imminently. We've also made sure that in terms of that cohort, we've where they've been clinically validated, we've identified whether that they have a current allocated care coordinator, and they have. And we've developed a clinical checklist describing the care required based on the guidance from the NHSE. And we shared that with teams to make sure that they're checking and auditing whether they're delivering the care that's required for that cohort. We're in the process of developing a dashboard that will then be used to audit our adherence to that checklist moving forward in a sustainable way. In terms of the policy review, the second of the three priorities, we've 8 key policies were identified for review. They've now been updated, they've been approved through the Trust governance structures. And we've also got a rolling schedule in place to make sure that the policies are current and service user and care involvement is embedded in that review process. So moving forwards in terms of the updated programme plan, the future plan is structured around 6 key areas which were identified both in the April guidance from NHSE and which also reflected the homicide review outputs. So the 6 areas are around the care and treatment, making sure that every individual should have a co-produced, personalised...
We've got them in front of us.
Oh, you've got them?
Yeah, they're on the
Thank
report.
Then in terms of... So we've got those 6 areas in which we're working towards delivering. In terms of challenges and risks for us, which is important to acknowledge, is around the service model expectation. So the detail is there, but effectively we're expected to cap caseloads at around 15, have daily contact for this cohort and work extended hours into the weekends and evenings. That's a huge additional ask of our current services, and there is no additional resource coming down. This is an issue for all mental health trusts across the country. We have provided some baseline idea of what resource would be needed, as has every other trust, but there's no additional resource being identified yet. There's a challenge around obviously the training requirements that we need to put in place to make sure that the staff working with this care cohort are upskilled to deliver that. So in terms of our next steps, it will be around finalising that cohort validation, sharing the information with social care colleagues and wider partners, because we're very conscious. So for examples like where somebody may go to prison for a period of time, there's a risk they may drop off the radar, for want of better words. So we're making sure that we're sharing the detail far and wide so that we make sure that as a system we try and wrap around this cohort of individuals. Of course, as I've said, we're making sure that they have the care plans that they need and the quality of care that they're delivering, and developing a workforce plan and assessing the impact. So I guess in conclusion, I guess where we are is we feel that we've done everything we need to do in terms of the plan moving forwards. We've got a huge challenge in terms of the resource and how we manage that additional ask. We're waiting for some further guidance around that and whether there will be resource coming down. But really the purpose of bringing it here is for that assurance that up to date we've got the plan as far as we are able to.
I'm going to play back to you what I'm hearing. So we now know how many people fall within the category of risk, perhaps equivalent to valdo-calocane in Norfolk and Suffolk. We know the treatment we ought to be providing. We're putting in place some measures, for example, a care co for every individual that we've identified. But there's a massive gap now in the expectation that NHS England has in terms of our response to those individuals and what we've either been commissioned or funded to do.
Correct.
Okay. So the big question is, how do we get that funding in order to be able to plug that huge gap? Can you give us an idea on quantum in terms of either money or more people that we need? And then let's work out in this board what we need to do to take this forwards. It's all very well as meeting the requirements of NHS England to report in June, but if we've got an identified gap of risk, we probably need to do a little bit more than that. So what's the quantum?
Yeah, so at the moment, because it's been rapidly moving in terms of understanding what the asks are. So we haven't been able to quantify in terms of exact numbers of staff, and I don't think any trust has at this point. What we've been waiting for really is the next update from NHSE in terms of what they think they're going to do. So in terms of what we need to do as a board, I think we need to wait for that to land, which is imminent. It's not in the far off in the future. It should be in the next couple of weeks. We're expecting it to come down from NHSE. So we need to probably wait to see what that says and then submit the plans based on what that comes back as.
Okay. Faisal?
Yes, thank you. Just to give you more information, the key here is the system discussions. So you're absolutely right. It's the learning from the tragic events that has led to, well, we need to work out what sort of assertive care do we provide these really vulnerable patients who are risky. So we've identified the patients, we've got a plan. That plan is being shared at system level. So in the roles that myself and Kath hold, we're having those discussions with system partners, and in terms of what is the gap and what do we need to do differently. So for example, this was discussed very recently in the Norfolk and Waveney ICB, and our Chief Executive Ed Garrett was there talking to these things. So these plans are feeding into those discussions, and it's very live at the moment.
Okay, thanks. Tricia?
So can I just clarify, we've identified the number of individuals who fall into this, yes? Do you have a number that you could share?
As I said, we're just waiting for the clinical validation process. So the number is likely to shrink down. We expect it to be in the region of 200 people across the trust. So it's not a huge, across the whole organisation, that's not a huge number. And that's what we would expect.
That sounds quite a lot to me if they need highly individual wraparound care.
Yeah, okay. Did you want to come in, Linz? Linz, I saw first and then David.
I did. I'm going to try and ask this question as delicately as I can, because we're talking about people and their lives. So 200 of our most at risk patients, we're talking around putting around the wraparound care, which I completely understand and I agree with. I think there's benefits, isn't there, which is, of course, in the way that we can help them to manage their own risk. I am assuming, and this is the delicate bit, that there are other benefits as well as a wider system in the preventative care that this would then provide. Are we able to see what that benefit is? And that could well be a pound amount, because if we're putting wraparound care, one would hope that the individuals don't then go on to do other things like in the Valdo case, or require other even more intensive support, such as like as an inpatient.
I think I do understand the question, but yeah, I think you're right, but I don't think we have like a pound that we could put around that. I think it's probably a question we'd have to go back or go away and come back with some thoughts on, but it would be difficult to quantify, I think, but I do understand the question and where you were going with it.
Okay, maybe we'll take that in the private board. David?
Yeah, just on probably the same kind of theme really, in terms of the resourcing required. Caseload of 15 people, wraparound care. Once we have done some more work in terms of clinical validation of numbers, you'll have clearly identify the resource and the resource gap. So there is a next step for us in terms of playing that into both seeking funds through ICB representation and all of that, which I hope sort of very loud and clear about the requirements of. But secondly, in terms of reviewing our risk register, because in terms of these kind of requirements now will pose a much greater set of risks on us as an organisation in terms of our responsibilities. And the final point really is, it is a system issue, and it's great to have better systems, governance and sharing of information. I'm as interested in systems management in terms of their own responsibilities for being part of a partnership, multidisciplinary approach. And I don't see anything in that here. So I just wonder if that kind of conversation can be played out in your further discussions, please. Because it's not all about the responsibilities on this trust. It's a system responsibility.
I think everyone understands that, David, and I think that's helpful. Andy, I know you do a lot of work system-wide, don't you, in order to engender that kind of response?
Absolutely, as assurance, absolutely. We are in. It might not be in there, but we're absolutely in conversation with local authorities around this. Yeah, so it is. Yeah, so there is the evidence, and we are trying to think about how you bring together a forum where across system we hold these individuals and have conversations around them.
Okay, look, can we thank Andy for bringing this to us? Could we note the content of the paper? But I think we probably need to go a little bit further than that based on the conversations that we've had. Can we ask you to come back with, when you've done all of the analysis work, to identify what the gap is between what we're able to provide now on the current resources and what we should be providing according to the guidance which we may get clarity on from NHS England, and a plan for how we're going to close that gap. Great, lovely. With those additions, can we note this report? Lovely. Thanks very much indeed. Thanks, Andy. We've now got a section on the agenda. Have we lived our values during this meeting, acted as a team, held each other to account, ensured we're learning and improving? Have we been kind? And have we brought this meeting in on time? Well, I can tell you the answer to the last one. No. Sorry about that, folks. But in terms of not detracting from the seriousness of this point, this is our opportunity to challenge ourselves within the space, the public space. Have we achieved what we wanted to achieve in the way that we've lived our values today?
I'll go first, as nobody else says. I think it's a really great process that we put in place now. We're building this into all of our meetings. So I think we have built on each other and been a good team. I think we've increased accountability. I think we could probably up it a bit more. I think we have really focused on learning and improvement. Again, I think there's more we can do around that. I think that's been a real theme. And I think there has been real kindness and respect across the whole board. So I thank you very much.
Anyone else want to come in? Jason. And then Anthony.
Yeah, I think the point on accountability, so yeah, as you said, Caroline, we have increased it, I think, compared to previous meetings, but I think there's still some way to go. And I think that's a common theme that we're seeing across a lot of our meetings when we're having this discussion, is we're still being, we have the trait of friendliness, don't we, in terms of across our organisation. And I think we're being too friendly at some points. I don't think we should be aggressive, but I think we need to challenge more.
Yeah, can I just come in? I would agree, but I think Zoe really focused much more today on, so when are we going to know it's improved? And I think with Stuart's work, we need to get stronger on trajectories for improvement. And you know, just think about the conversation we had about complaints. I don't think we landed that as well as we could have done, because you know, it's not, I don't know, you're often saying, you know, we have continual sores that we don't address, so we need to say to Kath, for example, right, we're on to trajectory, when you're going to bring that right down. So I do think there's more we can do to hold each other to account and put some tighter timescales around that, but I felt you really focused more on that today. Did I? Yeah, you did.
Anthony and then David.
I think in terms of how we conduct ourselves, I think we probably upheld our values in that regard. But I do think that the so what, I've been thinking about it myself, just going through my own papers today. There's something that I need to have a discussion with my team about in terms of the papers that I bring through. It's more substance in terms of the so what. I think that would help the conversation then at board.
One of the things that occurred to me, sorry, taking chair's privilege and interrupting David, who's next. When I was preparing for the meeting, and we do have to challenge, and we have to kind of demonstrate that we're challenging and providing that challenge in a public domain. I think it would be really helpful, and you may say to me, no, we don't do this in the NHS, if the reports weren't simply for noting, but there was actually a series of options for discussion and decision. And I think that of and in itself would cause, from the committee where we've decided to escalate, a reflection on the escalation from committee, a series of options, and then a discussion in the board, and it gives us something then to hold the conversation to, because at the moment some of these reports are vast and I'm looking at them and thinking, well, where do you begin with that one? But if there's been a sort of an interim step to say, right, we've taken this, these are the key things, and this is where we could go next, but we want board conversation, that might help us focus. But I don't know whether we do that anywhere else. I mean, let's not answer that now, but it's just a thought. David?
Yeah, I totally agree with that in terms of the added value of going through committees, and that then can help the board focus, really support that. I was going to say, actually, I think that if I sort of compare it over 12 months, the quality of challenge is better because the paperwork's better. But we're equally so, back to what we've just said, we're not complacent, we want to improve it further. So I think the challenge is getting there.
Yeah, Linz.
Just reflecting on the conversation now, I'm thinking in my role as chair of performance and finance, some of the discussions that we've had here today, we'd picked up in performance and finance, which I noted at the appropriate time. And I'm thinking actually in all of our chairs' reports, perhaps we need to be stronger in stating not only that we've had the discussion, but actually note the so what and what next as well, where we're assured and we're advising, actually say, well, this is what we agreed, this is when it would change by. So I think a tweak to what we're putting in our chairs' reports might help demonstrate some of that.
Yeah, I think that's really good, because I then flick back to the front page to think, it's been through quality group, performance and finance group, it's been through performance and finance committee. Can I, as a chair who was at neither of those, or the members of the public, actually see how things have moved and been kind of developed through each of those processes? I think that would be helpful as well. Tricia?
Not in that specific, but just in the general tenor of the meeting, when I reflect back on many board meetings, I think there's been an equal voice in this room. I think there's been, everybody's had the opportunity and taken that opportunity to speak up. And it would be very difficult looking in to see, if you're hovering over the top, who were NEDs and who were executives. We did have a time on our boards where only non-execs spoke. So I think there's been an equality of conversation today.
Yeah, and that's because we consciously work at that in our board development sessions, and we want to engender that whole unitary board feel and sense, and appreciating we've still got lots to do, and we've still got lots of sessions ahead of us. It's good to hear that people feel that there is improvement in that regard. Paul?
Yeah.
Apart from me telling you to hurry up in your first intervention.
Well, tell me again. Yeah.
Which I'm not, I promise. Take your time.
I mean, I just wanted to say, obviously it's my first board meeting, although I obviously observed the board on a number of occasions, but I felt very comfortable being able to challenge and ask questions. And sometimes when you enter into a very large group like this as a first time, you're sitting on the board, it's quite intimidating and challenging to do that. So in terms of the tenor and the welcoming, if you like, and the enablement and inclusion, it felt very easy for me to just step in and ask the questions that I've asked. So yeah, thank you.
Well, thank you, Paul. Good. I think that's important to have that reflection. We did it in the public domain as well. It's really important that we do that because we can only learn if we do that in that space as well. So let's take away all of those thoughts. I'm going to suggest we now hand over seamlessly to Julian. I'm not quite sure whether we have to reconvene as another committee. You were going to advise me now, aren't you, Rebecca? I can tell.
I think you've just got a script written of what we asked you to say, have you?
Have I?
If you haven't...
Have I, Jeff? Nobody understands that.
I can say it if you like.
Go on then.
Okay, thank you. So, Chair, if I may, on your behalf, formally close the board meeting in public and cease the live transmission, and ask the board to move into their role as corporate trustees of our trust charity, and hand to Julian to give a report of our first charity committee meeting.
Okay, including the public.
Which excludes the public. Thank you very much, Chief Executive.
Thanks very much.
Thank you so much. And thank you very much, Talia.